Okay, ready here? 9 and the other? Is it 9? Hey, why didn't you tell me? Good morning, all. Good morning, all. I'm Dr. Krishna Prabhakar. Welcome to day 2 of GERICON 2021. Without any further ado, we'll leap into the sessions. The first is the oral presentation, and it is chaired by Dr. Bijin sir. Dr. Bijin sir, are you there, sir?
Yes, sir. Yeah.
Yes, sir. Thank you very much. Thank you, sir. And I'm sure Dr. Prem Narasimhan Garu will join soon. Sir, with your permission, shall we go ahead with the session, sir? The speaker.
So he has joined. Dr. Prem has joined, actually.
Dr. Prem, sir, good morning, sir.
Good morning.
Good morning, sir. Sir, I think you can go ahead with starting the session, sir. The speakers are also ready. I hand over the session to you, sir.
Yeah. Can you obviously start all the timers for them?
Yes, sir. Timers. They are coming up, sir, right now as we speak. Sir, oral presentation, 8 minutes of presentation, 2 minutes of question and answers.
Okay. So I actually don't have the list, so you will have to just tell them to present one after the other.
Yes, sir. They would be doing it, sir. The first presentation is Dr. K. Soundarya. Are you there?
Yes, sir. I'm here. Can you hear me?
Yes. I'll hand over the chair to Dr. Bijin and Dr. Prem Narasimhan Garu. Thank you.
Sir, I'm not able to share the screen, sir. Hello?
Yes, Amma. Please check now.
Okay, sir. Thank you. Yes, sir. Sir, can you see me? Can you see the slide?
No, I cannot see this.
One second, sir. Now, can you see the slide, sir? Hello?
No, I don't think you have shared it yet. We can't see anything.
Sir, now you can see, sir. One second, sir. Sir, one second, sir. Hello?
Yes.
Hello? Can you see now, sir?
No, we can't see the slides. It's not shared at all.
It is.
Sir, like.
Not able to log in.
Sir, I'll coordinate with her, sir. Let's carry on with the next speaker. I'll coordinate with her.
Yeah, please. Can you also please
Yes, sir.
start the timers also, because
yes, sir. When they share, I'll start the timer, sir.
Okay, okay.
Sure.
Okay.
So who's next? Whoever is next, please come.
It's Kevin P.
Yeah.
Dr. Kevin.
Sir, yes, sir. Hello, sir. Sir, hello, sir.
Yeah. Can you please share your slides and start?
Da.
So can you see me now, sir?
Yeah, yeah. Please. Can we start the timer, please?
So good morning, sir. My study was about an association between thyroid function and EGFR in a patient with chronic kidney disease, a hospital-based cross-section study. Myself is Dr. Kavin. Myself, Dr. Kavin P. Government Villupuram Medical College, Tamil Nadu.
Just continue.
Chronic kidney disease is a highly prevalent condition in Indian population associated with wide range of adverse sequelae. Various endocrine disorders such as secondary hyperparathyroidism, insulin resistance have been recognized as extrarenal complications and it's a potential predictors of mortality and morbidity in this population. These endocrine deailments include functional abnormalities and in particular hypothyroidism have been documented in many cases. The overlapping features of CKD and hypothyroidism make it all more challenging for the clinician to timely diagnose and treat it. Therefore, the study was designed to estimate the association between EGFR and hypothyroidism among CKD patients. A cross-section study was performed in Government Villupuram Medical College on non-dialysis CKD patients in association with to determine the prevalence of hypothyroidism and its association with EGFR. Study was conducted after getting approved from Institutional Ethical Committee, assuming the prevalence of 17% according to existing literature. To 5% margin error of sample size was calculated to be 300. My sampling technique was consecutive sampling. Data were analyzed using Stata 14.0. The p-value of less than 0.05 was considered significant. To study the association between my aim of the study is to study the association between thyroid function and EGFR in CKD patients. My objectives are to study the thyroid function among CKD patients, to calculate the EGFR in CKD patients, study the association between thyroid function and EGFR in CKD patients. My inclusion criteria of all non-dialysis CKD patients aged more than 18 years who are willing to participate in the study have been included in this study. All subjects on drugs causing hypothyroidism on anti-thyroid drugs, specifically for hyperthyroidism, end-stage renal disease on renal replacement therapy, polycystic kidney disease, glomerulonephritis, rheumatological or autoimmune diseases, or pre-renal transplant were excluded. What hypothyroidism was defined by a TSH level of more than 5.5 and 3T for level of less than 0.89, the clinical symptom. So clinical hypothyroidism was defined by TSH level of more than 5.5 with 3T for level of more than 8.9, more than 0.89. And the CKD is defined as abnormalities of kidney structure and function for more than 3 months. The EGFR was calculated using CKD creatinine equation. The stages of CKD was defined according to critical guidelines. Among pre and non-dialysis CKD patients, 160 patients have normal TSH. 135 patients had raised TSH. That 69 patients had low T3 T4 level, and the 86 patients have normal 3 T4 level. These other variables are compared. there was no age and gender distribution variable.
This is two inches laptop.
For every 10 coexisting diabetes mellitus increase the incidence of hypothyroidism in CKD patients. Being diversifically higher overt and supplemental hypothyroidism cases, systolic BP also higher in overt and supplemental hypothyroidism cases. Dyslipidemia and hypercholesterolemia was significantly higher in overt hypothyroidism. Patients with hypothyroidism have significantly low serum albumin and low serum calcium than those with non-hypothyroidism. Microalbuminuria was significantly higher in hypothyroidism as compared to non-hypothyroidism. Mean level of hemoglobin was lower in overt hypothyroidism as compared to the subclinical and non-hypothyroidism. This slide shows prevalence of hypothyroidism increases while stages of CKD increase. This is odds ratio of say CKD patient getting hypothyroidism increases with 2.5 times in CKD stage 5, which is compared to in stage 3, it was 0.65. Out of 300 patients, 49 patients had over hypothyroidism and 89 patients had subclinical hypothyroidism. In CKD stage 4 and stage 5, 65.3% of over hypothyroidism and 59.3% of subclinical hypothyroidism cases. The thyroid function detected with Pauling GFR. For every 10 number Pauling GFR, serum pH level increases exponentially with ratio of 6.5 in CKD stage 2 to 2.5 in CKD stage 5. Most of the factors for hypothyroidism, CKD patient getting hypothyroidism, the pH level is often elevated in CKD in response to impaired secretion.
Divyayani, can you please mute yourself?
Metabolic acidosis and decreased clearance of inflammatory cytokines has also been labeled as one of the contributing factors. Low T3 syndrome is also commonly seen in CKD population, which is possibly an adaptation of the chronic inflammatory and malnourished state. Wolff cycle effect has been cited as causative phenomenon behind the rise of this disorder in diabetic kidneys. On the other hand, it has been hypothesized that hypothyroidism may lead to altered kidney function, decreased ventricular diastolic function and cardiac output, increased peripheral vascularization, which results in reduced renal blood flow, structural changes including decreased kidney to body weight ratio and altered glomerular architecture. Hypothyroidism is also associated with endothelial function and impaired microvascular function. These findings suggest that low thyroid function might lead to reduced GFR. A limitation of studies, this is a cross-sectional study that demonstrates the association between PSH and CKD, which does not provide information on causal relationship. Our study lacks details about possible etiology of hypothyroidism. As it is tested case under most of cases of CKD stage 4 and 5, hence hypothyroidism is overestimated. In conclusion, patient with moderate to severe CKD, there is an inverse association between eGFR and the risk of hypothyroidism. Clinicians must consider dangers of thyroid disease and provide appropriate treatment in conjugation to treating CKD. Further study is needed to delineate the mechanistic pathways linking hypothyroidism and CKD and determine the impact of exogenous thyroid hormones treatment on incident CKD and progressive. Thank you.
Thank you. Yeah, Dr. Bijan, you want to go first?
Just one question. Dr. Kabin, the study is good. Just one, you consider the age group more than 18 years, right? And your impression was it is no gender variability. So did you have a subgroup of patients like around 40 age group, mid-age, above 60, or all present the same? Even 80 to 60 is a big age group, right? So they're the same, some change, did you do a sub-study or something like that?
Which No, sir. Just calculated.
Okay, fine.
Okay, so what do you think? What do you think is the importance of CKD in older adults?
So as age progresses, every year 1 number fall in GFR will be present in older age.
Okay, which is the best formula to calculate EGFR?
And CKD epiform creatinine. This is studied.
Okay, and manually, quickly, which can be done?
Copper of God.
Copper of God. How do you calculate? Can you tell me the formula?
Is 140 minus age into body weight, ideal body weight divided by serum creatinine into 70. Serum creatinine milligram per deciliter into 72. If it is female, we can multiply by 0.8.
Multiply by 0.8. Okay, thank you. You have the next speaker.
Hello, can you hear me, sir?
Please share your slides and then the timer will be started.
Can you, sir?
Yes, please start your slide.
Hello. Yes, sir. I have started presenting. I have started sharing my screen. Can you see my slides, sir?
Yeah, please start.
Yes, sir. A very good morning to one and all. I'm Dr. Soundarya, second year postgraduate from Department of Geriatric Medicine at MMC. Today, I'm here to present my study titled Analysis of Factors Influencing Frailty in Elderly Patients.
Timer, please.
Frailty can be described as an accelerated aging. It is a clinical syndrome that involves multiple physiological symptoms characterized by decreased reserve and impaired response to stress. Frailty was influenced by multiple factors such as increasing age, cognitive decline, poor nutrition, and so on. Why it is essential to screen for frailty? Frailty screening at a community level will help in identifying at-risk individuals and help in promoting healthy aging. Sarcopenia. Sarcopenia is a syndrome of progressive loss of skeletal mass and strength. It has been considered a precursor syndrome or physical manifestation of frailty. Status and frailty with regard to multimorbidity, polypharmacy, functional status, and functional performance in elderly patients. The study was conducted at LT Clinic at Geriatric OPD at RGH. The study period was for 18 months. The study was a cross-sectional observational study. It was done in geriatric patients who attended frailty clinic. The sample size was 150. Those who were included in the study were patients aged 60 years and above, willing to participate in the study. And those patients with acute medical illness or those patients with physical disability and who were not willing to give consent were excluded from the study. The patients were selected according to the above mentioned inclusion and exclusion criteria. After obtaining consent, the study was conducted. The demographic data such as age, sex, educational status were collected. Along with that, patients' comorbidity history, medication history were collected. Price criteria was used to determine the frailty in all study participants. This formula was used to identify sarcopenia. Functional dependence is analyzed using SAS index, which is asking questionnaires about the performance of daily activities from the participants, where daily activities such as bathing, dressing, and toileting were asked how the patients were able to perform. A score of 6 indicates full function, and a score of 2 or less indicates severe functional impairment. And functional performance was examined using gait speed and timed up and go test, where gait speed less than 0.8 meter per second or timed up and go test, if the time used to perform timed up and go test is more than 10 to 13 seconds, it was considered to be poor functional performance. The data was compiled and the association between frailty and above mentioned factors, including sarcopenia, were statistically analyzed using SPSS version 21. P-value less than 0.05 was considered to be significant. The Frye's criteria is as shown below, where unintentional weight loss of more than 10 pounds in prior year or self-reported exertion by the patient, slow gait speed, where the gait speed is to cover a distance of 4 meters if the patient takes more than 6 seconds, or if the patient is slow by 20% by 6 or 8 is considered to be slow gait speed. Low grip strength, where it was adjusted according to the sex and BMI. For male, it was less than 30 kg, female less than 20 kg. And for low activity, the patient's reported low activity history was considered. A score of 3 or more than 3 was considered to be frail, and a score of 2 was considered to be pre-frail, and a score of 0 or none was considered to be non-frail. Sarcopenia was calculated using this formula, where men and women have separate separate cutoff points. The cutoff points for defining sarcopenia for men was 105, and for women it was more than 120. These are the demographic characteristics. In this old study population, 41% fell under 60 to 69 years age group, and 40 in the 70 to 79 years group, and 17.3% in the age group of above 80 years. Among them, as shown in this chart, you can see as age increases, the percentage of frailty increases, and the frailty prevalence is very more in the age group more than 80 years when compared to the 60 to 69 group and 70 to 79 group. And also pre-frailty prevalence increased with increasing age. And with regards 57% of frail elderly were female, and 43% of frail were male. When comparing the factors, sarcopenia, physical performance, and functional dependence, these were my figures. 79% of frail individuals had sarcopenia. There was significant statistical association between frailty and presence of sarcopenia, less than 0.05. And those individuals with poor functional performance also had significant association between frailty and functional performance. 63% of frail individuals have functional dependence. There was a significant association between functional dependence and frailty. Here I've shown the schematic presentation of the percentage of how many people with the frail individual at sarcopenia 78, and poor functional performance 66% of frail individuals had poor functional performance, and 63% of frail individuals had functional dependence. With regard to polypharmacy and multimorbidity, although the patients, many patients with history of multimorbidity had frailty, there was no significant statistical association between frailty and multimorbidity. In polypharmacy, 51% of frail individuals had history of polypharmacy, but there was no significant statistical association between frailty and polypharmacy. To conclude, in a study, the prevalence of frailty increased with increasing age. Frailty was very more in very old elderly, as mentioned in several studies conducted before. Female were more frail than male, similar to previous studies conducted in southern India and Italy. Although frailty was more common in people with multimorbidity and history of polypharmacy, there was no significant association between them and frailty in our study. Among all factors, the presence of sarcopenia was the most influencing factor of frailty. Patients with poor functional performance had increased prevalence of frailty and was significantly associated. Frail patients were more functionally dependent when compared to the non-frail patients. These are my references. Thank you.
Okay, thanks for adhering to the time. Dr. Bijan, you can start.
Good presentation, Dr. Soundarya. So regarding the
Thank you, sir.
multimorbidity, so what are the common comorbidities you encountered causing this frailty in your patients? Out of 115 patients you studied, yeah.
Yes, sir. Diabetes and hypertension were more prevalent in our study group, sir.
So you meant about that polypharmacy. So patients were mostly only on the drugs for diabetes and hypertension, am I right? Or any other drugs, any other comorbid illness?
Yeah, some few people also had CAD, CVA, and other comorbidities, but most people had diabetes and hypertension. The study participants included in a study had history of diabetes and hypertension, and they were using only 3 or 4 drugs. So we were not considering those patients to have polypharmacy history.
So were the patients on statins or anything? Use of statins? Because they're very old patients, you're telling. Most common,
Yeah.
very old is around 70 to 80 group. So were they
Yes.
use of statins or anything?
Statins uses were there. If the patients are having statin, when the patients were, even with the statins usage, it didn't come above 5, so usage of more than 5 drugs. So polypharmacy was not significantly associated in our study.
Okay, yeah.
Yes.
Okay, Manimoy, a very good presentation, actually, very crisp. I would want to ask you why you use Pride's criteria and not Rockwood.
Because it was actually the study was conducted in aim to screen the patients for frailty. So Frights was more easy for me to screen the patients at a OPD basis. So.
Okay, but you what would be the, if you have to plan a further study on these patients, what would you want to do? Which biochemical marker would you want to see so that you can actually can contribute to frailty as well?
I would actually consider sir, again, sir.
Which biochemical marker would you want to see to monitor these patients for frailty? Okay.
CRP and other biochemical markers can be used because frailty itself is it's a pro-inflammatory state, but those things cannot be done in a screening process. TNF alpha, another interval to screen. But
okay, thank you.
Thank you.
Yeah, can we move ahead?
Dr. Prem, the presenter is Soundarya, not Manimuri, on frailty.
Yes, ma'am. The first one is Soundarya, second one is Kavan, as per the list. Yeah.
Is my slide visible, sir? Hello, good morning.
Yes, it is visible. You can start.
Good morning, everyone. My study is on impact of multimorbidity on functional status in older adults attending geriatric outpatient department. Introduction. The prevalence of chronic non-communicable disease among elderly is around 58%, and the prevalence of multimorbidity around 23% in India. Multimorbidity is associated with increased disability, depression, higher rates of adverse drug events, reduced life expectancy, and economic burden. Functional limitations increases with age and are more common in women. They are associated with low quality of life, hospitalization, as well as increased healthcare utilization. My aims and objectives are to determine the relationship between multimorbidity and functional status, and to determine the relationship between multimorbidity and gait speed. Methodology. This is a cross-sectional observational study done in outpatients department in Regional Geriatric Center, Madras Medical College. Duration of the study was 1 month with a sample size of 150. Inclusion criteria were those patients with 2 or more chronic medical conditions, and the exclusion criteria were patients with single chronic condition and acute illness. The functional status of the patients was assessed by using modified Barthal activities of daily index with a total score of 20 and Lawton instrumental activities of daily living scale with a score of 8. Patients were grouped as functionally dependent in aerial activities, whether partial or total, and functionally independent in aerial activities. Physical performance was assessed by using gait speed. For gait speed, the individuals were instructed to walk at their pace along an 8-meter track. The first 2 and last 2 meters were not included, since these correspond to periods of acceleration and deceleration of gait. Therefore, the time spent on completing the central 4 meters was measured. The time taken was used to calculate the gait speed. If it is more than or equal to 1 meter per second, the mobility is intact. Between 0.6 to 1 meter per second, there is high risk of functional dependence. If it is less than 0.6 meter per second, they already have aerial difficulties. Functional status and gait speed were compared between patients with multimorbidity, with 2, 3, and 4 diseases, and the confounding effects, age and sex were statistically analyzed. Since this is a cross-sectional study with a small sample size, it had identified association but did not allow cause-effect relationship between multimorbidity and functional status. Longitudinal study and large sample size are needed to establish the association between multimorbidity and functional status. The impact of individual disease and disease pattern on functional status were not observed in this study. Coming to results, in the study of 150 older patients with multimorbidity, 48% were in the age group between 60 to 69, 35% between 70 to 79, and 17% in the age group more than 80. 57% of my study participants were male. Patients having 3 diseases were more in the study, constituting about 43%, followed by 2 diseases with 35%, and those with 4 diseases with 22%. In our study, males have greater number of multimorbid. Nearly 60% of the patients were functionally dependent partially in at least one aerial activity. As age group increased from 60 to 69 to 70 to 79, the percentage of patients with number of disease was also increased, but not in patients above 80. This was probably due to small number of patients in that age group, and there was no statistically significant association between age and number of multimorbid disease. Multimorbidity and functional status. In patients with 2 diseases, 47 patients were independent and 25% were partially dependent. In patients with 3 diseases, 36 were independent and 48% were partially dependent. And those with 4 diseases, 16% were independent and 25% were partially dependent. As the multimorbidity increased from 2 and above, more patients become partially dependent in function. In patients with 2 multimorbid disease, the mean modified Barthal area score was 19.3, and those with 3 disease, it was 18.9, and those with 4 disease, it was 18.5. The mean modified Barthal area score decreased significantly as the multimorbid disease increased. In patients with 2 disease, the Lawton IADL score was 5.7. In those with 3 disease, it was 5.3, and those with 4 disease, it was 4.7. In gait speed, in patients with 2 disease, the gait speed was 0.64 meter per second. In those with 3 disease, it was 0.58 meter per second, and those with 4 disease, it was 0.54 meter per second. Gait speed decreased significantly as the number of multimorbid disease increased. Discussion. In a study in Ireland on multimorbidity and health outcomes, those with 3 or more chronic conditions had an extremely high risk of disability and poor quality of life. Multimorbidity was associated with poorer physical function in a cross-sectional study done in UK. In a study on well-functioning older adults, slower gait speed was observed in older adults with multimorbidity. Conclusion. In our study, As the number of multimorbid disease increased from 2 and above, more patients become partially dependent in function. There was a statistically significant decrease in mean modified Parhal area score and gait speed as the number of multimorbid disease increased. These patients should be identified and targeted for interventions to improve health outcomes. Individualized assessment and care plan is needed in the management of multimorbidity, which improves quality of life by reducing treatment burden and adverse outcomes. These are my references. Thank you.
Yeah, Vijay, go ahead.
Yeah. Just one confirmation, Dr. Divya. Good study,
yes, sir.
actually.
Thank you, sir.
Your study include 100 patients or 150 patients?
150 patients, sir.
Because you mentioned 60 to 69 years is 48, and 70 to 79 is 35, and 8 to 10 is 17. Am I right? So,
sir,
your study when mentioned just confirmation. 60 to 69, you had
yes,
mentioned
sir.
48 patients, and 70 to 79, you mentioned 35 patients.
48%, sir, not patients, sir. 48%.
Okay, fine. So, as you told that above 80 years, it is 17, right? 17%. Am I right? Plus, above
sir, I couldn't hear you, sir. Hello?
Above 80 years is actually 17% less, right? In multiple,
yes, sir, 17%. 17%.
Okay. So out of that, you're telling about multimorbidity. So, like as you mentioned, you have excluded that one chronic condition and acute illness, but you included 2, 3, 4. Am I right? So out of
yes,
that
sir,
2, 3, 4 multimorbid, so what were the common comorbidities you encountered? For example, it's a diabetes, hypertension, COPD.
Sir, can you repeat the question, sir? Sorry, sir.
Nothing, no problem. See, you had mentioned the exclusion and inclusion criteria. You had mentioned
yes,
about that you are excluded the patients with one chronic condition and an acute illness, whereas I included patients
yes,
with
sir.
more than 2. Am I right? So as the in your study inference,
yes,
it revealed that according to 2 comorbids, 3 comorbids, or 4 comorbids, the dependency increased. The independent. Am I right? So what were the commonest commonest comorbid conditions you encountered? So did the patients, for example, those
neurological conditions, sir?
Like for example,
sir, neurological conditions, sir. CVA.
Okay. Oh, so patient present with CVA. Okay. So I meant not that diabetes,
yes, sir, CVA.
hypertension.
Those patients were diabetes, hypertension were common, sir, but compared to functional dependency, those CVA patients were more functionally dependent, sir. Chronic arthritis, like
okay, so
the hypertension, diabetes is more common, sir, but dependency, neurological conditions, sir.
So you're not able to perform the gait speed for that patients, am I right? The arthritis patients and the severe patients, right?
Yes, sir.
Okay, sure.
Okay, Divyani, what is the normal gait speed?
So more than 0.0 meter per second, sir.
How do you do gait speed?
Sir, gait speed, the patients are instructed to walk at their pace along 8-meter tracks, sir. The first and last 2 meters were not included, sir, because it denotes the periods of acceleration and deceleration. The time spent on central 4 meters was measured, sir.
Okay, and what is the is tug more better, or is gait speed more better, or both are different?
Sir, gait speed is better, sir.
Why?
Sir, because we are excluding the acceleration and deceleration of the gaits.
Okay. Thank you.
Thank you, sir.
Next, please.
Is my slide visible, sir?
It's visible.
Yes.
Please start.
Yes, I'm just starting. Good morning, everyone. I'm Dr. Ruben Gerald Felix, postgraduate student in the Department of Geriatrics, Christian Medical College, Vellore. I will be presenting my study on is hand grip strength, a useful tool to detect slow walking speed in older adults, a cross-sectional study on community dwelling geriatric outpatients. So the aging population is increasing worldwide, and frailty is becoming a global issue among older adults due to its increasing prevalence and adverse health outcomes. Hand grip strength and walking speed are two important criteria in the definition of frailty. The feasibility of performing a walk test, particularly in older adults with decreased cognition and physical abilities, has always been a concern. Although hand grip strength has been proposed as a method to identify slow walking speed in literature, there have been very few studies done, especially in community dwelling older adult population. The Asian Working Group for Sarcopenia updated the diagnostic cutoff value of slow walking speed from 0.8 meter per second to less than 1 meter per second. Hence, there is a need to examine the association between hand grip strength and walking speed in older Asian population based on this new cutoff. So my primary objective of the study was to study the hand grip strength, how it correlates with the walking speed, especially in Asian community dwelling older adults. And the secondary objective was to determine the optimal cutoff values of hand grip strength in detecting slow walking speed according to the recent criteria by Asian Working Group of Sarcopenia. And as per Asian Working Group of Sarcopenia, low muscle strength was defined as a hand grip strength less than 28 kgs in men and less than 18 kg in women. And low walking speed was defined as a 6-meter walk test showing less than 1 meter per second. So my study was a cross-sectional observational study with a sample size of 100, and it was conducted in Geriatrics Department OPD in CMC Vellore after getting approval from ethical committee. And the population were people aged more than 60 years. The outcomes measured were hand grip strength and walking speed. And the time period of the study was from September 2020 to October 2021. Inclusion criteria: patient more than or equal to 60 years attending the geriatric outpatient clinic, willing to participate in the study, and who are able to perform the hand grip strength test and 6-meter walking test, and patients who had peripheral vascular diseases, specific muscle and nervous system disorders, recent MI, patients with COPD, stroke, liver disease, and kidney diseases, and patients who are actively receiving treatment for cancer or severe infection were excluded. The demographic and clinical methods were collected and entered into a research proforma. The hand grip strength were measured using a handheld digital dynamometer, and the walking speed was assessed using a 6-meter walk test. Epidata were used for data entry. So the data were summarized as mean or median for continuous variables, and the categorical variables were reported as number and percentages. Karl Pearson coefficient was used to determine the relationship between walking speed and grip strength. Chi-square test was used to test for the association of slow walking speed with other related variables. Logistic regression was used to test the association between walking speed and grip strength after adjusting for other confounding factors. And receiving operating characteristics were used to determine the optimal cutoff for hand grip strength for predicting a slow walking speed. So as I said, the total participants in the study were 100, and majority of the population were less than 70 years. There are 67 of the participants was less than 70 years, and 63 of the 100 participants were male sex. So this table shows the 6-meter walking speed based on different characteristics of socio-demographic and lifestyle. So in this table, it is seen that the body mass index and the smoking status had significant association with slow walking speed with a significant p-value. And other important characteristics like age, in age, patients who were more than 70 years old, although were walking slower, it was not statistically significant. Similarly, in the sex, although the female population was walking slower compared to the male population, it was not statistically significant. And other characteristics like socioeconomic status, physical activity, and alcohol status did not have any significant associations. In terms of comorbidities, patients in diabetes, the non-diabetic patients were walking slower compared to the diabetic patients with a significant p-value. And also the mini nutritional assessment scale, participants who had a score less than 12, almost 84% of the population were walking slow, which was showing a significant statistical association. And the Pearson coefficient correlation between 6-meter walking speed and other variables showed that variables like age, weight, body mass index, hand grip strength, and appendicular lean mass was having significant correlation, except age, which had a negative correlation. All other factors had a positive correlation with a significant p-value. So this is a scatter plot showing the correlation between hand grip strength and walking speed. So when the walking speed was plotted in y-axis against the hand grip strength on the x-axis, it was noted that there was a linear association. And also, as the hand grip strength increased, the walking speed also increased, showing a positive correlation. So in the univariate logistic regression table, it was shown that it was seen that the body mass index, the diabetes, patients with ALM mass and mini nutritional assessment score and a grip strength was found to have significant association with a p-value of less than 0.001. However, in multivariate logistic regression table, it was found that only the grip strength and a mini nutritional assessment score of less than 12 was found to have a significant p-value. So based on this, the reacting operating characteristic curve was analyzed to find an optimal cutoff of hand grip strength in predicting a normal walking speed. So it was done separately for both men and women. And in case of male, the area under the curve was 0.92. And in case of female, the area under the curve of 0.95. And for men, it was found that a hand grip strength cutoff of 28 with an accuracy of 90% was predicting a normal walking speed, whereas in women, a hand grip strength of 20 with an accuracy of 94% was predicting a slow walking speed. And both of the hand grip strength had a p-value of less than 0.001. So the prevalence of slow walking speed varies across different studies, mainly because of the definition used and the differing study designs. In a study conducted by N. Ho Lin et al. In Taiwan, the prevalence of slow walking speed, as per the recent Asian Working Group cutoff, was noted to be 56.5%. The results were consistent with our study's prevalence of 53%, although the Taiwan population had a higher mean age than our study population. Multiple studies, although have shown that older people, female sex, and people with sedentary life had a slow walking speed, our study, although had a similar trend, did not show a statistically significant difference. So a cross-sectional study by Maikon Liu et al. Compared the accuracy of different cutoff points of hand grip strength for assessing slow walking speed, and even proposed a cutoff of 32 kg for men and 21 kg for women. However, the study population did not include Asians, and the cutoff used for slow walking speed was less than 0.8. Compared with the study in Taiwan population, as I said before, by N. Hyun et al., which showed a hand grip strength cutoff of 35 kg for men and 17.93 for women, our study showed a hand grip strength cutoff of 28 kg for men and 20 kg for women. So the limitations of the study were smaller sample size. We used a digital dynamometer instead of a jammer dynamometer, which is a standard one, because of its easy accessibility and our population was mainly community dwelling population. So these findings cannot be taken up for an institutionalized older adults. So further studies are required in these populations. So concluding, our study shows that hand grip strength assessment was used as a surrogate marker indicating for detecting slow walking speed. Hence, large population studies are warranted to examine the same. These are my references. Thank you. I would like to sincerely thank GERICON for selecting my paper for presentation. And I would also like to thank my professor, Dr. Gopinath sir, for guiding and helping me throughout the presentation. Thank you.
Okay. Very good presentation, Dr. Ruben.
Thank you, sir.
Just one question. So you were mentioning about that regarding that gait speed, that non-diabetics were walking slowly compared to the diabetics. That's what you told. So
yes,
what
sir.
are the causes for that? Any other contributing to that? That's my first question. Yeah, please. Yeah.
Yes, in the diabetics, when we actually went through it, the HbA1c levels were pretty almost controlled in both the diabetic and non-diabetic group, and there was not much of difference, and there was not evidence for any peripheral neuropathy or anything also. So the population is also similar in both these two groups actually. So yes, and we thought probably diabetic people would have gotten extra little bit cautious of their diet and exercise as motivated by the doctors, which could have influenced it. And in the non-diabetic arm, that regular advice from a practitioner would have not been there, and maybe that would have influenced it, sir.
So probably the glycemic control was obtained for diabetic.
Yes, even the diabetics were all having a good glycemic control.
Okay, sure. Thank you.
Okay, you said further studies you would want to do. What further study would you want to do?
Sir, especially the hand grip strength and gait speed hasn't been done in Asian population. And this would be one of the first studies to represent Asian population. But this was a sample size of only 100. Especially there was some clarification needed in terms of diabetics and also in peoples with sedentary lifestyle. And these two parameters are two important things which can actually affect a walking speed. So these characteristics could be further analyzed.
Okay.
For its accuracy, sir. Yeah.
Thank you. Next, please.
Thank you, sir.
Am I audible, sir? Good morning to all. I am Dr. Manimuri, second year postgraduate. I am going to talk about an interesting of reversible cognitive disease in elderly. Introduction. Genetic disorder presenting for the first time in geriatric age group is uncommon. However, in certain circumstances, this has to be considered as a differential diagnosis in presentation like multiple electrolyte abnormalities in a patient presenting for the first time after the age of 60 years. We had a 64-year-old man who presented to our outpatient department in a wheelchair with a history of acute onset non-progressive weakness involving all four limbs for past 4 days, with no history of loss of consciousness, no history suggestive of cranial nerve and sensory system involvement, no history of trauma. This is the first episode presenting area body study. Patient was conscious, oriented, afebrile, and vital stable with BP of 110/80 mmHg, with no clinical signs of respiratory distress. Examination of central nervous system showed normal higher mental function with cranial nerve examination was normal. Patient had motor system examination. Patient of power of hypotonia. Patient had hypotonia with the power of 2/5 of all four limbs with the absent deep tendon reflex. Plantar showed bilateral flexor response. Sensory system examination, sensation were intact. Cerebellar function could not be accessed. Extrapyramidal signs were absent. Other system examination was clinically normal. Investigation taken at the time justice was suspected PCD. We treated the patient with IV potassium followed by oral potassium supplement. Patient was symptomatically improved. Potassium level of around 2.5 normal range for persistent level. We subsequently checked for magnesium. Initially, magnesium was normal range, but again,
I think we lost her.
I'm audible, sir.
Hi, audible. You can continue. Yeah.
Suspected hypomagnesemia. So immediately we also treated with the IV magnesium and oral magnesium.
You'll have to share your screen. We can't see.
Sir, visible, sir?
No.
Visible, sir?
Yeah, it's vertical and your voice is still breaking.
Visible, sir. Screen is.
Yeah. Now it's visible. Continue.
Patient potassium was persistent low range, that is below normal range with a low magnesium level. We immediately start treating along with the IV magnesium and oral magnesium supplement and started on tablet aldactone, and the patient potassium becomes normal. And interestingly, on day 3, while checking BP during rounds, patient showed signs of hypocalcemia, that is torsion sign. In this video, there is a carpal spasm is explained and pedal spasm also explained. And subsequently, after taking investigation, we treated the patient with the IV calcium and oral calcium supplementation. Serum calcium range was come for a low level with a range of 6.3 milligram per deciliter. With immediately we taken parathormone, showed a normal value. TFT also we checked to rule out hyperthyroidoxic periodic paralysis, but TFT also normal. For low calcium level, we checked for urinary calcium and also compared with the creatine ratio, it showed hypocalciuria, that the below normal range of 0.15. And we checked for potassium loss, we checked for urine potassium and creatine ratio, it showed above normal range, that is 4.24 milliequivalents. It indicates renal loss. Other investigation done was USG abdomen tour. It showed normal with no evidence of renal failure. MRI brain with whole spine screening was done for quadriparesis. It showed no cervical cord or any other lesions. Now conduction study was done to rule out demyelinating disorders such as Guillain-Barré syndrome. It's come to a normal study. To rule out a rheumatological connective tissue disorder induced renal tubular acidosis with hypokalemic changes, we have done the rheumatological investigation. It's also come to a negative. With that, patient had quadriparesis, low potassium level, low calcium level, low magnesium and low phosphate. We have evaluated patient had hypokalemia with urine potassium creatine ratio of more than 2.5. That is above normal. We are going to suspect a renal loss of potassium. Again, we come to patient BP. It was normal with a pH of mild alkalotic range. We go for a urine chloride ratio, urine chloride that is more than 20. With we go for again suspecting hypocalciuria, that is urine calcium creat ratio with below normal range. It's come to a DD of thiazide diuretic or Gitelman syndrome. In this patient, patient had quadriparesis, hypokalemia with hypomagnesemia, metabolic alkalosis with a normal BP with hypocalciuria. We suspected a patient for a Gitelman syndrome. And the patient was treated, and the patient was previously no diuretic usage. We have come to a conclusion, Gitelman syndrome. Patient was treated, discharged with oral potassium and magnesium supplementation. Patient is on now follow-up with no recurrence till now. Let's see about what is Gitelman syndrome. Gitelman syndrome is a autosomal recessive disorder with mutation in thiazide sensitive sodium chloride co-transporter in distal convoluted renal tubule. It usually present in late childhood and adulthood with presentation like musculoskeletal or chondrocalcinosis symptoms with the usual biochemical abnormalities for hypokalemia, hypomagnesemia, and metabolic alkalosis with the increased renin-aldosterone ratio. Patient had a hypocalciuria, that is urine calcium creatine ratio of less than 0.20 with no renal stone. Treatment like potassium and magnesium replacement was given along with the potassium sparing diuretics. Patient maybe had chondrocalcinosis due to hypomagnesemia, calcium pyrophosphate deposition in joints. Gitelman syndrome, and now our patient, what are the symptoms had us? Patient usually elderly onset. We have never done the genetic analysis, so we have named this syndrome as a Gitelman phenotype. The patient had an elderly onset presentation with hypokalemic paralysis and carpopedal spasm, hypokalemia, hypomagnesemia, and metabolic alkalosis with hypocalciuria. We suspected Gitelman phenotype. So usually Gitelman syndrome, normal calcium level, serum calcium level with hypocalciuria. But interestingly, our patient had hypocalcemia with hypocalciuria with no renal stone. Patient was treated with the potassium and magnesium supplement and potassium sparing diuretics. Okay, let's come to the close DD of Gitelman syndrome is Bartter syndrome type 3. In Bartter syndrome, usually it's present as early childhood with hypercalciuria, same metabolic abnormalities with hypercalciuria with renal stone. In our patient, it is present in elderly onset with hypocalcemia, with hypocalciuria with no renal stone evidence. So we that concluded, we came to a conclusion. Patient had a quadriparesis, multiple electrolyte abnormalities like low serum potassium, calcium, magnesium, and phosphate along with the metabolic alkalosis with hypocalciuria. We come to a conclusion with Gitelman phenotype with hypocalcemia, that is hereditary renal channelopathy. Patient is on follow-up with no recurrence till now. These are my reference. I would like to say thanks to my patient, Mr. Gondandam, and my sincere thanks to Dr. D. Thangam Madam and Dr. Professor G.S. Shanti Madam and other professors at the Department of Geriatric Medicine and Madras Medical College, Chennai. Thank you.
Very good case, Dr. Manimuri, about gentleman phenotype. Something new, yeah. Just two questions. Did the patient have a history of fever?
Sir, no history of fever, sir.
No history of fever, only the weakness, right? Acute onset of
Yes,
weakness.
sir.
How the patient presented in wheelchair, right? Okay. And one
Yes,
more question.
sir.
You were telling about gentleman and Barters. So how do you differentiate from gentleman from Liddle syndrome?
Liddle syndrome also, it's present at a early onset with a high BP level with a normal renin and aldosterone ratio. In Gentleman syndrome, due to hypovolemia, due to sodium and chloride loss, patient have increased renin and aldosterone ratio.
So
And it also treated with
so renin was not done.
BP, sir. BP and
BP, yeah, good, okay.
Sir?
Good, yeah.
BP, sir.
Okay, thank you.
Thank you, sir.
Are you planning to do the genetic testing?
It was advised to the patient, but patient is not up, so we can discharge it, sir. Discharge it. Until now, the patient is on follow-up, sir, with no recurrence.
Okay, fine. Yeah, thank you.
Okay, sir. Thank you, sir.
Dr. Bijan, I think we are done with the case, right?
Yeah, I think the 5 candidates.
Yeah. Okay, so thank you, everybody.
Thank you all.
Thank you, Dr. Bijan. Thank you.
Thank you, sir. Thank you.
Dr. Gandaya and Dr. Shanti Madam. Dr. Shanti Madam will read about the Natarajan sir oration.
Yes, sir. Yes.
And introduction of the Vivek Agarwal, Gandaya sir will be doing. So over to you, Shanti Madam and Gandaya sir.
Yeah, it's my privilege to chair this Dr. V.S. Natarajan oration. A few words about the oration, how it started. Professor Dr. V.S. Natarajan, Padma Shri awardee. He was born in 19th June 1939, graduated in medicine from University of Madras from undergraduation in 1965 and post-graduation in 1968. He pursued his training in geriatric medicine at Southampton, UK in 1973 and received the fellowship of Royal College of Physicians, Edinburgh in 1987. Started his career in 1974 at Government General Hospital, Chennai, and he established the geriatric medicine department at Madras Medical College with geriatric OPD in 1978, the first of its kind in India, and later expanded to inpatient services in 1988. He also was instrumental in bringing the first MD geriatrics postgraduate course in India, and this was started in 1996. And this was the fruit of untiring efforts of Professor V.S. Natarajan when nobody were aware of this specialty of geriatrics at all. He has a number of credits to his achievement. He has received the prestigious Padma Shri Award, also a recipient of B.C. Roy Award in 1994. He was awarded the gold medal by British Society of Geriatrics on the occasion of their 50th anniversary, and also received the Best Social Worker Award from Government of Tamil Nadu in 2007. And also he has the Lifetime Achievement Award conferred on him from Indian Academy of Geriatrics in 2009, Ministry of Social Justice and Empowerment in 2010, and from the Tamil Nadu Dr. MGR Medical University in 2012. Recently, on October 1st, 2021, he was awarded the Vayoshreshta Samman Award by the Government of India. for his excellent services in establishment and or continuing social geriatric services. He has authored a number of books on geriatric healthcare for the general public also in both in Tamil and English. His contribution to social geriatrics is also worth mentioning. After his retirement, he was a chairman of Senior Citizens Bureau, and later he himself started Dr. V.S. Natarajan Geriatric Foundation, which is doing a very human services to the welfare of the elderly. He has also started the Memory Clinic and the first adult immunization clinic, that is the Senior Citizens Immunization Clinic, which is first of its kind in India. He launched the House Call program in 2008, a comprehensive geriatric care program for the needy, sick, bedridden elderly. He serves as a member of National Council of Aging and Older Persons, NCOP, a Government of India agency operating under Ministry of Social Justice and Empowerment. So as a mark of recognition of his untiring efforts and services to the elderly, and as a honor to this great personality who is considered as father of geriatric medicine in India, Professor Dr. V.S. Natarajan Oration was started in the year 2004. May his contributions to geriatric care continue in the years to come, and he is still doing a very able and efficient services to the geriatric population and to the specialty of geriatrics. With these few words, I hand over the mic to the chairperson Gandaya to introduce the speaker.
Madam, good morning, Shanti Madam.
Good morning, sir.
At the outset, I thank the organizers and the organizing committee of GERICON 2021 for giving me the opportunity to chair the session. Thanks to Dr. Y.S. Raju Garu and also my friend Dr. Chandrasekhar Garu and also Krishna Prabhakar Garu for giving me this opportunity. It's my honor and privilege to introduce Dr. Vivek Agarwal. He graduated in 1991 from Pune University, postgraduate from Pune University again in 2007. He completed his DNB in 1998. He completed his postgraduate training in geriatric medicine in 2012 from CMC Vellore. He's a diploma in healthcare management, Lucknow University. He presently is professor of geriatrics at AMC Pune. Total publications for his credit are 34, and he owns a gold medal in ophthalmology in UG in 1997, Brig IP Balla Award for best thesis in MD General Medicine in 2007. He got second prize in platform presentation in geriatrics in 2012, first prize in platform presentation in 2019. Is a double helical National Academy in Geriatric Care in 2020. He is a life member of APA and IAG, and is presently the Joint Secretary of IAG. Thank you. Thank you. Now I will go over to speaker, Dr. Vivek Agarwal.
Sir, Vivek Agarwal, sir. Yeah. Please share your screen and start off with.
Yes, I'm audible.
Yes, sir. You're audible, sir. Can you make it the slide mode, sir? Yes, sir. Now it is perfect.
Yeah, good morning to everyone. I first of all, I would like to thank GERICON 2021 organizing committee for giving me this opportunity to speak on this topic. Falls in elderly, assessment and prevention. Falls in elderly is a very common, serious, and ignored geriatric giant. It is a common problem. Almost 1/3 of elderly more than 65 years of age have a fall in a year, and after 80 years of age, every year they have a fall. Fall is a very disabling and distressing condition, both for the patient as well as family. Sometimes fall can be fatal. Around 20% of falls can have fatality due to head injury or fracture of femur. It affects independent functioning and active participation. And most important, falls are preventable, and we should try and do whatever we can do to prevent falls in elderly patients. If you see this, incidence of falls increase with age, as per data from Western countries, after 65 years of age, 1 in 3 people fall each year. After 72 years, every elderly has fall in 2 years, and after 80 years, there's a fall every year in elderly patients. Coming to Indian data, we don't have a statistics of Indian population of how much fall is there, but this is a study from Rohtak which shows that the incidence of fracture neck femur increases with increasing age. So this is we can see that this may be due to increased falls with increasing age in elderly population, and this is more common in women. This is a study which we done at which we did at FMC. We had 2 cohorts. One, we had a cohort of urban slum in West Maharashtra, and we did and we had a cohort at Kumbh Festival 2019, and we did fall risk assessment in all the elderly patients, and we can clearly see as the age increases, the fall risk increases in elderly patients in these 2 cohorts. We also saw in our study that the fall risk was much more common in women as compared to men. Fall has a great impact both economically as well as to the individual. In US, every 20 minutes there is a death due to a fall. The approximate cost is around $50 billion every year due to falls in US. Even after surgery, if you do surgery at an early stage after a fall or after a hip fracture, the mortality remains 3 to 4 times than the normal population. Coming to India, the average cost of treating hip fracture is around 1.5 to 2.5 lakhs, especially in a private practice, in a private setup, and mortality after fracture is 20 to 58%. Coming to once there's a fall, there will be a fear of falling, which will cause movements will be restricted, will decrease mental well-being, social isolation, and there will be a vicious cycle which causes declining health, disability, and this cycle will continue and fall risk will keep on increasing. Falls can be due to both intrinsic factors as well as extrinsic factors. Extrinsic factors are very important as we can prevent falls if we identify these extrinsic factors. Causes of falls in elderly are multifactorial. Any acute illness like infections or UTI or pneumonias, stroke, metabolic disturbance like hyponatremia, hypoglycemia, then syncope, seizures, then any gait abnormalities, visual impairment, arthritis, they can cause falls. Environmental hazards like clutter, slippery floor, and poor lighting can also cause falls. I think, can we mute somebody's mic is unmute? Yeah, thank you. Fall is usually multifactorial, and multiple factors play a role to cause falls. So whenever a patient comes with falls, we have to see all the factors which can cause falls in elderly patient. So it is multifactorial, and you have to address all the causes which causes increase in falls. These are the preventable factors for falls. They can be cardiac, environmental cause, medications, metabolic causes, musculoskeletal, neurological, psychological, sensory impairment, and acute illnesses. Now, fall risk assessment can be done either in community settings, or we can do it in OPD, or we can do it in inpatients, which can be acute, chronic, or rehabilitation. How do you assess falls? The falls assessment can be done by fall risk screening, which is done by patient self-reporting or a screening questionnaire, or we can also use a stopping elderly accidents, deaths, and injury at a steady toolkit by citizen. And then we do a detailed fall risk assessment by detailed fall history, identification of factors, which can be medications, vision, hypertension, and fall focused physical examinations. Patient self-reporting can be patient reporting with acute fall, patient coming with history of fall in last 1 year or having fear of fall, history of poor or impaired balance, postal giddiness or sudden standing, or there's something called a CBSE, community-based assessment checklist, which is now a part of a toolkit which is used by ASHA worker to assess falls in community as a part of Ayushman Bharat, in which there's a one question of asking about a fall risk in elderly patients. This is a steady screening questionnaire which tells you how much is the risk of falls, and these are some questions. Have you fallen in past 1 year? I used to have been advised, or this is a question which was, and if the score is more than 4, then you call, then this screen is positive for increased risk of falls. Coming to the fall risk history, when you see a patient of falls, we should see location of fall, indoor or outdoor, time of the day, when did fall happen, was he suddenly standing or suddenly turning in bed, pattern of fall, falling backward, falling forward, falling sideways, and symptoms before the fall, any palpitations, any syncope, any weakness, any use of assistive devices which may be either inappropriate or not properly used, medication dosing schedules, ability to rise after fall, and history of minor injury or major injury of fall. The history is very important in fall. I have to take a detailed history of the fall to know the exact cause for the fall, because fall is usually a multifactorial, and we have to find the exact cause which has actually caused the fall. In medical history, you can history of Parkinson's, CVA, TIA, epilepsy, arrhythmias, hypertension, dementia, eye diseases, osteoarthritis, rheumatoid arthritis, dizziness, or neuropathy. Then any drug use, substance or drug abuse like alcohol, sedatives, hypnotics, neuroleptics, antidepressants. So all this history has to be taken. Antihypertensives, NSAIDs, polypharmacy, and then look for any postural hypertension, muscle functions, joint functions, vestibular system, vision, proprioception, cognition, alertness, and balance and gait. These are the different medication related to falls, which basically tell the odds ratio which medicine can cause, how much falls with particular medicine. Now, how do you do a fall focused physical examination? The commonest test which we do is a timed up and go test. Second test is 30 seconds chair rise test, and then we can also do a TRD fall risk series. Other tests which we can use is Berg balance scale, downturn fall risk index, Hendricks 2 fall risk model, St. Thomas risk system tool, and Trinity balance scale. Coming to the tug test, that is timed up and go test. It is based on time to rise from a chair, walk, turn, walk back, and sit down. If this time taken is more than 14 seconds, we call it as there is an increased risk of fall. Community dwelling, it can be used in community dwelling, chronic care, clinic, but not suitable for acute settings. So basically, the patient sits on a chair or on a stool. Chair should be with a backrest, preferably without armrest. He stands, walks for 3 meters, turns around, and then comes back and sit back again on the chair. And the time taken to do this test is called as a tug time. So this can tell you how much is the fall risk. Normally, the tug time should be less than 10 seconds, but more than 14 seconds is supposed to be increased risk of falls, especially if a patient has got a hip fracture and is operated, and that tug time more than 20 seconds, then also is increased risk of fall after surgery. So this is actually a automated device which we have used in both Kumbh Festival and as well as in urban slum in West Maharashtra, which can measure the fall risk by doing a tug test. It's called as a Kinesis Q-tug device, in which there are 2 sensors placed on the ankles of the patient, and there's a tablet which is connected to this sensors, and patient asked to stand from a chair, walk 3 meters, turn back, and then sit down. And this calculates everything: time taken to stand, time taken to walk, time taken to turn, steps taken to turn, time taken to come back, time taken to sit back. And all these parameters are taken, and then automatically it can calculate the fall risk of the patient as low fall risk, moderate, high, or very high. And this can be used to identify elderly which have got a very, very high fall risk, and we can do the interventions in these patients. Like somebody is getting difficulty in getting up from chair. So we know that there's a difficulty in proximal muscle weakness. Somebody is taking more steps to turn. Then we know that there is a difficulty in balance. So we can identify the particular part. Somebody is sitting very fast. That means he's unstable. So we can see which part of the has to be taken care and which what is the main cause of the fall. So this is a normative tuck time, but this is for elderly European countries, and it is shown that if it is more than 14 seconds, then it has a high fall risk. For Indian data, we don't have any data on fall risk. I'll call you back. बाद में करता हूँ बात. If post hip fracture patient, if has more than time taken more than 24 seconds, then it is predicted to fall within 6 months. So we have done a tuck time using this machine in the two cohorts, and we found that tuck time in the urban slum population was 18.1 seconds in Indian population, and tuck time in Kumbh Festival cohort was 14.4 seconds. So probably tuck time in Indian population is much more than tuck time of the European population, and we have to make a nomograms of the tuck time for Indian population so that we can have a fall risk assessment in Indian population also. Other test is 30 minutes chair rise test, in which patients sits on a chair and gets up as many times as he can in 30 seconds. Normally it is 12 times he can get up. Less than 12 times, then it is the high risk of falls. This is a study to take. So first we do a stay independent brochure, which we have already seen. If the score is more than 4, then we do this complete assessment of steady to fall risk assessment tool, and we can make out low risk, moderate risk, or high risk in this. And prevention of fall is very important. Prevention can be by doing some exercises which are balance and strengthening exercises. Commonly used are Otago and Tai Chi exercises. In India, we can also use yoga exercises. Then reduce hazards at home, correct vision, correct post-lap hypertension, reduced polypharmacy, proper podiatry, identify and treat medical conditions, and use of appropriate devices. It's important that walking alone does not prevent fall risk. Coming to the exercise program, so Otago is the most studied exercise to prevent the fall risk. It can be a home-based or chair-based exercises in which can be done in elderly population, and this can be done at home. You don't have to come out of this population of this. And various studies have shown that Otago exercises have helped in prevention of falls or decreasing fall risk in elderly population. Other is Tai Chi exercises. The Tai Chi exercises also is it also helps in decreasing the fall risk, and there are different studies which have shown there's a decrease in falls after doing a Tai Chi exercises, and this decreases with increase in training volume with Tai Chi. In India, we can do yoga. So there is we don't have any data on yoga as but there's some exercises. There's a study done which shows that some Tai Chi exercises can be which are the yoga exercises which can be part of Tai Chi exercise also. So we can use some yoga exercise also, and can you do it in fall prevention, and this is a matter of research. I could only find 2 papers which which showed that yoga can be used in prevention of falls in elderly, and more studies are required to be done in this. Then home modification is very important to prevent falls. And treating of reversible factors like visual acuity, discouraging use of bifocal glasses while walking, and visual rehabilitation is important. Then treating of hypotension, arthritis, endocrine disorders, vertigo will also help in prevention of falls. Using of appropriate devices is very, very important to prevent falls, because we have seen with inappropriate devices which are increasing the risk of falls in elderly population. In this regard, we have made an algorithm at FMC in which it is a tab-based algorithm, and automatically we can prescribe a appropriate device to the elderly patient, whether it is standard cane or a quadruped cane or a wheelchair or a walker, this can come automatically in a form algorithm with a tablet. And a pilot has been done in this studies. Management of fracture of femur is very important. It's a medical emergency, it should be treated within 2 to 3 hours and should be managed by a proper orthogenetic team. A study done from Gujarat by Dr. Deepak Jain showed that if a proper orthogenetic team manages or there is a proper program is there, then definitely the mortality can be reduced in fracture neck femur patients. A fall is an important disabling multifactorial genetic syndrome with tremendous economic and social impact. Screening for fall risk is very important to identify vulnerable elderly. Prompt and timely management of fracture neck femur is important. Fall can be prevented by exercise programs for muscle strength and balance, appropriate communications, and identify and addressing reversible factors which can cause falls. So thank you very much. The aim of should be that we should be fit at 40, strong at 60, and independent at 80. Thank you very much. Any questions I would like to answer? Thank you.
Thank you, Dr. Vivek, for your detailed and very elaborate presentation on the fall assessment and the importance of significance of falls and also the ways in which we can prevent falls. Thank you so much. This is an oration, so generally questions are not encouraged. Any chairperson can give his remarks.
Thank you, madam. Thank you for nice presentation. Thank you, sir. Thank you for your detailed presentation and very lucid presentation.
Thank you, sir.
Prabhakar Nadin video no this is.
It's over.
Okay.
Over, sir.
Over. Okay.
Next step. Okay. So we are moving on to next oration. That is Trivandrum oration. So by Dr. Priya Vijay Kumar. So for which I invite Dr. D. Tirupati Rao, eminent physician from Karimnagar, and Dr. Thangam Madam from Madras Medical College. So Thangam Madam will explain about the Trivandrum oration, and Tirupati Rao will read out the biodata of Dr. Priya Vijay Kumar. Over to you, chairpersons, for the Trivandrum oration.
Good morning, one and all. I welcome you all to this Trivandrum oration. I'll just give you a few background information about this oration. This oration is part of the GERICON, the annual conference of Indian Academy of Geriatrics from the year of 2006. In the previous year, 2005, GERICON was hosted by Trivandrum Medical College under the guidance of Professor Dallas. And there it was committed to conduct Trivandrum oration every year in the conference from then onwards. Since then, this oration is rendered every year by distinguished medical fraternities who are interested in the field of geriatrics. They stimulate and enrich the knowledge of the listeners, including the budding geriatricians. This year too, Trivandrum oration is going to be delivered by one such personality in the field of geriatrics, Professor Priya Vijay Kumar, a teacher, astute physician, and an able administrator from Amrita Institute of Medicine, Cochin. I request my co-chairperson to introduce the speaker. Thank you all.
Very good morning to all of you. Good morning to today's speaker, Dr. Priya Vijay Kumar, and also good morning to my co-chairperson, Dr. Thangam. It's a honor and privilege to introduce such a eminent speaker. So Dr. Priya Vijay Kumar, after completing post-graduation in general medicine from Kasturba Medical College in 1999, joined Amrita Institute of Medical Sciences, Kochi. geriatrics as an independent department was started in Amrita in year 2000. She shifted to geriatrics department the same year. She took a formal training in geriatrics from the University of Michigan and Wisconsin, USA. She also acquired a diploma degree in geriatrics from Indira Gandhi National Open University. She also has completed a certificate course in palliative medicine. She currently works as a professor in the geriatrics department in Amrita Institute of Medical Sciences, Kochi, involved both in clinical work and postgraduate teaching. She has received an award as a distinguished woman in health sciences in 2019. With this introduction, it's over to Dr. Priya Vijayakumar for a topic on management of neurodegenerative disorders. Thank you.
A very good morning to all of you. In the outside, thank Dr. Raju and Dr. Shanti and other members of the scientific committee for giving me this opportunity today. I've selected the topic management of degenerative neurological disorders of elderly for this talk, for today's talk. Degenerative neurological disorders is an emerging problem. It's a critical health problem worldwide as population age. And the practicing geriatricians all agree with me that the incidence of these degenerative neurological disorders is increasing steadily now. But unfortunately, we cannot offer much to our patient or to the family or the caregivers. Clinical studies are going on continuously in this field, and we can hope that we'll be able to help them more effectively in the coming future. Right now, it's tender love and care what we can offer to our patients. So in the degenerative neurological diseases, these are the clinical conditions which come under. That is Alzheimer's disease, cognitive impairment and dementia in Parkinson's disease, dementia with Lewy body disease, multisystem atrophy, progressive supranuclear palsy, and frontotemporal dementia. And dementia is a leading medical condition in degenerative neurological disorders. And in the dementia, Alzheimer's top the list. And we know the etiology and pathogenesis is still uncertain. And earliest clinical manifestation is selective memory impairment, though we can elevate the symptoms associated with Alzheimer's disease, but the disease goes on progressing for the patient. And the timely referral of the Alzheimer's patient to a specialist depend on the knowledge and the comfort of the primary care physicians who provides the care and the availability of specialty clinics nearby. The two major groups of medications what is available for treatment of Alzheimer's disease now are the cholinesterase inhibitors and NMDA receptor antagonists. So both these groups, they are quite safe, tolerated by elderly, but then when and how we should give these groups depends on the severity of dementia. And assessment of severity of dementia is done by MMSE or MOCA or the clinical dementia rating scores. And we prefer to use cholinesterase inhibitors, that is donepezil, galantamine, or rivastigmine for mild to moderate dementia. Up to 6-month trial we'll be giving, and cholinesterase inhibitors mostly tolerated except for few GI side effects and anorexia and weight loss. And rivastigmine, so galantamine and donepezil can be given in the oral form, either single or twice daily doses. But the advantage with the rivastigmine is that it's available in the patch form. So in a highly demented Alzheimer's patient, we'll be able to administer drug in the patch form, so that's an advantage. Then in severe dementia, we prefer to use Mementin, and again well tolerated except for dizziness, and in the long-term use, it can cause hallucinations. And both even Mementin, like acetylcholinesterase, we'll be giving it for about 6 months, and then after that, we'll look at the response of the patient, and then after consultation with the family and caregivers, we'll take a decision whether to continue the treatment or not. In advanced dementia, decision on the long-term use depends on the patient's functional response to the treatment, and the long-term goals of care should be decided after consulting with the caregivers and the family. Now, the follow-up and monitoring with cholinesterase inhibitors. There is no lab test required. It's just clinical interview and use of screening cognitive tests. Again, the tests used are MMSE, Montreal Cognitive Assessment, that is MOCA scale, and then we'll be assessing the clinical response. Other treatment options available, omega-3 fatty acids and antioxidants found to have some effect in mild to moderate in delaying the progression of dementia. Still in varying results. Vascular risk factor modification, lowering the prevalence of hypertension by 25% could reduce the incidence of Alzheimer's disease by nearly 1 lakh cases. So there are various clinical trials which was done by American Heart Association and American Stroke Association by using various types of antihypertensives. And finally, they concluded that diuretics and calcium channel blockers were able to bring statistically significant reduction in dementia risk when compared to ACE or ARB. Statin, there is no benefit. Now, mild cognitive impairment. This is an intermediate state between normal cognition and dementia. Older adults with minimal cognitive impairment, there is increased risk of progression to dementia. And in various studies showed that 14 to 56% of minimal cognitive impairment improve over years if a treatable cause of dementia is diagnosed. And treatable causes like vitamin B12 deficiency, hyperthyroidism, depression, etc. Annual rates of conversion of MCI to dementia is about 5 to 16%. Screening and treating of vascular risk factors, especially hypertension, has a role in improving minimal cognitive impairment. Less evidence for the efficacy of antiplatelet therapy, statin therapy, smoking cessation, or diabetic management in the treatment or prevention of dementia, but these can bring out an overall health benefits. This is a newer agent, aducanumab. That's a recombinant monoclonal antibody recently approved by FDA in the treatment of mild Alzheimer's disease and minimal cognitive impairment. And this drug is directed against amyloid beta. Contraindications, it's Lewy body disease, vascular dementia, AD in the setting of Down syndrome, who have high risk of hemorrhagic side effects, who are on antiplatelets and coagulant therapy. But many trials shows that aspirin, the persons who are on aspirin 81 milligram, they are safe to take this drug. And it's usually given, starting doses 1 milligram per kg as IV, and then monthly dosages gradually stepped up with periodic MRI screening, and no clear guidance regarding the duration of treatment, may be stopped once amyloid in PET-CT is negative. But the disadvantage is that it's very expensive. The other options, transdermal nicotine, intranasal insulin, and growth hormone releasing hormones has been studied in very few trials, but not yet recommended. And we often see prescription like of an Alzheimer's disease patient as including piracetam and ginkgo biloba. Both are very expensive compounds and absolutely not recommended in treatment of Alzheimer's disease. Aerobic exercises improved global cognitive ability. Then cognitive interventions have been shown to improve the function in healthy older adults. Now, along with the dementia or along with the Alzheimer's disease patient, we should always monitor them for the neuropsychiatric symptoms. So these behavioral symptoms peak by afternoon and late evening. This is a sundowning phenomena. And sleep disorders, it could be associated with Alzheimer's disease, or it could be a manifestation of neuropsychiatric symptoms. So sleep history is always very important when you're dealing with an Alzheimer's patient. Delusions, about 30% they have paranoid delusions. That is, they feel that their house has been stolen, their articles has been misplaced, and they feel that their spouse has been unfaithful, etc. Visual hallucinations, about 7% of Alzheimer's disease has. And when a demented patient becomes aggressive or agitated, always look for the underlying causes like delirium, medication side effect, if there is pain for the patient, or the patient is depressed, or there is sleep disorders or sensory deficits. Please correct this. You may be able to control your patient to some extent. And in the treatment of agitation, address the underlying cause. Cholinesterase inhibitors have no role in Alzheimer's disease, though found a role in dementia with Lewy body. Nimantine is to be studied in Alzheimer's disease. That is when the patient becomes agitated. Psychosocial interventions, following a psychosocial interventions, what we can apply. And then use antipsychotics like quetiapine or olanzapine. Antidepressant medications, SSRIs, SNRIs, and atypical antidepressants can be tried. Anti-epileptics, uncertain benefit, and drugs to avoid is benzodiazepine. Severe psychosis, atypical neuroleptics like olanzapine and quetiapine. Then a new compound like the serotonin receptor modulator, pimavanserin, is used recently. Now, the second medical condition which I would like to discuss is the cognitive impairment and dementia in Parkinson's disease. So, dementia is a common feature of Parkinson's disease. Prevalence is about 30 to 40% in a person with Parkinson's disease. Memory impairment is less prominent early on, while executive function, dysfunction, and visual spatial impairment are the features. So for the motor symptoms of Parkinsonism, you have to treat it with a levodopa or other anti-Parkinsonism medications. So coming to the management of non-motor symptoms. So if the Parkinson's patient develops symptoms of psychosis, always see for the triggers. So the anti-Parkinson's medication itself could be a trigger factor for the psychosis, like dopamine agonists, or see whether the patient is in delirium. If the patient is suffering from any infection, is there any new medication added to their list, or is it the worsening dementia? So assessment of the underlying cause, treat the cause, psychosis resolves. Then you can monitor the patient. If the psychosis persists, then determine the severity of psychosis and now look into their drug list. If the patient is an anxiolytic, sedative, antidepressant, please take those drugs off. Till the patient is not showing any response, then consider your anti-Parkinson's medication. You have to reduce or taper off and stop the medications in the following order. Initial, you have to stop that anticholinergics, followed by amantadine, dopamine agonists, MAO-B inhibitors, COMT inhibitors, and last, the levodopa. Sleep disorders, about 50 to 80% of Parkinson's patients have sleep disorders, that is excessive daytime sleepiness. So for this, optimize the nocturnal sleep, make them as active as possible in the daytime. And drug options, modafinil is supposed to be, has some benefit, but methylphenidate and sodium oxybate doesn't show much of a benefit. And if the Parkinson patient becomes fatigued, is it related to depression, daytime sleepiness, or conditions like hypothyroidism? Look into this and then address the problem. Autonomic dysfunction, constipation is the most common symptom. Manage it conservatively, or lubiprostone is another agent which can be tried. In sialorrhea, botulinum toxin injection to the salivary gland and glycopyrrolate 1 milligram 3 times a day can be given. Rhinorrhea, no effective treatment. Sexual dysfunction in men with erectile dysfunction, sildenafil is used. Orthostatic hypertension. Again, the disease itself, this Parkinsonism itself can cause orthostatic hypertension. The drugs, that is like levodopa, dopamine agonists, MAO inhibitors, all can cause orthostatic hypertension. So again, you'll have to taper or you have to discontinue depending on your patient's response. Now, the third medical condition is the dementia with Lewy body. No disease-modifying treatment is available right now. Again, dementia with Lewy body, they have associated Parkinsonism. So the patient could have symptoms of neuropsychiatric symptoms and autonomic disturbances. So depending on your patient's presentation, you will have to address the patient. Cholinesterase inhibitors, beneficial, again 6-month trial, not yet proved completely. Memantine, there is very limited use. If the patient develops psychosis, then go for Quetiapine is a preferred one. And for anxiety and depression, you have to use SSRI or SNRI. But the problem is if you use SSRI or SNRI, it can precipitate sleep disorders. So to manage sleep disorders, again, melatonin is the only safest agent. But at times, you may have to give clonazepam, even though benzodiazepine is contraindicated in this condition. And for Parkinson's symptom, levodopa is the preferred agent. Electroconvulsive therapy for the management of depression, very limited studies are available. If the patient has urinary frequency, mirabegron is given orally as 25 milligram tablet. And benzodiazepine, haloperidol, tricyclic antidepressants to be avoided in this condition as far as possible, but then may not be possible every time. This is a group, multisystem atrophy. It is rare but progressive and fatal. Again, there will be a collaboration of symptoms like autonomic disturbances, features related to cerebellar degeneration and corticospinal degeneration. Again, management is just symptomatic. Motor symptoms, again, trial of levodopa in very high dose. So when you're using this dose, again, the side effects of levodopa is definitely to happen. Maximum, they've shown that it's a 3-month trial. Dopamine agonist, there is no role. Physiotherapy, yes, of course, that botulinum toxin injection is given for focal dystonia. Eventually, the patient may require a PEG insertion. Autonomic symptoms, orthostatic hypertension. Again, try the non-pharmacological interventions and pharmacological therapy with midodrine. Postprandial hypotension. Again, general measures like the quality of the food, the quantity of the food, the timing of the meals, etc. can be addressed with octreotide injection 30 minutes before each meal given subcutaneously. In urogenital symptoms, developing with multiple system atrophy, with the detrusor hyperreflexia, torturodine can be given, bladder atony, intermittent bladder catheterization, erectile dysfunction, it's again sildenafil. Depression, again SSRI or SNRI. If the person goes for stridor, we may have to go up to tracheostomy in some patients. Rapid eye movement sleep behavior disorder, again melatonin is the safest agent to be tried, but times we may have to use clonazepam. Progressive supranuclear palsy, another medical condition under degenerative neurological disorder. So this is the Parkinsonian syndrome, characterized by vertical gaze palsy, postural instability, and frequent falls. No specific drug. It's a multidisciplinary approach, which with the help of a speech therapy, assessment of swallow periodically, early occupational therapy, mirror prism lens help to patients with severe limitation of extraocular movements. Then botulinum toxin therapy for blepharospasms, physical therapy, gait training, balance training, walking aids. Again, because they have for maintaining their balance. Pharmacological treatment, levodopa carbidopa therapy, even though it's a Parkinson's syndrome, this helps to distinguish only idiopathic Parkinsonism. So there is no prescription required for this for Parkinson's, for progressive supranuclear palsy with levodopa, because absolutely no effect. And solpidem, improved motor function, but just in 2 to 10%. Electroconvulsive therapy, mixed results. And these are the few investigational therapies which are going on in the field of progressive supranuclear palsy with neuroprotective agent, monoclonal antibody coenzyme Q10. Frontotemporal dementia. So this is degeneration of both frontal lobe and the temporal lobe. Very, very distressing as far as caregivers are concerned, because there is a personality disorder, there is a personality change, there is changes in the behavior, and the disease and the disease progresses to a global dementia. So it's only symptomatic management as far as patient is concerned. Addressing the caregiver stress is the most important in case of frontotemporal dementia. And in the behavioral changes, you can try with citalopram. Quetiapine can be used if the patient is agitated. And frontotemporal dementia has to be differentiated from Alzheimer's disease, because memantine, it causes no change in neuropsychiatric symptoms, but showed more frequent cognitive adverse effects if given with FTD. So this is important. MAO inhibitors pass evidence, and moclobemide and salicylic, again, just trials. Benzodiazepine is avoided. So these are the experimental drugs which are going on in frontotemporal dementia. So from all these slides, it's clear that we cannot offer much other than the supportive treatment to our patients. So there is a society in India that is Alzheimer's related disorder society, that is known as Society of India, that is ARDSI. But they have branches in just 24 cities across India. So we know the magnitude of our population and the service which is available to our society. And but anyway, wherever the service is available, please recommend to your patients and the caregivers. And the vision of the society is to create a dementia-friendly society. And these are the various activities. They conduct state chapters, research, policy advocacy, training. And these are the services provided by RDSI. So among all these services, what I feel the most important is the daycare facility. Because like children going to the daycare, we can send our patients to the daycare. So at least in the morning, in the daytime, when they are in the daycare, the caregivers can have some rest, will have some time to do their own activities. Because otherwise, 24 hours, 365 days, they are bound with our patient. And these are some pictures of ARDSI, because it's very active in my place in Kochi. And I have few patients who is attending their daycare centers. So summarizing, the medical conditions which cause degenerative neurological disorders are progressive. No definite cure till date. You can control or alleviate the symptoms. And addressing the caregiver is very important in this field. And we know our patients are old. They may be having multiple comorbidities. They may be having multiple medications. So advanced directives is very crucial in patients who are suffering from these disorders. So this is a video from Malayalam movie.
ഇല്ല അമ്മക്ക് കുടിക്കാൻ എന്തെങ്കിലും വേണ്ടേ?
This was from the Malayalam movie Bridge. So the son leaves the mother, and that's what we have seen. Thank you.
Thank you very much, madam. Wonderful talk, exhaustive, but it is in a simple way with full of clarity. You have enlightened us. As you know, the neurological disorders are increasing. Unfortunately, it happens in elderly patients. And at present, as you told, there is not much we can offer to them, except supportive treatment and as well as nursing care, particularly from family. Unfortunately, in India, taking care of our elders is a less priority than our children. So good family support and early diagnosis is very, very important. And spending with family and spending with old friends definitely will play a role in improving the dementia conditions. So intensive research is going on. I'm sure within near future, we will be able to find out some newer treatments and we'll be able to give proper treatment. Thank you very much.
Thank you, madam.
The diagnosis of neurodegenerative disorders are easier when compared to the challenging and demanding part of the management. Madam has elaborated the holistic management of the neurodegenerative disorders with reference to the elderly. Thank you very much, madam. It was a very good lecture. Thank you. Followed by that video. And recently, the government of Tamil Nadu has also initiated a program for taking care of this elderly diagnosed with the neurodegenerative processes, and including the daycare program and engaging them in the daycare centers, along with engaging and counseling the caregivers, like in your state. I hope all over India this will be followed. Thank you very much.
Thank you, ma'am.
Thank you,
madam.
It was a wonderful talk. I would like to congratulate Dr. Priya Vijaykumar for her elusive and very heart-touching video. It was a final touch that was very good. and all the points are practical, really cherishing the practical issues and way to find a solution is also very important. Thank you so much. Thank you.
Thank you, ma'am.
So thank you, madam. Excellent. Because this is oration, there is no question and answer. But in the chat box, Dr. S.S. Chakravarti has mentioned excellent points raised by madam. Great presentation, Priya. Dr. Prasad Matthews. Heart-touching video from Dr. Shanti. Sureka madam saying superb. G. Usha madam says good video. So all are appreciating your oration, madam. Thank you very much for presenting such a wonderful talk.
Okay.
With this, we are concluding this oration, and we are moving on to
Good morning, all. Go back to our sessions. We are going to the session 9. I would like to invite Dr. Vijay Mohan Garu to introduce the speaker and take over the sessions. Thank you, sir.
Thank you, Krishna. Are also aware of these. Even the common people are aware of these terminology these days, especially during the last 1.5 years, thanks to the pandemic. So, what is this immunomodulation? What is this? What does it happen? What does it do in the aging? Immune system is nothing but a homeostasis, natural homeostasis. We have natural immunostimulants, immunosuppressants, but how to modulate them? Immunosuppressants, immunostimulants. So, it's a very important topic. Dr. Sadhana Sharma, Professor Sadhana Sharma is here to talk on this very important topic of immunomodulation in aging. Over to you, Dr. Sadhana.
Good morning, sir. Before I begin, I would like to thank the organizing committee for giving me this opportunity. I would also like to thank Dr. Y.S.N. Raju, sir, and Dr. Magesh for letting me be speaker on this esteemed platform. Now, this is one of the news which is coming up, and why I picked up this is, as sir already mentioned, COVID has suddenly brought us into a scenario where immunity has become the major player. So in the next 20 minutes, we will be pondering over with a few basics which all of you are acquainted with, but we'll just refresh regarding what is immunosenescence and what is immunomodulation got to do with this immunosenescence. Why do we need this immunomodulation in elderly? How can we achieve it? And what do we have in future for us? So as Roy Walford, he coined the term immunosenescence, which meant that age-related involvement of immune system, which leads to progressive reduction in ability to trigger effective antibody and cellular responses against infections and vaccinations. So this is what we are concerned about now, that we are not being able to get an effective response against vaccinations and infections in elderly, and that increases the burden. Aging affects both the innate and the acquired immunity, but we see that in adults, in elderly, it is the acquired immunity which is affected much more than the innate immunity, and we see that the T cells are dramatically destroyed. So there are multiple factors, right from genes to nutrition to exercise. One very important thing is sex. So we see that in females, that estrogen is a immunostimulant, while progesterone and androgens, they are immunosuppressives. Now, we don't have much of menopausal postmenopausal data as to substantiate it. We also have seen that there is immunosenescence which is progressing earlier in males as against females. We really don't have much idea about it as well. Then regarding the therapeutic interventions and their response in either sex is again an area to broaden. Previous exposure to microorganisms, we all know about the exposure to herpes and how it prevails as a latent and chronic infection. A very interesting thing is the HCMV status. We see that up to 70% of the elderly above 60 years are either infected with HCMV, with the cytomegalovirus, or they are seropositive for cytomegalovirus. And we see that this cytomegalovirus, it affects the CD38 of T cells. And we see that most of these elderly who have the positive HCMV status, they have decreased CD38 plus effector cells or memory cells and increase in the CD38 minus effective cells. Now, CD38 is which governs the second definition of immunosenescence, that is, there is an increase in the memory cells. So these are the hallmarks of immunosenescence. There is a reduction in the number of peripheral blood naive cells, both T and B cells, associated with a relative increase in frequency of memory effective cells and a lingering chronic inflammation, which is known as inflammaging. So let's come back to thymus, which is the predominant immune organ. If we look at this graphic presentation, we would see that by puberty, there is atrophy of the thyroid characterized by increased adiposity as against the thymic tissue. And by the age of 50, we see there is a drastic abrupt atrophy of the thyroid. And as the age advances, we see most of the thymic tissue is replaced by the adipose tissue. So what happens is thymus is the one which is contributing to most of the adaptive immunity. So we see as we age, we are on the negative balance of T cells and B cells. Again, this is why we see that in there is a sudden atrophy of the thyroid at the puberty is because of the falling in interleukin-7 and increase in the sex hormones. If we go through this slide, we will see that there is the cells of innate immunity, which are neutrophils, monocytes, macrophage. All of them display decreased phagocytosis, chemotaxis, receptor ROS production, reactive oxygen species production, decreased cytotoxicity, and most importantly, decreased antigen presentation. Some changes happen in the adaptive immunity in that the naive pool of T cell and B cell is replaced by a subset of effector memory cells. And despite what we see, despite the functional and the numerical changes which happen in the innate and adaptive immunity, we see there is an if somebody could if we could, yeah. So despite the alterations, functional and numerical alterations in the immune cells, we see that there is an increase in the pro-inflammatory cytokines such as interleukin-6, interleukin-8, etc. So with this, what are we seeing? We're seeing that there is an increased telomerase activity. There's an increased incidence of cancers. There is increased susceptibility to infections. There is an increased autoimmune inflammatory reactions. And there is a maladaptive response to vaccinations. Let me just say a few words about inflammaging. So inflammaging, it means persistent, non-resolving, low-grade inflammation during ages that moves on to an inflammatory status or repair tissue injury. Now, this is characterized by increased biomarkers like interleukin-6, CRP, TNF-alpha, and this is what is implicated in most of the neurodegenerative disorders, diabetes, cardiovascular diseases, as well as cancers. Let's come to immunomodulation now. So what do we mean by this immunomodulation? Immunomodulation, it basically implies that there is an adjustment of immune response to a desired level. It can either be by potentiating immune response, suppressing the immune response, or inducing a state of immunologic tolerance. Now, what are the situations where we really need augmentation of immune response? So it is usually achieved by vaccinations in cases to prevent infections predominantly in the primary or secondary immunodeficiency states. We can fight the established infections by shifting the immune response to T cell helper phenotype, and as well as in fighting cancers. Allergies, autoimmunity, and organ transplantation are the scenarios where we usually go for immunosuppression. Now, why do we need immunomodulation in elderly? So we know that we are facing the COVID pandemic. We are going to have an obesity pandemic. Now, if we see probably by 2050, it should not happen that we have a pandemic of immunosenescent elderly. So increase in lifespan essentially doesn't mean increase in health span. What is happening? What happens is as the person gets immunosenescent, he falls prey to more infections, he falls prey to autoimmune diseases, chronic diseases, leading to more hospitalizations, more morbidity, mortality, increased pressure on the already ailing healthcare infrastructure, leading to total social and economic collapse. So we are looking at the new frontiers like immunomodulations, maybe to be prepared for the coming epidemic. Now, how do we achieve immunomodulation in elderly? Over ages, it has been found that diet is the over ages, it has been found that Mediterranean diet has played a diet has played an active role. Diet has played an active role in the maintenance of anti-inflammatory status and a proper immune regulation. So if we go to the Mediterranean diet, which we have read day in and day out, whenever we talk about cardiovascular diseases, we see that there is an increased increased life expectancy and decreased cardiovascular diseases in the Mediterranean regions, where there is a more consumption of Mediterranean diet comprising of fruits, vegetables, and with decreased consumption of animal proteins. So how do we achieve immunosenescence, immunomodulation? How can we immunomodulate the elderly with this diet? Is it downregulates the level of soluble intracellular adhesion molecule, vascular adhesion molecule, C-reactive protein, and interleukin-6, which are all the pro-inflammatory mediators. Now, caloric restriction again plays a major role while downregulating the activation of many of the pro-inflammatory mediators. We have been talking about cycles of fasting, mimicking diet, long-term fasting, etc. in cases of diabetes. These fasting ways influence inflammaging as well by means of their antioxidant and anti-inflammatory effects. So it could be due to the disposal of damaged cells with the growth of new cells. We also know about metformin, the new aging molecule, which is an activator of 5-AMP activated protein kinase. It is called as an anti-aging molecule. How do we achieve this immunomodulation by diet in malnourished elderly? So all the ways which we spoke about till now was anticipating that they were well-nourished or properly nourished elderly. In malnourished, we cannot follow, obviously we cannot follow these ways. So what we use is we can use supplements such as zinc, which had been in a big controversial state with COVID, copper, iron, vitamins like C, vitamin E. Vitamin C especially because it increases the antibody formations, nutraceuticals and probiotics. So there was this study in severe sepsis. It was a randomized control study where they found that they could demonstrate some of the immunomodulatory effects of glutamine-enriched nutrition by decrease in some of the pro-inflammatory biomarkers. Old is gold. Physical exercise, as has shown, is pleiotropic effects in almost all the disease conditions, have shown in retarding immunosenescence in elderly as well. So increasing the habitual physical activities, basically the moderate strength and endurance exercises, it enhances the innate immune functions, and it thereby it reduces the infection risk and inflammation potential. So the kind of exercises which we propose are moderate and intense training lifestyle exercises. And this has been seen in sustained higher antibody responses in elderly who received influenza vaccine. We all know that cancer also decreases if we maintain a healthy lifestyle. So if we go at this illustration, what we see is in innate immune system, there is a decrease in the neutrophils, macrophages, and there is a decrease in the naive T cells with a chronically elevated pro-inflammatory cytokines if we follow a sedentary lifestyle, as against a physical active lifestyle, which totally reverses the entire scenario, where you see that there is a decrease in the senescent exhausted T cells along with an increase in the naive T cells and the increase in the decrease in the pro-inflammatory cytokines. So we all know that toll-like receptors, they are upregulated along with physical inactivity, and hence thereby increasing the systemic inflammation. Again, there is a lot of hullabaloo about probiotics, prebiotics, and symbiotics in irritable bowel syndrome, in inflammatory bowel disease, and a lot of other things. We know as we age, there is an increase in the proteobacterium while the butyrate-producing bacteria decrease. And we know that this dysbiosis of gut microbiota also lowers our immune status. So they have tried with specific strains of lactobacilli bifidobacterium as probiotics and some galacto-oligosaccharides as prebiotics, and combining together as symbiotics in immunocompromised people, and where it was seen that there was a lower production of all the pro-inflammatory cytokines by peripheral blood mononuclear cells. Nutraceuticals, they again encompass a plethora of diseases. So they have an application right from cardiovascular diseases to gastrointestinal diseases. We know these are the plant-based products, bioactive food compounds, which are usually plant-based and in fatty fish. Coming to carotenoids, if we think what we consume in most of the vegetables and fruits, the quantity of beta carotene in that is very less. So they did some studies with higher doses of beta carotene with 30 and 60 milligram per day, and they found that there was increase in the natural killer cells. Similarly, we have all been talking about dietary polyphenols. So if we say resveratrol, there's a good news for red wine lovers. So resveratrol is red wine, berries, and grapes. They are rich in resveratrol. And they found that if you have a regular consumption of these dietary polyphenols, they again reduce the expression of various cell adhesion molecules. Of course, we all know about omega-3 polyunsaturated fatty acids, which are rich in fish and flax seeds. They also exhibit anti-inflammatory properties. So if we go through this, so we have a total win-win situation. But what we see is this win-win situation is predominantly still with exercise, diets, and nutraceuticals. So as we mentioned, what are immunostimulants and what are immunosuppressives? Immunostimulants are the ones which usually potentiate the immune system, and they have been used in multiple cancers, infections, viral fungal infections, and many of the immunodeficiency and autoimmune disorders. So we have a whole range, a battery of immunostimulants which have been used for different indications in different scenarios in younger patients till now. And we do have these immunosuppressants, again, which have been used right from organ transplant to autoimmune diseases. But we are still, and in these immunostimulants, we are now looking at these newer ones, which are the checkpoint inhibitors or the mitosine kinase inhibitors or TOR inhibitors. So if we think of interleukin-7, if we go back, if you just recapitulate the slide which we saw when the thymus atrophy was shown, we saw that interleukin-7 had a major role to play in thymus atrophy. As the levels start falling, this is mainly produced by bone marrow and the thymus medullary cells. So as the age increases and the thymus atrophy starts, the interleukin-7 levels fall. So what they've tried is they tried with therapeutic doses of IL-7 to enhance thymopoiesis in older individuals. But there was a caveat in this. What happened is we require the integrity of the thymic architecture in terms of its stroma and its epithelial cells. So we have to assure that the thymic integrity is there so as to see the response of interleukin-7. Similarly, immune checkpoint inhibitors, which are monoclonal antibodies that inhibit the expression of many proteins made by T cells in some cancers. And they have been actually, what role do they have in, they have been majorly studied in cancers, but what role do they have in retarding immunosenescence is still, the studies are still to be done for this. And they have studied some of the antibodies like PD-1 inhibitor and cytotoxic T lymphocyte antigen inhibitors like ipilimumab and nivolumab in bladder and the metastatic cancers. Mitogen activated protein kinase inhibitors, they target the second hallmark of immunosenescence, that is by decreasing the number of inhibiting and or decreasing the number of effector memory cells. Vaccination. This remains still the most cost-effective and most the safest way for modulating the immune response. What we have been witnessing is that vaccine efficacy is quite lower in elderly. Now, there are multiple reasons for this. And so what have been tried is to manipulate the response to vaccines by newer tools like use of cytokines, viral vectors, and naked DNA by using high doses of vaccine. So they did a small study in which they gave in influenza, they gave a higher dose of influenza vaccine than the standard vaccine in the elderly. And they found that the antibody response was much more with the higher dose as against the lower dose. But when compared with the younger adults, there was not much of difference. Similarly, they tried with different routes of administration, again with influenza vaccine, and they found that the availability of vaccine at the site was much more by intradermal administration rather than by intramuscular route. Newer adjuvants, we have been using aluminum preferably as the adjuvant always in most of the vaccines, but they found that newer adjuvants, they can increase the antigen presentation of the naive cells, and probably that can help in the vaccine to be more efficacious. So now trained immunity, it is a newly emerging concept, and which shows that innate immune cells usually say they possess a non-specific immune memory, and this is established through epigenetic and metabolic reprogramming. How much we can train this immunity with respect to immunosenescence is a frontier which is still being probed upon and is are working on it. And if it works out, probably it will improve the efficiency of vaccinations, and it will enhance the immune response against infections. BCG vaccination we had heard a lot during COVID scenario, and whether it will be of help in retarding immunosenescence is again a point to ponder. So we do have a lot of these newer things in the pipeline for us. But as of now, we as geriatricians, we still are tied down with immunomodulators like diet, physical activity, and nutraceuticals. They are the gold mines. Probably nothing would be, this is something which will have more of universal appeal, more of universal availability. And the newer immunotherapies which are on the anvil, how much would it be accessible to all the class of people, whether we will be able to achieve the target which we are thinking of, is only future is going to tell. So we have this Dhanvantri, which has a pot full of so many things. Let's see what works out for us. Thank you. Thanks a lot.
Thank you, Dr. Sadhana, for your excellent insight into this very important topic of immunomodulation. You have nicely enumerated the details of the cellular level functions and what is the immunomodulation. And I have a quick question. You said there one fascinating word that you have used, inflammaging. Is it either universal, is it uniform in everyone, or if it is not, what could be the reason? I'm talking about inflammaging that you mentioned.
Yes, sir. So inflammaging is, again, as such, we say we cannot really predict because every individual is different. The immune status is different. So we really don't know the inflammaging, whether it's going to be uniform or not. As we said, the immune senescence itself is multifactorial. It is determined by multiple factors, like sex being one of them. So maybe the immunomodulations in the form of exercise, diet, and all those things, they are a non-uniform parameters in a different class of population, different subset of population. Maybe it may not be uniform.
Yeah, metformin, you said it's an anti-aging, but diabetes is immunosuppressive state. And metformin, is it can we use metformin as immunomodulator, or is it just a research stage now?
It is still
Hello?
in the...
Okay. Yeah, thank you very much. Anybody has any questions in the box? Dr. Krishna, anybody has any questions? Can you just check?
No questions, sir.
Okay, if there are no questions, I think we will stop here. Dr. Sadhana, it was nice talking to you and listening to you. Thank you very much. And it was very wonderful talk. Thanks, Dr. Sadhana Sharma. Thank you.
Thank you, Dr. Sadhana. Thank you, Dr. Vijayamohan Garu. We would like to go to the next topic. I would like to call upon Dr. Shanti Garu to chair the session and introduce the speaker. Shanti Madam, to you, ma'am. Thank you.
Yeah, thank you. The next, having heard so much about immunomodulation, the next topic of this session is on vaccination in elderly. And we know that vaccination, which was once considered as only for pediatric age group, now it applies to elderly as well. And much more has been talked about during this COVID days. So now they have thrown light on the importance of vaccination in elderly in the past 1 or 2 years, even though all are aware that elderly people who are also vulnerable, who are also like children, need vaccination to boost up their immunity. Its application and its practical use is now emphasized in this COVID era. So I would like to introduce the speaker of this session, Professor Dr. V. Chandrasekhar, the organizing secretary of this GERICON 2021, and he is the chairman of API Telangana chapter. He is professor of medicine of Kakatiya Medical College, Warangal, and also the medical superintendent and additional director of the Mahatma Gandhi Memorial Hospital, Warangal. He was former principal of Kakatiya Medical College, Warangal also, and he's a teacher for postgraduates in the field of medicine for nearly 24 years. And not only that, his contribution in the scientific area is he has addressed many national and international forums, and he has been a faculty of EPICON, RSSDI, ACPCON, and IMA activities. And he has published many articles and papers in the national and international journals, and also contributed chapters for Medicine Update and so many monograms. So over to Professor Chandrasekhar for his talk.
So good afternoon, madam, and good afternoon all the delegates. At the outset, I thank Dr. Shanti madam, scientific chairman, for giving me this opportunity. And at the same platform, I extend my thanks to Dr. Magesh sir, Dr. Vyas and Raju sir, for giving me this opportunity. So I am talking on the immunization in elderly, but the previous speaker, Dr. Sadhana Sharma, has very much explained about immunomodulation, so which made my talk very easy. So I'll straight away go into the vaccination aspects in the very elderly. So, hello, it's not moving. Oh, yeah. So this madam has already told you the aging overview is genetic, epigenetic, and environmental factors. So it is almost like a chronic inflammatory disease status with cachexia, sarcopenia, osteoporosis, and all. So this is how the thymic involution and immune or inflammatory dysregulation. So that the novel term about this thing has come. And there is a two aspect, frailty is there, definitely immunosenescence is there, but aging is a heterogeneity in itself. So because the immunosenescence with multiple mechanisms, so there may be impaired functionality in the immune cells, decrease in the total T cells, B cells, NK cells, and there is also impaired functioning in the many organs. So this is also interplay of the many things like healthy eating and having the regular physical activity and avoiding the smoking and screening of the chronic conditions and hygiene. But at the bottom life of this pyramid, so the life course immunization, so which was not picked up very much into the population, adult itself, and elderly adults is still more difficult. So the impact of immunosenescence, we know that the diminished protective effect response to the vaccination is also a one problem, because vaccination helps, but the taking up of that immunogenicity after vaccination is poor. So because of this, so there may be some increased susceptibility to bacterial and viral infections. So these are age-related changes. Madam has been elaborated. So there may be changes in the adaptive immunity in T cells, and there is also changes in the adaptive immunity by B cells in the aging. And so here, the vaccination in the older adults is a underutilized opportunity, particularly to promote the healthy aging in India. So WHO says that immunization is...
Can you move on the slides?
Madam, am I audible?
You're audible, but slides is only the title slide until now.
So it's not moving, madam?
PPT, it's only the first slide which is seen.
Okay, I think I'll again go back and
थोड़ा stiffness कम हुआ, stiff है. Right left थोड़ा swelling थोड़ा कम हुआ.
Right. Now is it moving, madam?
Yes, now it's.
Back then both ये थोड़ा swelling.
I think somebody is talking. Can be muted.
Please unmute all participants. So here, after I was telling about this, madam, vaccination in older adults is a definitely underutilized opportunity. So there we are lacking to go ahead for healthy aging in India. So here WHO says that immunization is not for the children, and it should be beyond infancy as a global priority. So this is why, because that population group percentage is changing over the decades. As of now, 46% are in the adult age group of 2 to 49 years. So may reduce it to 46, whereas the older adults above 60 years may be increasing for 27 years, 27%. So here, because of this, there may be chances of mute all these things. Mute all participants.
మీటింగ్ పోవాలి
Where from it is coming? Oh yeah. Yes, here. Sorry, madam. There is some crosstalk is coming. The technician is verifying. I think now it is clear, madam. Yeah. Okay, madam. So because of this changing, increase in the number of the older adults, so from 2021, 19% to 27%. So there is also increase in the prevalence of the VPD, that is vaccine preventable diseases in India, from 2.2 to 3.4 times higher than. Even compared with the global scenario also, the need for vaccinating the older adults is much more as for this slide. And the increasing age is associated with the higher risk of the chronic health conditions, particularly one with the diabetes mellitus is increasing as the aging. So the diabetes mellitus itself is an immunodeficiency condition, so it may prone for so many other infections. And as well as there is also this orange line indicating increasing incidence of the chronic lung disease, so which may cause so many associated infections and which will have an impact on the morbidity and mortality. So this burden of the vaccine preventable disease is very much in 4 diseases. One is the influenza. So now when we are in the current pandemic of the COVID, it's the modification of the influenza itself. And there is what is called as the invasive pneumococcal disease. So 90% of the invasive pneumococcal disease will be more among the adults 65 years of age. And pertussis is one which is underdiagnosed, which may cause secondary infections and lead to death, and herpes zoster is the one. So these are the 4 important diseases in elderly persons, so which are very much preventable. So that is the point I want to emphasize on this. And these vaccine preventable disease has a exuberant costs affecting in all these things. So in one study, it is amounting for the $11 billion annually for the population between 50 and 64 years. So that much can be saved with one preventive measure with the vaccination. So adult immunization coverage rates are very low. So we are failing to vaccinate our elderly population, because all the elderly population are taken care of their children. So strictly following the universal immunization, but the reverse when should happen, that grown-up children, so he has to vaccinate his parents. So that was lacking. So it needs some social reforms also in the society thinking. And as a physicians and geriatricians, we have to spread this information of these vaccine preventable diseases. So here in one study from the AIIMS Jodhpur in 2018, so there are Indian adults are under immunized, and there are barriers for this under immunization. So lack of surveillance is there, lack of national guidelines, lack of coordinated adult vaccine programs, and cost is also one this thing. Treatment taking precedence over the prevention. So we are all after at the fag end of the COVID pandemic, we have focused on vaccination. So like that, so we will attracted for more of treatment rather than the preventive aspects, and lack of provider. These are the various reasons why it is. But despite all these things, global and local bodies recommend so various adult vaccinations. So WHO in September 2020 says that individuals with underlying health conditions like diabetes, hypertension, HIV, AIDS, asthma, and other COPD, chronic heart lung disease should continue to be prioritized for the influenza vaccination. So, but still there are news that some are hesitating to take even COVID vaccine. So even GINA April 2021 recommends the people with asthma to have the annual influenza vaccination. So API also, Association of Physicians of India, has a policy for the COVID pandemic. June 2020 recommendation says that immunization should be continued during even COVID-19 pandemic. So the vaccines are effective. I think this part also covered by Dr. Sadhana Sharma. So it effectiveness varies, depends upon the vaccine type, disease outcome, and the age and health of the person vaccinated at the point of vaccination. So it may results may vary according to the what parameters you are looking for, whether prevention of death, prevention of hospitalization due to secondary infections, and reducing the visits to the doctor and visits to the emergency room, and just to prevent the disease symptoms. So this will vary. So, but one thing I want to tell you, the ramifications exist when we fail to vaccinate the adults. So not only that one particular individual which is going to be affected, but because of these not vaccinating in masses, so that creates a disincentive for the manufacturers. You see, because for many diseases, for the over the decades, no vaccine is developed. For these 2 years, this COVID has almost 10 to 12 vaccines are available, because when need arises, demand arises, so it is incentive for the manufacturers also. So not to pray for this incentive to the manufacturers, so that we may not get the available vaccines for the needy population. So this also leaves the chronically ill people vulnerable with the diseases, and it also creates the disparities. Despite all these things, so just this is a table for the following the adult immunization, but I'll be concentrating on population over 60 years. So influenza, so whatever may be the age, yellow is the mandatory vaccine. So 1 dose has to be given every year. So that also holds good for the over 60 years olds. And the tetanus, diphtheria, pertussis vaccine, either TD or Tdap, has to be given one time at the 60 years of age, and thereafter every booster over 10 years. And varicella, 2 doses has to be given across the spectrum. It is a mandatory. And the zoster, you see, zoster is specifically recommended for 60 years old, and rest of the others. And one more thing is the pneumococcal vaccine, 1 dose has to be given over the 65 years. This yellow is a mandatory. So other this violet color indicates the meningococcal hepatitis A and B, depending upon other situation. So how many remains now? Influenza annually, and pertussis 1 shot right now if is not taken, and every 10 years after. Varicella 2 doses, that's all. Booster 1, zoster 1 dose, and pneumococcal vaccine 1 dose. So these are the only 4 vaccines remains. So here out of the adult vaccinations, only this red indicating is needed for 65 years of age. Influenza and polysaccharide vaccine for pneumococcus 23 for 65 years, tetanus and TD vaccine for every 10 years, zoster for 6 years, 60 years and all. So these are the only 4 vaccines. Just we can including these 4 vaccines for elderly persons. So we are saving their health, their wealth, and many other things. So there is something about the pertussis which is also underdiagnosed because symptoms are so common. And these pertussis is estimated to be more common in older adults than reported because it is under-recognized, so under-reported. So they will think that the cough may be because of something else. So the cough is the most common symptom, and these clinical symptoms in the very elderly are very atypical. So we may miss this thing, but the cost of the missing pertussis, actual versus real incidence, will vary from each study. So there is a strong major difference between the study incident and real incidence. So, and even at the childhood, we have taken the pertussis in DPT. So either in between the natural infection or by the vaccination, the protection will be lasting up to maximum up to 12 years only. So because of this, it may cause the serious health impact, including the mortality. Mortality over the 50 years, it is 28% when compared with 1 to 5 years. But here we will take the vaccine more promptly rather than here. So like that, the quality of life also worst in this age group. So because of all these reasons, so even the secondary complications with the pertussis, which is underdiagnosed, pneumonia is almost 10%, sinusitis is 13%, otitis media is 4%, and so the cough, chronic cough, unexpected, may lead to other health problems like urinary incontinence, weight loss, rib fractures, and fainting. This we may think that these are the independent problems of the elderly, but in fact, they may be secondary to the undiagnosed chronic cough, maybe perhaps due to pertussis. So taking into all these consideration, one shot of the pertussis vaccine has to be given so that they will be prevented with secondary bacterial and viral infections, saving their life. And here, Global and Physician Association recommendation for the Tdap vaccination in adults. So Gold says that all the COPD patients should receive one Tdap if not vaccinated in the adolescents. And CDC says a 10-yearly Tdap booster, and APA also says that one Tdap dose start and every 10 years thereafter. So in summary, for the pertussis is underdiagnosed in adults. It is in very old adults and those with asthma or COPD, leads to increased disease burden. And although Tdap vaccination helps prevent the pertussis, coverage is low and at-risk group remains vulnerable disease. And the world trusted Tdap is there with many companies. Boostrix is one with GSK. And coming to the influenza, we know that we are currently in COVID-19 pandemic. So because simple flu and COVID have almost many similarities, it is sometimes because in coming days, so whether third wave will come or not with Omicron, but definitely this COVID will become endemic rather than totally eliminated. So then comes a situation where to differentiate between it is a common flu or COVID-19. So for this reason, COVID vaccination is mandatory, as well as annual influenza vaccination is also mandatory because influenza associated deaths are up to 90% in the aged more than 65 years of age. So there are so many recommendations. Even WHO recommends that a seasonal influenza vaccine should be given prior to the start of the primary dose of increased influenza activity. So benefits of influenza vaccination in risky adults is that patients with chronic respiratory, that COPD, and influenza vaccine should reduce the morbidity among the COPD. And in particularly, the influenza vaccine reduces the morbidity among the CVD patients also. Many patients may be suffering with coronary artery disease. So it will cause the 20% reduction in the risk of hospitalization
So even diabetes and influenza has a very bad combination. Influenza vaccine reduces the morbidity among the diabetes patients, whatever may be the morbidity. So it without vaccination, diabetes has a 3 times
Please
higher
mute.
risk for
Somebody's
hospitalization.
crosstalk is there. Can you please mute? Because we are not able to hear the speaker talking.
There's a lot of crosstalk is going on. You see, అది ఎక్కడ వస్తుందో recognize చేయండి, identify చేసేసి. I'm unable to hear myself also. You have to sit here and solve the problem immediately. Consider unmute చేయొచ్చు కదా అందరిది, all participants. Sorry, madam, for that. This thing I praised technical person. So this is about the recommendations for the adult vaccination. Even API, Association of Physicians policy decision during the COVID-19 has advised the proactive vaccination strategy for elderly and those with diabetes, COPD, cardiac disease, and kidney disease. So here there are two types of vaccines of the quadrivalent split variant vaccine is available, which mostly contains all viral antigens, and the seroprotection against the strain B is very higher with the split variant vaccine and T cell response. So there is also subunit vaccine, but the better recommended is a split variant vaccine. So coming to the summary of the influenza, older adults with chronic conditions are at the greatest risk of the influenza complication. Vaccination helps to reduce the influenza related hospitalizations, particularly in diabetes, CVD, and respiratory disease. So coming to the pneumococcal vaccine, polyvalent saccharide vaccine 23 is there. It is recommended after the age of 65 if more than 5 years since the original vaccine is taken. And there are conjugate vaccines and the polysaccharide vaccine. So it has to be given insequentially. So conjugate vaccine first either 7 or 13, followed by polysaccharide vaccine 23. So dosage schedule is given in this schedule. I am not going to elaborate. So there is a slight difference between the polysaccharide vaccine. Stimulates the antibodies in infants and toddlers is the polysaccharide, but conjugate vaccine is seen with conjugate vaccine is only useful for the infants, but healthy adults either of can cause antibody stimulation. And primarily immunological for enhanced responses can be seen better with this conjugate polysaccharide vaccine. So I am coming to end with other two diseases like herpes zoster. So reactivation of the chickenpox virus varicella, 1 in 3 persons will develop shingles during the lifetime. Cell-mediated immunity is a major determinant for incidence and severity. Immunocompromised persons may get disseminated with skin, CNS, pulmonary, and hepatic involvement. So usually unilateral and trunk are in the 5th cranial nerve. So it is usually associated with aging, immunosuppression, and intrauterine exposure and varicella at the younger age than 18 months of age. So herpes zoster vaccine changes the host cell relationship, and live virus vaccine boosts the cell-mediated immunity. It is little bit expensive, but it has a very advantageous for elderly, so particularly 50 and above, but it is less effective within the 4 weeks of pneumovax. That space one has to be given, that pneumovax given first, and then there are 4 weeks after you can go for the zoster vaccine. There are certain contraindications for the zoster vaccine, particularly severe allergic reaction, pregnancy, immunosuppression, and even active tuberculosis patients. So in conclusion, for the zoster, substantial burden of the disease in adults with vaccines are available, and vaccines are effective in adult population. Effectivity may vary with vaccine type, disease outcome, and age and health of the person vaccinated. Vaccination rates are low among the elderly population, and because of the ramifications in failing to vaccinate has many, including the increased morbidity and mortality. So I'll end my talk with a quotation: by failing to prepare, we are preparing to fail. That is a Benjamin Franklin. This holds good for the vaccinating elder population, particularly these 4 vaccines. As a repay or whatever you say, all the children should vaccinate their parents and grandparents. So there we are repaying immediately in this lifetime.
so that the social message has to go from the doctors, physicians, geriatricians, I thank you very much for your patient hearing. Thank you.
Thank you. Thank you, Dr. Chandrasekhar, for your very elaborate talk on a very important topic of immunization in elderly and the various vaccines which have to be advocated for the older people. Once upon a time, it was only a privilege for the people. Adult vaccination was given for people who travel abroad, which was made compulsory at that time. When it was optional, nobody came forward. But now the realization of importance of vaccine in the older patients is also recognized by the physicians as well as the public. So definitely this will pave way for better immunity and prevention among diseases. But we should also consider the point said by the previous speaker, that the efficacy or response to the vaccination is however less. And this point has to be appreciated. And definitely in due course, by repeated vaccinations, if 2 doses are recommended, it has to be complied with. Even for COVID-19, the people, we find there are a lot of resistance among elderly people in getting vaccinated, and for which sheer some counseling has to be done, and the fear for vaccination should be removed from their minds. And a point to be added in the pneumococcal vaccine, of course, you have emphasized the importance of influenza, pneumococcal, herpes zoster, and Tdap vaccination, which are mandatory for the elderly. And in that, probably the pneumococcal vaccine has an important role, even though it is very costly. Studies say that the rehospitalization rate for pneumonia is coming down when the person is vaccinated. And it is our duty to vaccinate, especially the all elderly. The recommendation says all elderly, but all the more for high-risk patients like COPD, diabetes, CAD, CKD patients, and so on. And here in pneumococcal vaccine, the recommended dose of conjugate vaccine, 13-valent conjugate vaccine, if the person is naive, up to 65 years, he has not been vaccinated, then the first dose should be a conjugate vaccine. And 1 year later, the second dose of polysaccharide polyvalent 23-valent vaccine has to be administered, so that you extend the coverage for the 23 serotypes. But however, even for other influenza vaccine, as you rightly said, the quadrivalent vaccine, which is preferable. So quadrivalent vaccine is nowadays the one preferred for the influenza, and Tdap, of course, now people are coming for it. And so many times we've come across people encountering herpes zoster in some seasons, and all the more 80% of them are in diabetic elderly. So definitely the zoster vaccine also plays a role. And whatever said and done, vaccination is our duty to prevent at least, especially COVID-19 infection to spread prevention of spread among the other family members is very essential, whether they cooperate or not. And it is our duty, as you have rightly pointed out. Thank you. Thank you so much.
Thank you. Thank you, madam.
Any questions from the audience? Any doubts, clarifications?
No questions, ma'am.
Questions in the chat box. So all are familiar, I think. So if there are no questions, shall we wind up the session?
Yes, ma'am. Thank you, ma'am.
Thank you. Thank you so much.
Thank you, ma'am. Thank you, ma'am. Thank you, sir. We would like to go to the next talk, robotic surgery by Dr. S. Ananthakrishnan. I would like to call upon Dr. Mohandas Garu.
Yeah, Mohandas speaking.
Kindly take over the session, sir.
Hello.
Dr. Mohandas Garu.
Yeah.
Sir, kindly take over session, sir.
Hello.
No.
Good afternoon. Hello. Hello. Is it audible?
Yes, sir. It's audible, sir.
Yeah. Good afternoon, everybody. I am Dr. Mohandas, Principal of Cognitive Medical speaking. Yeah. Now the next topic is on robotic surgery. Yeah, geriatric role of robotic surgery in geriatric people. The speaker is Ananthakrishna, isn't it? Yeah. Hello.
Yes, sir. You can read upon Dr. Ananthakrishna's CV, sir. It's projected, sir.
It's not shown in my laptop, no? Hello. Yeah. 1 minute. Hello.
Yes, sir. It's there, sir. It's projected, sir.
Yeah. I'm very glad to introduce Dr. Ananta Krishna. He is MS DNB, MRCS, Edinburgh, and MCH Urology and FRCS Urologist. Fellowship in Robotic Surgery from USA. He is a Chennai urologist and Robotic Institute of Chennai. And Dr. Ananta Krishna Sivaraman currently serves as a consultant urologist and director of robotic surgery at Chennai Urology and Robotic Institute, Chennai. Director of Indian Prostate Cancer Foundation and best known for pioneering robotic surgery in South India. So, hello. Hello.
Dr.
Hello.
Krishna, start the presentation, sir.
Yeah. Okay. I want to say a few words. The robotic surgery is very, very upcoming subject in the surgery field. So the robotic surgery is geriatric, not only useful for geriatric person, it is useful for geriatric surgeons also. With a robotic, we can older surgeons can operate very comfortably because they can sit in a console room and without standing, and there's no need to wear the gloves, so that they can intermittently refresh can be done, and they can avoid tremors while doing surgery. So the robotic surgery is very much useful for the older surgeons also, not only for geriatric patient, but older surgeons also very useful. So now I request Ananta Krishna Garu to present the robotic surgery in urology overview. Thank you.
Thank you very much. Thank you very much, Dr. Mohandas. And before I start, I must thank the organizers, especially Dr. Chandrasekhar and Dr. Mahesh, for giving me this opportunity. So before I start, as urologist, my thought process about geriatrics was that it's surgery of elderly people. But I actually looked at the definition, and the consensus seems to be people above the age of 65 come under the purview of geriatrics. And that in effect makes 85% of the surgeries that we do as urologists are geriatric patients. So I think our specialty itself should be called as geriatric urology. But my talk today is going to be on robotic surgery, especially in urology. So I'm going to give you a quick overview of what it is, and then I'm happy to answer questions at the end of this talk. So to start off with, this lithotomy is a procedure that was done in the 1600s. This is a French surgeon doing a lithotomy. And these were the type of instruments that they had at that time. They had one surgeon doing the procedure, and there's patient as well. He's lying down, and there's two other people that were there to hold the patient down. And the reason is we didn't have anesthesia in those days. And next, in the 1800s, this is introduction of ether-based anesthesia. And then they could operate comfortably without the patient having major pain. But the patients were still dying because there wasn't any asepsis. And this gentleman, Dr. Lister, he introduced carbolic acid and the aseptic technique, and then came antibiotics and so on. And then came the era of big surgeries where you could put in any organ and take out any organ. And this was the era of major surgeries. So as surgeons, it was a great time to be there because, the limitation was your imagination, what you could do and couldn't do. Because you could treat them without pain, you could get rid of infections, and renal transplants came into vogue, and all sorts of surgeries came into vogue. But one fundamental thing remained. We were saving lives, but the quality of life suffered because we had to put big incisions to do major surgery, and we were already treating patients who are elderly and who are sick. And imagine putting big incisions for those sort of patients, and the recovery is going to be much more prolonged. So the next logical evolution was minimizing access, and then came laparoscopy, where minimally invasive surgery could be done with laparoscopy, but laparoscopy was not perfect. The problems with laparoscopy were the exceptionally good benefits, especially reduced blood loss, complications, shorter length of stay, and so on. But there were limitations as well. And the limitations were especially loss of depth perception and hand tremor and decreased range of motions. The precision was not great, and it was ergonomically uncomfortable for the surgeon because you're looking at a 3-dimensional environment on a 2-dimensional screen and turning your neck and operating. So it wasn't ideal way to do surgery, but then laparoscopy came to stay. What we actually needed was to maintain the minimally invasive approach without losing the advantages of open surgery. And that is where robotic surgery came into the picture. Right? It was actually an American government-funded program for the army, where they wanted to operate on soldiers injured in the battlefield by a surgeon who was sitting about 100 miles away from the battlefield. So that was the goal of starting robotic surgery, but it slowly came into mainstream medicine, and it came with improved visualization, improved instrument control, enhanced dexterity for technically challenging procedures, and superior ergonomics. You can sit down and operate, and you can operate all day without straining your neck. So it was exceptionally good for the surgeons who were operating as well. So as I said, the original concept was to perform robotic surgery or remote surgery for surgeons in the battlefield, right? So what are the advantages? One of the main advantages is a 3-dimensional vision. There are 2 cameras in any robotic surgery scope and 2 lenses where we're able to give you a 3-dimensional vision of what's happening inside the abdomen. And the instruments were pretty small, same as laparoscopy, but the more important thing was there was an endo wrist that was available, which means that you can use the instruments like you use your wrist while you're operating. So that's again a key point in robotic surgery. And there, you could do 360-degree rotations of your arm, as well as wrist-like movements, exactly like a human wrist. So this is the size of the instruments. And a lot of people ask me when we started out with robotic surgery. Now, I came to India in 2012, and the initial battles were when we had to convince patients that it is the surgeon who is operating, not the robot. So the robot as a term gives us this idea that something is being done by a machine all the time. But here, this is actually, the robot is misnomer. It is a master-slave system where what we do outside happens inside. So the next video that I'm going to show you will demonstrate this suitably. So this is how it happens. So what I do outside using the instruments that have come with the robotic console exactly happen inside. And it's an immersive field where you put your head into the console, and the machine gets activated only when you put your head into the console. So what is done outside exactly happens inside. And the ports are done similar to laparoscopy. And the vision that we get is 3-dimensional. And because the camera is so close to the field that we're operating in, it gives us such a wonderful picture as exactly like we're seeing with our own 2 eyes. So this is one of the systems available. It's called the Da Vinci surgical system. And now, for the last 20 years, the first robotic prostate was done in the year 2000. I started getting trained in the year 2006. But it's been 21 years since the first robotic prostatectomy has been done in the world. And it's slowly but steadily, the robotic surgery is advancing into the mainstream medicine. So this is one of the systems. It's called Da Vinci system. And there are other systems available as well. Medtronic is making a system called the Hugo system. And then the CMR is another company, the British company, that's making another robot called the Versius system. So they're all in India at the moment. And eventually it's going to become much more widespread. So this is a video of how we put the ports inside. So the ports have already been put inside and the robot is being docked. And this is the hospital that I got trained in the US. So there you see, these are the robotic arms that are being attached to the patient. And there you go. So each and every instrument that we put inside has to go via ports that are pre-placed onto the patient. So the head of the patient is towards us, the leg of the patient is away from us, and we're operating on the abdomen. And this surgery being done is a prostatectomy surgery. And what you see right now is the ports being fixed. So that's the time it takes. It's exactly real time. It takes exactly 2 minutes for us to dock the robot inside, and the instruments go inside. And the size of the instrument, the ports is around 8 millimeters and 1 10 mm port for the camera. So you see the camera going inside, and this is how you push the camera inside. And what you see outside is on the screen, the immersive screen is about 5 to 10 centimeters away from your area that you need to operate on. So why is it so important for the prostate? So because robotic surgery and prostate cancer surgery kind of grew together. Previously for prostate cancer surgery, they were mainly doing radiation or orchidectomy. But with the advent of robotics, there were kind of a huge eruption in prostate cancer surgery as well, because we could do it very comfortably for the patient as well as the outcomes. So if you looked at prostate cancer mortality, that was pretty low across Asia. But if you looked at incidence to mortality, it is very high in India. So which means the chances of Indians dying from prostate cancer was very high if they got it. Though the incidence is lower, the chances of dying because of it is higher. And one of the reasons, the main reasons is we are seeing cases at later stage. The idea that we have to do prostate specific antigen for people above the age of 45, 50 on a yearly basis is kind of not percolated into the mainstream. For instance, when I came back about 10, 12 years ago, what you had was master health checkups that didn't bring in PSA as part of the protocol. So that's something that we're trying to change here as well. So if you look at the anatomy, inside the abdomen, the organs that are best, most advantageous to operate are prostate, bladder, and the kidney, and these are urological organs. And what are the benefits of robotic surgery? If you look at this video, what you see here is, hopefully it starts. Right, let me go back. And one of the benefits of robotic surgery is that, let me see. Yes, right, it's starting. So this area that you're seeing right now, just robotic surgery happening, this area is the prostate, and this is the dorsal vein complex. It is below the pubic symphysis. Now, I've done the same surgery as an open surgeon. I've done it as a laparoscopic surgeon and as robotic surgeon. Now, this sort of vision that you get here when you're doing robotic surgery, where you're right close to the organ of interest, and the arms and your movements that you do, like for instance, we're suturing here, is so convenient when you do robotic surgery, because you see the wrist of that instrument. That is what makes one of the key differences. And it's 10 times magnified compared to 4 times in laparoscopic surgery. So this again is one of the key advantages, your ability to look at organs that are otherwise very difficult to reach when you're doing open surgery. For instance, when I do this as an open surgeon, if I put my arms inside this pelvic area, I won't be able to see the organ. It's more by feel rather than by seeing. So, but when we're doing robotic surgery, because that's the quality of the vision that you get, 10 times magnification, as well as the pneumoperitoneum. When you have pneumoperitoneum, small blood vessels, etc., do not bleed. So the vision that you get, again, is very good because of the pneumoperitoneum as well. So let me go to the next video. I won't keep you on this. So how does the robot improve outcomes? Now, a lot of people said initially that it was a marketing gimmick. There is nothing that the robot does that cannot be done by open surgery and so on. That was 20 years ago. Now we have reasonably good evidence and robust evidence saying that robotic surgery does improve outcomes. So whenever we talk about prostate cancer, we talk about the trifecta, which means getting 3 of these entities: cancer control, urinary continence, sexual function, all of that to be exceptionally good in a person after having prostate cancer surgery. So I'm going to show you some evidence that came some time ago. And the reason here is, if you look at, these are neurovascular bundles that go close to the prostate. And this is what is important when we do prostate cancer surgery. If you're able to preserve these neurovascular bundles, if you're able to give a good length of the urethra when we're operating, then the outcomes for the patient, along with cancer control, are exceptionally good, right? So that's the video that I wanted to show you. So again, the left side here is the prostate where my cursor is moving. And this is the neurovascular bundle that's going close to the prostate. And there you see very tenuous nerves and vessels that need to be preserved. And because we are using instruments that give us 10 times magnification and millimetric precision, we're able to preserve these nerves and at the same time take out the cancer. It's like your prostate's wearing a shirt, and we need to leave behind the shirt and take out only the prostate, right? So this is the neurovascular bundle that's important for sexual function. And because we can see so well, it's difficult to make a mistake here. So only the pedicle to the prostate is cut whilst we're preserving the neurovascular bundle in this particular case. So that's one of the key advantages. That's how robotic surgery helps us preserve the functional outcomes for the patient and give them adequate cancer control as well, thereby achieving the trifecta. So again, evidence shows that in terms of operating room time, in terms of estimated blood loss, in terms of complications, in terms of positive surgical margins, in terms of continence 12 months, in terms of erectile function, robotic surgery is more than adequate or equal to open surgery. But the advantages are significant enough to choose robotic surgery or open surgery, especially for prostate cancer. So what about surgery per se? When you're talking about prostate cancer, one of the diseases that you commonly see in the geriatric population, surgery compared to other modalities seems to be definitely better when you're talking about localized prostate cancer. If it's not localized, then other modalities and multimodal approach comes into the picture, right? Now, even now, one of the things that we have started doing quite often recently is people who've already had radiation for prostate cancer. They come back to us. Probably they've had it 10 years ago and the PSA is not responsive after radiation. They come to us and we do a salvage robotic prostatectomy. So again, this is one of the more difficult components of robotic prostate cancer surgery because the planes are not very good. It makes us suffer when we're operating. But even this, we're able to offer good outcomes for patients who need salvage robotic prostatectomy. So that's about prostate cancer surgery. One of the most commonest things that you will see in terms when you're talking about the geriatric population. And the reason I put that is to show that the bar is being raised in terms of the outcomes that we're able to give for prostate cancer patients. Next comes renal surgery. And again, nephrectomy, partial nephrectomy, pyeloplasty, pyelothotomy, these are common things that we do for the geriatric population. Now, this is a very thought-provoking slide. Now, previously, when somebody talked about renal cancer, the surgery that comes into mind is radical nephrectomy. But of late, this has changed because if it's a small tumor and if you're able to resect it well, then the long-term oncological outcomes of partial nephrectomy are similar to radical nephrectomy, with the advantage being that you're able to give these patients that amount of extra nephrons. So nephron sparing surgery is the norm. Now, the advantages of doing it with robotic surgery is you have a ultrasound that you place it on the renal tumor. So you know how much to cut and how far to cut and how deep to cut. So this is a quick example of renal tumor that's being done. Now, 10, 15 years ago for tumors like this, radical nephrectomy would have been the norm. But things are rapidly changing nowadays. Now, in my practice, predominantly we do, if we, previously, but if we thought about radical nephrectomy, that would be one of the commonest surgeries that urologists do. But in my practice for renal tumors, 80% of the time it is partial nephrectomy rather than radical nephrectomy. And the reason is predominantly you see these small renal tumors nowadays being detected incidentally. So people go for a mast cell checkup, people go for some other problem, and they get an ultrasound done and it picks up a small renal tumor and they come to us. We're able to save the kidney as well as preserve the rest of the kidney, save the kidney and take out the tumor. The oncological outcomes of partial nephrectomy are more or less similar to radical nephrectomy. So I think this has become the norm. But obviously, we have to understand the size of the renal tumor also matters. Now, if it is a 10-centimeter tumor, there is no reason to do a partial nephrectomy. You will have to do a radical nephrectomy. And if it's involving the entire kidney, there is, again, no reason to think of it as a partial nephrectomy case. But if it's a small renal tumor, 4 centimeters, 6 centimeters, up to 7 centimeters also is acceptable. If it's an exophytic tumor, doesn't involve a lot of the kidney, then it is our duty to give the patient this ability to preserve the nephrons in the kidney. again, elderly people, we get a lot of them with diabetes, hypertension, and you also look at it, they have some sort of azotemia. If you take out the kidney, they might go into dialysis. So again, carefully assess the patient, and we have to tailor the surgery for the patient situation, right? So there you go. We are cutting out the tumor. I'll quickly skip this for want of time. I think it's, so this is how the tumor is being cut. Now we've already marked the edges of the tumor with ultrasound. The depth has also been marked, and we're able to cut out the tumor completely. And we will send it for histopathology. It shows what exactly the specimen is. So again, here, what you're seeing here is the tumor bed that has been cut. And because the kidney receives 1/5 of the blood supply that's being pumped by the heart, it's a very, very vascular organ. So we have to clamp the vessels when we're doing the renal tumor surgery. And there is a time frame within which we need to do it. So about 20 to 30 minutes is the maximum that you can be operating when you're doing a partial nephrectomy, because beyond that, then you're going to lose more nephrons than you're going to save. So there again, there you see this. It's a sliding clip rhinorrhaphy technique. The tumor has been cut, and the tumor bed is completely sutured. And at the end of it, we bring it back together, the edges of the tumor, and thereby the patients. So the advantage in robotic surgery is for this sort of major surgery, the patient stays in hospital only 24 to 48 hours. They start walking when they're about 4 to 6 hours after surgery, start drinking in 4 hours after surgery. And I'm going to show you this quick video to show how we mark the tumor with the ultrasound. So this is the point that I wanted to bring in. 1 second. So there you go. So quickly take you to the site where the ultrasound is being done. But anyway, I think let's move on. So, right. So what we have ability right now is to have an ultrasound probe inside the abdomen while we are cutting out the renal tumor. So the probe sits on top of the kidney, and it tells us how deep we're going, how far we're going, and whether all the margins are going to be free or not. So this is one of the, so this is what I wanted you to appreciate. So you see the renal tumor here, the ultrasound probe here. I can keep the probe on top while I'm cutting out the renal tumor. That gives us an exact idea how far we need to go and how much of the kidney we can preserve. So then again, another quick video to show what we do for prostate cancer surgery. So even when we're doing for prostate cancer surgery, especially for salvage procedures, we can keep an ultrasound probe as a 4th dimension. Already we have 3-dimensional vision. And an ultrasound probe in the rectum gives us a 4th dimension, telling us how far and how deep we can go when we're separating the rectum from the prostate, right? So advantages, definitely decreased blood loss, lower pain levels, faster recovery, shorter hospital stay, smaller incisions, lower complications, and better functional and oncological outcomes. And major advantage for the surgeons, if you make me do 3 laparoscopic surgeries per day, my back at the end of the surgery is gone. But if I do 3 robotic surgeries, I'm pretty much fresh. I'm sitting and operating. It's very comfortable position to operate as well. So it definitely works. And this is to show you what sort of uptake there's been 10 years ago. Currently, America has 4,000 robots. And how should India react to this technology? India is relatively late to the ball game. We are probably considered the late majority, but we're not in the laggard situation. America has 4,000 robots for 330 million people. India has 75 robots for 1.3 billion people. So again, we are definitely lagging behind the rest of the world. And the trouble because it is expensive, and there's a learning curve to it as well. So any complex procedure or technique has a definite learning curve, right? So this is the learning curve in laparoscopy. This is the learning curve in open surgery. And I suspect robotics is going to be somewhere in between. So it's important that people go through a structured training program before they go into, right? So the other important point that I'd like to mention is we're also running a fellowship. And this fellowship, we're training about 6 persons have passed through our fellowship. It's a 1-year fellowship for robotic surgery. So again, this is important. In order for India to become good at robotic surgery, we need more and more robotic surgeons coming out of training. So another important thing that you have to understand is it's not the machine alone. So if you give me the same car as Michael Schumacher, do you think I'll be as fast as him? That's not the point. You have to be a good surgeon before you go into robotic surgery, right? So that's important to understand. You cannot, number one, there's no shortcuts to a good surgical training. There's no shortcuts to being a good surgeon. You have to put in that many years of experience before you become a good surgeon, right? So again, there's a learning curve, decreasing blood loss, operating time less than 4 hours, decreasing positive surgical margins, and decreasing cochlear, around 200 to 250 cases you will have to go through before you become a good surgeon in robotic surgery, right? This is something that I'd like to emphasize. The robot cannot make an average surgeon a good surgeon. It's very important to undergo a structured training program and breach the learning curve before you become a good robotic surgeon. So one of the key points as far as India is concerned is affordability. If you look at any robotic surgery, it's going to be 1.5 lakhs more expensive than a conventional open surgery, because the instruments per case, each case, we have to pay to the company that makes the robot. So affordability is a key question. But I think when you look at affordability, you should look at how quickly the patients are going back home, how quickly their attenders who are staying with them in the operating room, in the hospital, they have an ability to get back to their routine quicker. All this needs to come into the picture, right? So if you have to maintain the same quality along with the, when you want to provide robotic surgery at an affordable cost, you have to have a high volume center. When you have a high volume center, we're able to give outcomes as well as bring down the cost for robotic surgery. That is what we're trying to aim and trying to achieve in Chennai Urology and Robotics Institute. Because if a technology has to touch the world population or our population, it cannot be the purview of only the rich few in any country. And then that means we've not succeeded in our goal. So if only the rich can afford robotic surgery, that is not the way to go forward. It needs to be accessible by the entire population that needs it. So that is one of the key goals that we are trying to get into robotic surgery. And before I finish, I must thank the organizers for this opportunity, and I'm happy to answer any questions that you might have. Thank you very much.
Hello.
Yes. Am I audible?
Yes, sir, you're audible, sir.
Yeah. Thank you very much, Sri Ramakrishna Garu, for a nice presentation describing the basics of robotic and advantages of robotic over open surgery and laparoscopic surgery. Yeah, it is still evaluating in India. Basically, the first it was used for carcinoma prostate, now slowly spreading to other diseases also, not only in the urology, in the general surgery also. Only problem, as you said, is the cost effective. So most of the corporate centers are having the robotic nowadays, but still most of the government sector is not having, sir, because it's a costly. Within next few years, I think it will expand to the government sector also.
So that is one of the reasons my hospital is not a corporate hospital. It is a single specialty hospital, a nephrourology hospital. And we are able to, less than 100 beds, but we are able to make robotic surgery work. So I think a lot of these 100-bedded hospitals, if they're able to get into robotic surgery, it'd be great.
Sir, it's a volume turnover is important, sir. Even the 100-bed hospital, if we do robotic surgery regularly, it is cost effective and affordable for the institute also. Sir, we had a nice presentation, sir. But as far as general surgery concerned, they say the results of the laparoscopy and robotic are almost the same as now. So I think time will tell us.
The important thing about laparoscopy and robotics is if there is an element of reconstruction involved,
yes,
then
sir.
Robotic surgery will score over laparoscopy times over. But if it's purely ablative surgery, then I think they're going to be more or less equal.
Yeah, because the magnification movement, wrist joint movements are better there. So definitely, and the surgeon also very much comfortable during surgery. That's the most important for us. Thank you. Thank you very much, sir, for a nice presentation, sir. Thank you very much.
Thank you very much. Thank you.
Thank you, sir. Thank you, Dr. Ananthakrishnan Garu. We would like to proceed to the next session. and the topic would be mind, body, medicine, and elderly. I would like to call upon Dr. YSSR Srinivas Garu. Sir, you're there?
Om Shanti.
Madam, good morning, madam. We are waiting for chairperson to join. A couple of minutes, madam.
Yeah.
Sorry for the inconvenience. Madam, Dr. YSSR Srinivas Garu would join us soon. I would like to introduce the next speaker, Dr. BK Umarani Garu. She is a doctor in naturopathy and yogic sciences, currently the executive member of medical wing of Brahma Kumaris, Hyderabad, and a senior resource person at Brahma Kumaris, Shanti Sarovar, Hyderabad, in charge of Brahma Kumaris, Malakpet branches, Hyderabad. She has an experience of 40 years practicing spirituality and yogic services, and her field of interest as values, spirituality, and meditation. Madam, I would like you to start your presentation, madam.
Thank you. Thank you, brother. Om Shanti. Can I please spotlight it?
If there is a presentation, please
Om
share the screen,
Shanti.
madam.
Good afternoon. Good afternoon. And my hearty, yeah. Shall I start?
Please start, madam.
Thank you. Good
Thank you, ma'am.
afternoon. And my hearty congratulations to all the organizing committee, which is a very wonderful and interesting subject today, that is geriatric management, healthcare of the elderly people. And why it is very interesting subject means it is going to benefit all of us first, irrespective of the age and profession. Every individual, like a king or the poor, even healthcare professionals and all the people in the society, we are going to enter into this phase. So anyhow, it is first going to benefit us, those who are participating and enjoying. So that's heartfully congratulate all the organizers for giving us all these benefits by organizing this. Some disturbance is coming, brother. Can I? And this is how, when the very, 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 very damaging and most highly risk phase, where we are going to face more and more uncertain, like traumas, physically and mentally, emotionally, more than physically. We are going to face more and more traumas in this phase of life. Like our 60s may not be, it is unlike like 50s and 70s, the same, 80s and 90s is unlike before the previous decade. So it's a very difficult task to manage for each and every person when we enter into this phase. So here we must be very much properly, very crystal clearly, we must design our future life, the remaining life, to enjoy it. If you properly manage it and learn how to manage this phase step by step, every phase is different. You see, 60s, 70s, 80s, 90s, more and more it is going to get damaged, deteriorated physically. Mentally and emotionally, I cannot speak like that. It is more and more going to get deteriorated. But the physical degeneration, we cannot stop for any individual, even if they are healthcare professionals also. But still, if you manage your mental and emotional traumas in a better way, and we all know that medical science teaches us prevention is better than cure. So it is better that this segment of people, this group of people, if they are educated in a better way before they enter into this phase, they can enjoy their life in a blissful way. So for that, we have to learn more and more. Not only this, okay, it's technically we have to learn all this, because the physical position of that person, people will be very delicate, unlike that youth stage. Very sensitive, very delicate. It is very hard, heavy risk for the professionals, healthcare professionals, to deal with that age group. And at the same way, the mental and emotional traumas are also going to create more and more physical traumas for them. And if somehow, if the people learn to avoid this mental and emotional traumas, like you see when that naturally the physical body's deterioration, degeneration, so they have to undergo that and they have to experience. But if they are trained well, if they learn how to manage it in a healthy, positive attitude, they can really enjoy that remaining life, and they can lead a blissful life, successful life also. And before they enter into that phase only, we must educate the society. So, but in that stage, they will have more and more anxiety, tensions, worries, stress, depression, very panic conditions. But to manage from all this, they need a lot of training. So they need to have more and more planning before they enter into this phase. So for that, how does this healthcare profession can help them it's also very much important for in the society everywhere. It is better to have some counseling centers for these elderly people. Already we have community centers.
Ma'am, if you are sharing slides, we are not able to see them.
Am I audible?
Yes, you are audible, but your slides are not visible.
Is it okay? Shall I continue?
Are you sharing something, ma'am, or you are just speaking? Are you sharing the slides?
Yeah. Shall I continue?
Ma'am, we can't see the slides, ma'am.
Am I audible to you?
Yes, you are audible.
Your voice is not clear for me.
You are audible, ma'am.
Shall I continue?
Yes.
So like when people enter into this phase, they will have more anxiety, more worries, more stress, more depression, and more panic conditions. And before entering this phase, if they learn how to manage this phase in a better way, so the remaining life they can enjoy very blissfully, successfully. So this phase, it leads the people to develop that social maladjustments because of the insecurity feeling. What expectations they have from their children have more expectations about their children, and when they become dependent on their children, and their children have more planning about their future of their children, so they move away from those people when they become dependent. And in such a way, in the relations also, they will have to face more and more trauma, the pain, suffering. And if they are well planned to manage all these things, how to face them in a healthy and positive attitude, in the relations also, and financially also, if they manage their life better before entering into that phase, they can avoid many types of relating stress and anxiety, worries, depression, and panic conditions. In that way, when they protect themselves from these all things, mental and emotional traumas, so then they can also postpone. We cannot avoid this physical degeneration, but at least we can postpone 10 years by managing our mental and emotional traumas. So for that, the most important thing is a person should have a better crystal clear planning of their future. A great vision they have to create, great purpose they have to create for this remaining life. Most important thing is all this time without a vision, without a purpose also, yes, the people can lead their life because they have professionally the career and everything, family life, everything fine. Without any planning also it goes on. But this phase, it is uncertain. They must be prepared and well managed to face these challenges. And for this, if we have a clear purpose and vision of our future life till the death, till the last breath, people plan for to live with dignity. In Brahma Kumaris, we plan for die with dignity. Even dying is also a part of living, So the end stage, the final, the last breath also, we must live it with dignity, with great satisfaction, with great contentment, with a lot of ecstasy and bliss. But how it is possible? It is not possible at all, but it is possible when our attitude becomes very positive and very qualitative thoughts towards our future of this phase. Very positive attitude in the sense we must create some affirmations about our day-to-day life. And if we try to churn and contemplate on those affirmations every day, So that itself can avoid so many incurable diseases when we awaken our inner powers, when we strengthen our inner powers by practicing guided meditation. So the guided meditation in the sense, so many healthcare professionals, they advise the people, those who are suffering with depression. These days, so many people, they are the software engineers, and many people, they come for this. Even in there was a lot of demand when there was lockdown. We can only arrange online classes, not physical, but still people were demanding to have physical classes. So, but to avoid that, even medical science also, we believe that yes, that relaxation techniques and practicing meditation, that is guided meditation. What is a guided meditation? In the sense in which we have visualization technique, not simply contemplating on the positive thoughts, but we must have a visualization, because our brain has that capacity, our mind has that capacity to like when we continuously create one sort of thinking process, highly elevated positive thinking, our brain has a capacity to create that neurological circuit. That neurological circuit, it is developed when we contemplate on any positive or negative thinking. The positive thinking, it will decrease this all sort of mental and emotional traumas. But the negative attitude, negative thinking, that negative circuit will damage, and it will lead to more and more diseases, to increase that. So for this, the guided meditation teaches us to visualize that all positive thinking, positive attitude towards your future life, the positive affirmations about yourself, about your family, and about your workplace, about your hospital, society, and nation, and our universe, to be a better place to live for all of us. So in this way, the healthy, it means it is heal thyself. Heal plus die. So if this process, healing the self means it is the higher self. When we try to heal this, the mind and our emotions, so definitely they will promote our physical health also, the growth, the healthy growth of healthy cells and hormones. So in this way, disease also, when we move away from our original nature of ease, to be at ease, it is the original nature of every human being. When we move away from our original nature of ease, our mind and our feelings and emotions, so then we become dis-ease. So that ease, that comfortability, that serenity, that tranquility, when we create in our inner space, in the higher self, in our mind and in our feelings and emotions, then definitely that is going to heal our physical ailments also. So this sort of vision we need to create in this phase of life, definitely one must have this. And it is going to promote our health. And it is going to protect us mentally and emotional traumas. So for example, for a small little story I would like to share with you. A young mother, when she was suffering with cancer, the doctors declared it is 6 months maximum she is going to live. So when she came to home, after a few days, after 1 month, her husband died in an accident. Then she thought that, why should I leave now? There is no support at all from my spouse also. And it's better to die, commit suicide, she decided. But when she saw the small kid, her child, crawling and crying there in front of her, that moment, there was a click in her mind that she thought it is, no, I will never die until and unless my child becomes grown up and he stand up on his own legs. Then that moment, yes, it made her to live. Till then, her child grown up and he was eligible to a job. And when he joined a job, then the third day she left her body. And it's all because of that new willpower which she developed. It was not that her cancer was cured. It was spreading all over the body. But she could overcome that and she could expand her lifespan so many years, not days. It's all because of that new willpower which she developed emotionally in her feelings. That strong affirmations, definitely, they are going to protect ourselves first. And then the society, we are going to help the family members and the society. First, we must need to manage that phase when we enter before that phase. So we should learn all these techniques. And for this, I must have these affirmations every day about myself, with my family, and my workplace and my society, the universe. The first thing is at least 7 times we must create in a day, and before going to sleep. And then when you wake up early in the morning, we must practice these affirmations. And then during the day also, nearly 5-6 times, if we can practice this, all sitting alone, sitting with you, and practice these affirmations. They are going to help us even now in this phase also, for everyone. And definitely, but with a vision you have to create. With a vision, you must visualize that. Even if it is a reality, your experience, or the imagination also. Our brain has this capacity, if you contemplate on that, it creates that circuit, neurological circuit, and that will protect us, that will energize us. If we become intuitive and develop that sort of positive attitude and vision purposefully, if we are living for that, to die with dignity, then definitely you will enjoy your life very blissfully, successfully, and you become role model for yourself, for your soulmates, and then younger generation also. Because the elderly people, those who come to our classes, their family members, the children come along with them to the center, and they say that, sister, we are very much inspired looking at our mother or father, at this age also, when they are facing the situations more than us, they are able to give counseling to ourselves in spite of giving to them. We are younger people, but they are able to manage their emotions and feelings, and they are positively giving us that to remain very happily in spite of facing all the situations. So in that way, we are very much blessed to have such parents, they say that, elderly people. So in that way, we can also lead our life very purposefully, meaningfully, if we can develop this visualization techniques in a guided meditation. In Brahma Kumari's organizations also, when people come here, one-to-one classes will be there, and we guide them how to create these suggestive thoughts for their for promoting their health, and to have a clear, crystal clear, purposeful vision for this future life, to live a successful life, healthy life till their last breath. The first thought early in the morning, first I must create that, yes, I am healthy. I am healthy. I am healthy. And in the silence, you visualize yourself that, yes, you are becoming healthy physically, mentally, emotionally. And I am wealthy. I have enough money. I am wealthy. I am happy. I am blissful. In the same way, my home is a healthy home, a wealthy home. My society, my workplace, a healthy atmosphere, healthy society. So with these affirmations, and before going to sleep, through the day also 5-6 times, we have to sit alone and practice this and have the visualization of this. When you visualize, the brain accept, the mind accept, and it creates the feelings and emotions. Then it leads to release the healthy hormones in our body. That is the thing. So that's how, before going to sleep, okay, whatever the destructive things emotionally, mentally, and physically, whatever happened is happened, put a full stop to that. And try to eliminate all those toxins, toxic thoughts, toxic feelings, and even accumulated toxins from the body. They are all eliminated from my body, from my mind. Visualize this, visualize this. Contemplate and visualize. When you visualize, you feel it. Your mind will create the feelings. And that feelings will become emotion. E plus emotion, energy is in motion. When that energy, it forms that emotion, then it will circulate into each and every body and cell and tissue of your body. And then the healthy hormones, promoting hormones are released, and it promotes us to get relief from the pains, stress, anxiety. So like this, we have to practice these affirmations according to the guided meditation. If the people come to the centers, meditation centers, so definitely they will be guided towards this aspect, how to develop a strong willpower, create a crystal clear purpose, vision for our future life. This ways to manage till the last breath. With that positive attitude, be prepared for that also. The last breath, how I'm going to live my body. You design it for yourself. You design it. And according to your vision only, you are going to, yes, live your last breath very successfully, very happily, in a very peaceful manner. That's enough. That's it. It's a successful life till the last breath. Thank you so much. Thanks a lot for giving me this opportunity.
Thank you, Dr. Umarani. That is excellent talk. How to be happier. Happy is the most important thing in life. So when one is happy, then health and wealth automatically will come to the person. You have very well told about all this importance and how to achieve it. Thank you, Dr. Umarani, madam, for coming and giving a very such a beautiful lecture.
Thank you. Thanks.
Then moving on to the next topic, Dr. Prasoon Chatterjee, sir. So he is going to talk on how to be a super ager through the life course perspective. So Prasoon, sir, are you there? I'll read out the biodata of the Dr. Prasoon Chatterjee, sir. Dr. Prasoon Chatterjee is an additional professor working at the Department of Geriatric Medicine in All India Institute of Medical Sciences, New Delhi. He has been selected as a global expert by the World Health Organization for working with policy and research implementation for healthy aging decade 2021 and 2039. He has more than 10 years of teaching, clinical and research experience at AIMS as a senior resident and faculty. He has several innovative research projects in the field of geriatrics and gerontology and diagnostic assessment of dementia for Longitudinal Aging Society of India, LASI. Cognitive impairment being his primary research area of interest. He has also carried out many cutting-edge researches on frailty, falls, and intrinsic capacity and community geriatric. Bearing in mind the importance of preparation for active aging, he wrote a book by title Health and Well-Being in the Late Life. Okay. So, a narrative in India published by Springer Nature Singapore Private Limited. Dr. Chatterjee worked with the World Health Organization of Regional Office for Southeast Asia as a consultant in the division of MCA and was involved in the preparation for the ICOP manual for the nurses, trainer's handbook, and primary care physicians, health status guide. And I also say that I invite Dr. Vijay Mohan sir is added now, and he is going to chair the rest of the talk of Dr. Prasoon Chatterjee. Thank you. Welcome, Dr. Vijay Mohan sir, and take over. And Dr. Prasoon Chatterjee will start his lecture. Dr. Prasoon Chatterjee sir, are you there?
Hello.
Hello, sir.
Hello. Dr. Prasoon available? Hello. Dr. Prasoon, are you there?
So sir is facing with some laptop issue. Soon he will be joining us. Prasun sir is having some problem with his laptop. So bear on, within couple of minutes it will be solved and sir will be joining.
Yeah, till Dr. Prasoon joins, thank you again, GERICON, for having me here. Again in the afternoon session, Dr. Prasoon will be joining us very soon, who is the speaker for today. And his topic is how to be a super ager through life course perspective. Super ager, without wasting time till he joins us. Super ager, that's quite a new word for many of us. Super ager, who is a super ager? Super ager is the one person who is 80 plus, but his memory, his cognitive functions are as good as a 50-year-old person. That is the super age. Most of the senior doctors that we have who still are with us, and then they actively participate in the academic discussion, they are actively participate in the treatment of the patients. And similarly, we have many political leaders, IAS officers, heads of the state who are still 80 plus, and they do a wonderful job. So this kind of special group of people are called as super agers. So Dr. Prasoon will highlight what is the super ager, how to live through, how to become one. Everyone wants to become a super ager. So let us see what is in store for Dr. Prasoon. Dr. Prasoon.
He has not yet joined, sir. You can join us. We can listen, sir.
Yeah, I think we don't have Dr. Prasoon still. I think he will take a couple of minutes more. Lifespan, as you all know, compared to last century, it has been significantly increased. The human lifeline that in the palm also is lengthening. Compared to the yesteryears, the average human lifespan has gone up significantly from 35 to 45 to 65 to even now 75 plus now. In some countries like Japan, the lifespan, the average age also is on the increase. You see a lot of 100 plus people walking on the road if you go to Japan. So if this trend continues, no wonder the same trend, the same pace continues, increasing the lifespan. A child born today is going to live up to 100 years. And recently you've seen the article that they're also working on what is the aging gene and how to moderate that, how to modulate that. And they're looking at human age of 150 plus or 200 even. We have heard in our mythological story that those thousands and lakhs of years before, people lived up to 200 and some say 1,000. Ravanasur lived for 10,000 years, it seemed. So that is what super agery is all about. And if Dr. Prasoon is there, I'll hand over the mic to him. Did he join?
Not yet, sir.
In the meantime, I think until we get him online, anyone wants to say anything on this topic, super aging, super ager, anyone, just to fill the gap of time. Dr. Chandrasekhar, if you're listening to me, can you just look into the matter, please? Or we can go ahead with the next talk. The speaker didn't join yet. Speaker joined.
Link was there in the website. Now can you see me? It is in Pratik, my son name. Let me rename it. Dr. Prasun. Rename.
Hello.
Yeah, hello.
Dr. Prasun.
Yeah, I'm very sorry. There is a lot of technical issue. That is the problem of virtual world.
I can't hear you, Dr. Prasun.
Hello. Can you hear me? Hello. Link was there in the website. Now can you see me? It is in Pratik, my son name. Let me rename it. Dr. Prasun. Rename.
Hello.
Hello.
Yeah, Dr. Prasun.
Yeah, can you hear me now? Yeah, hello.
Yeah.
Yeah, I'm very sorry. There is a lot of technical issue. That is the problem of virtual world.
I can't hear you, Dr. Prasun.
Hello. Can you hear me? So, hello.
Yes.
Now can you?
Yeah, we can.
Can you see me?
Yes.
It is in Pratik, my son name. Let me rename it. Hello. Dr.
Resound.
Hello. Hello.
Yeah, Dr. Prasun.
Yeah, can you hear me now? Yeah, hello.
Yeah.
Yeah, I'm very sorry. There is a lot of technical issue.
Hello.
So there may be issue, I think. So announce that.
Hello.
Hello. Yes, Dr. Prasoon.
Now I think it's fine, huh?
Yeah, it looks okay. I think you can start now.
Yeah.
Okay, go ahead.
So allow me to share the screen.
Yes, please do. Share the screen.
He has to share. He has to do.
Yeah. Dr. Prasoon already introduced you and said few points about the superedger and all those stuff. You can go ahead straight away. Yes, Dr. Prasoon.
Yeah. Now I think it's fine, huh?
Yeah, it looks okay. I think you can start now.
Yeah.
It's coming again and again, resound.
Yeah. So allow me to share the screen.
Yes, please do. Resound. Same thing is being recorded and resounded. Yeah. Dr. Prasoon already introduced you and said few points about the superedger and all that.
Hello, Prasoon sir, you have opened two devices in your system. One is delegate link and one is
I think you can start
the
now.
other is like speaker link, Zoom link. So
Allow me to share the screen.
Yes, please do. Resound.
అవును sir.
Same thing is being recorded and resounded. Yeah.
ఒక్కసారి like if now it stops sir.
Now it's coming again. Can you try now? Can you start, Dr. Prasoon? Say something.
మన దగ్గర లేదు కదా. Sir, please unmute sir. And before unmuting, request you to please close that window of the like Google Chrome which you have opened delegate link. Wait. There will be some connectivity problems. Gautam, హాలిడే చూసుకోపో కొంచెం. Oral presentation. చూడు అడుగు అక్కడ. ప్రసన్న సార్ కాల్ చేయండి కదా ఇంకోసారి.
Hello, Dr. Prasoon. వాళ్ళు రెండిట్లో లాగిన్ అయ్యారు సార్ ఒకే బ్రౌజర్లో.
Hello?
Yes.
Now I think it's better. I hope.
Yeah, Dr. Prasan, we can't see you.
Yes, sir.
I'm trying to check.
Yeah, checking.
My deck is.
Yes, sir. I'm having this, sir. Right, sir. అయిపోయింది అక్కడ లోపల మీరు ఏం చేస్తుంది
Dr. Prasan.
Yeah, I'm just opening it.
Yeah. You are from Kolkata, Dr. Prasan?
No, sir. Originally not from Kolkata. It's Bolpur Shantiniketan.
Oh.
Bolpur is a little far from Kolkata.
Okay.
But yeah, still you can say. So it's already late, so I'll not take much time.
Sure.
I think this is great to see that this team is doing well, and thanks for inviting me. So I'm additional professor in AIMS, and that. Sir, can I start?
Yeah, please. You're audible and visible too.
So superager, this concept is an achievable notion. It is no more something like this cartoon that like Superman. It is very much achievable provided we follow some strict lifestyle. Of course, there is some role. I'll say some very minimal role of your genetic makeup, your longevity, your family, and etc. So can you be the next superager? And aging starts from the day one. I am also aging, you are also aging, everyone is aging. This middleman is Mr. S.S. Rudra. He's a person who is at the age of 93 and very close to me. So I'll just say quickly some psychological assessment tools. CDR, we assess cognition, dementia. CDR is one of the most valuable. CDR 0 means your brain is normal. IQ, you can understand 114 by 130 is extremely great. Boston naming test, naming is one of the component of your brain. RAVLT is recall, again 11/15. Calatrell was excellent, 42 second. I checked for myself, it was also nearing the same. Extraversion is one of the personality trait, tendency to experience positive emotion. In our study, I'll come later. We have maximum people has extraversion. Neuroticism is also there, which is again a component of your personality which will be there, but extraversion is more, which is definitely positive. Similarly, conscientiousness, again a personality trait which is common among the superager, which we have seen in this person who is very careful, diligent to do task well. He's a person who has been, if you see his life history, he has been forced to come from Pakistan to India, then working here and there. Then when he was working in some shopkeeper as a attendant, he started his studying. He completed his BE in a very late age. Then he joined job. Then he retired as executive engineer. His lifestyle is excellent. He has lost his wife almost 15 years back due to cancer when he served her. And now he's staying with his family, obviously joint family. He has almost 4 generations. You can understand someone who is 93 is seeing and enjoying life with 4 generations together. Uh, but great thing is he's always there, even in the at this age, to visit and help anyone in need, and always happy, always smiling. Ups and downs are there. He has suffered from milder form of infection, not COVID, and he stays in a small apartment. And when I ask in Hindi, we ask, but I'll translate that in English. Sir, what are you doing? How are you practicing your exercise? He exercise for last 60 years, you can say. There is a large park in front of his house. He works, he does yoga, resistive training, and my patient for last 10 years. So he told, I'm not doing much, but yes, I'm taking 10,000 steps per day. So just imagine, I can tell all of here, including us and audience, how many of us takes 10,000 steps per day, even during COVID crisis, and he does it in fragmented manner, not at a time, and always smiling and trying to help others. This is the criteria, and you can see his score. He's actually superager. So why we are talking about superager? This is nothing to say in a geriatric conference that life expectancy is increasing. We have somehow achieved better quality of life, who are living longer. We have taken care of functional capacity. We call as intrinsic capacity, mental, physical strength. But independence and dignity is the priority, which is very important for all of us till death, which deserve we also deserve. So how to define as per literature? Superagers are 80 plus with episodic memory performance that is at least as good as what would be considered typical for 50 years, determined by chronological age and neurocyclical performance. So we can say that we have managed to take care of our brain as good as someone who is 30 years younger than us. What more you want? So that is I think target or vision. That should be the vision for all of us, right? To be a superager. What classify a person as superager? If I say from cognitive standpoint, studies have shown structures of superager brain connectivity, neural connectivities are maintained as just like young adults. According to functional MRI study, the superager had maintained the same high level of neural differentiation, connectivity, and networking, which is very important. So studies has found that some areas of brain appear thinner, an indication of cell loss, which is again common. I'll come to that later further. From biological standpoint, some studies have indicated that people in their 80s who exercised at high intensity are better with having a good amount of aerobic capacity. Resistance, they have more resistance towards tau degeneration to the cortex, and their brain exhibit less volume loss, which is actually common with aging. So, as we get older, this is again a fact which has been studied. This process of shrink of our brain accelerate. So brain weight decreases by 5% per decade after 40. So even I am on that age now. So the frontal lobe, the hippocampus, the two primary area for our brain function related to memory encoding begin to shrink mainly after 60s or 70s. So the importance of education and lifestyle, there are a lot of studies on that. Some people are born with genetic advantage, which I will say is a very less percentage, but specialists estimate that our genes are responsible only 20 to 30%, even lesser than that, and you can modify that through lifestyle, exercise, and a positive attitude. So again, structure of superager brain, and as I mentioned, they resemble closely with young adults. And the study also shows that the larger annual cortical volume loss over 18 months than superager. So studies have shown that 18 months follow-up studies has shown that someone who is a superager, their volume loss, cortical brain volume loss, is lesser as compared to anybody who is a typical elderly. We call as typical elderly, who are not superager but 80 plus. We call as typical elderly. So a Harvard medical study shows that thicker brain cortex, they have a thicker brain cortex. Superagers have a thicker brain cortex than same age peers with average for age memory. Again, their neural differentiation, as I mentioned, is better as compared to typical older people. The study also suggests that the same thing I'm repeating. You can see here young and old. You can see there are a lot of volume loss in old people as compared to young, but in case of super ager, you will see the picture like MRI picture will be like this as compared to the old people. You can see there is a lot of shrinkage in the volume, so that only the ventricle get dilated. Study Godoy et al. In 2020, just this year, they published that superager present excellent memory, best performance, and reflect resilience to the conventional pathway of aging. In pathway of aging, we are showing few only regarding tau tangles, amyloid deposit, thinning of the cerebral cortex, volume loss in the frontal lobe and hippocampus. But there are many more mechanisms which is biological, molecular, genetic, epigenetic, mitochondrial dysfunction. I will come that we are fortunate to do similar study here now in. So cognitive functioning remains stable with age in superagers, whereas non-superagers demonstrate decline overall cognition with age, which is significant. You can say memory task performance and demonstrate similar discrepancy in trajectories. So what all can you do to be a superager? Gene, no, you cannot change. Environment, you cannot change. But what we can do, you can have a healthy and active lifestyle. Definitely, we can have a healthy lifestyle. You keep pushing yourself to new height, at least for your brain as well as physical activity. Interact with others, family member, friends. Of course, joint family is much preferable. You have to be like social butterfly. Society. Our interaction with aging, with the society, with the people should be much more as compared to when we are young. Indulge in various activities and hobbies. Start learning new skill, reading book, writing things, learning language, using your left brain if you are a right-handed person. All this matter. Of course, limit alcohol intake. Studies have shown moderate alcohol intake prevent dementia. Even if as a doctor, I always care to say this, red wine in moderation, it prevents dementia by 23%, which is a great number. But again, if you cross the limit, it will fasten the development of dementia. So as I mentioned, I'm fortunate to have a great grant from ICMR, the apex body of apex research of India, where I am trying to work on characteristics of Indian superager, a prospective core study with a potential future predictive model. Why? Because most of the studies has focused something very hi-fi, genetic makeup, amyloid deposition, tau deposition, which layman doesn't understand. But what actually makes you superager? We are working on that. Here we have reduced the age from 80 to 75 because usually for us cutoff is 75 for oldest old in as per UN definition. So aged 75 and up in the study, typical older adults, superager, as well as another group, individual 25 to 50. So our control is 25 to 50, and we are comparing by, as I mentioned, there are many things, psychological tool, detailed history. We are taking a history of life course starting from birth to till 8 years, whatever they recall, whatever they memorize about their diet, their education, their hobby, their happiness quotient, their life satisfaction. We are taking a battery of tests which takes almost 3 hours time to assess. Then some blood-based biomarker, FOXO, which are proven concept for aging memory, dementia, but no research has been done related to this for superager concept. ApoE, SERTWIN1, we are working on this marker. fMRI, functional MRI shows there is differences between typical and superager in especially cingulate gyrus and hippocampus, which matters most, and life course perspective, which will be most important. My target is to create a tool to say this: if this is your lifestyle, you have a chance to be a superager, which should be the purpose for all. Test we are doing, as I mentioned, VAS-4 is basically for your IQ test. RVALT, through this we check your overall memory and like your and CTT, more of recall and episodic memory. CTD is basically for your attention concentration, BNT, and even neopia. Neopia is your personality. Personality matters a lot. With aging, you will see many people are very they are agitated, they don't behave properly. So this matters, and personality we develop much early. Maybe you need 30 years effort to modify your personality to be more towards positivity. So the study, we have progressed very less as compared to we promised because of this COVID crisis. Getting elderly people at in hospital, bringing them from community is really difficult now. So as I mentioned, we are doing CDR, and we have characterized 6 categories of cognitive and functional performance relevant to Alzheimer's disease. These I have already mentioned. So far, we have 42 people have been recruited for the study, 23 control and 19 older people. Out of this 19, only four has been fulfill the criteria to be a super ager. You can understand it's not so high prevalent, but yes, there, as I mentioned, I started with the one example, Mr. SS Rudra. I don't think formalizing our life wherever, in which position are we today, irrespective of our age, even if you are 60, even if you are 40, even you are 20, start practicing to be prepared to be a super ager, which is very much possible. As I mentioned, what we saw is this super ager who performed collectively on all tasks as good as young adults control group. They have demonstrated significant level of extroversion and conscientiousness, which is a characteristic of a positive character, more of personality, as I mentioned. So this is our finding till now. And my last slide, this is a graphical representation. This you can see, this is basically a color trail test A, B. This is 2 color trail. This is for young control. This is for typical older adults, and this is for super ager. You can see this is a super ager. You can see the height here, super ager and the young adult are reaching same. So color trail that shows the speed, your cognitive speed basically. So cognitive speed of super ager is as good as someone who is young as compared to typical elderly. They have much less as compared to the super ager. So it is a very, I'll say, still it is a complex topic, but it is achievable. We have to generate evidence to create some predictive model to say that it should be imbibed in your practice. But yes, you continue your education to improve your cognitive capacity. Your cognitive reserve has 2 variety. One is quantitative, is qualitative. One is dynamic, one is static. So that is a huge discussion. I believe I'll not go in detail. You work on your exercise module. Physical exercise is a must. It's not only for cognition. That is the only thing which prevent the decay, the cumulative deficit we call it as aging process. So biological aging. So you can stop that. You don't smoke. Have healthy diet, many diet, Mediterranean equivalent diet. We have done another study which is under publication. Work on Mediterranean diet. You can do that. It can be achievable and practice. You can practice. Work on your brain, stretch your brain as much you can. And last but most important is engage yourself purposefully, irrespective of your age. Do something for others. So help others. That gives lot of happiness. We are working, but yet to conclude whether life satisfaction, remember life satisfaction and quality of life is different. You may have a good quality of life. Quality of life is a very cross-sectional view, whereas life satisfaction is a prospective and retrospective combination view. It is a wholesome approach. Is called life satisfaction. You have to have life satisfaction in your life at any of your age. All matters to be a super ager. So these are my reference. I'd like to thank my all project staff who are working very hard for this project to make it successful despite the COVID crisis situation. And this is my book, has been published almost 2 years back. I have already written something about super ager here, and I'm writing my next book on dementia where I'll try to cover maximum about super ager. Thank you. Thanks for the opportunity. I'd love to have any question you have. I know I'm late for some technical glitch.
No, it is still worth, Dr. Prasoon. Your lecture was fantastic and something different from what you hear every day as a doctor. It was very nice, and the very concept of super aging and all, you have enlightened very nicely. I have a 1 or 2 small question. You said there's a 5% decline in the brain sinks by 5% after 40. Is it per year or what? I couldn't quite catch it.
Decade. It's decade, sir.
Decade. Oh, okay. Decade.
Yeah.
And you also mentioned that typical elderly and we have to be social butterfly and all. I like those phrases that you use. Anyway, anybody has any questions, please, you can go ahead. Dr. Prasoon, why is ethnicity and in geographical division part in this super aging? Because in countries like Japan and all, you see a lot of 100 plus old super agers walking on the road, almost as a typical daily scenario. But do you think that any similarly we have Sweden and other Norway and Sweden, the life span is little more compared to others. Do you think that geographical area plays a role in aging?
So definitely, because there is a concept called blue zone in the earth, which I have discussed a lot in my book, where the average lifespan is blue zone is in 5 zone in the world, mostly island, Japan, few area in Japan, few area in Italy, few area in America, in Australia. So why their average life expectancy is in 100 years? Because their lifestyle is such that they have to exercise, they have to hike. Suppose someone is staying in hilly area, every day he has to come down to take some vegetables. And another thing, so which is important, which is unfortunately missing from our culture, is joint family culture, connecting with young generation, interacting with them, interacting with peer group. There, I will say, much better social butterfly than our people who after retired constrict them much more as compared to they were socializing better when they were working. But that should be the reverse case. They should socialize further, learning new things. Very rare people in our country. How many of you have heard that 80 plus has started learning music, started painting? So again, I have discussed in my book. If you get opportunity, health and well-being in late life, you can just read it. Successful aging. There is a chapter where I have given a real life example that someone who is stretching their bend, because learning new things, I know many people has learned many things during this COVID crisis also. They couldn't go out, but they were learning. So your overall, coming back to your question, ethnicity and the practice, we create age friendly environment. The WHO specific term is called age friendly environment. So we as a society, what positive things we are giving to the elderly people to age gracefully, successfully, and to be a super ager? And this is, I'll not say it is a very different concept than a longevity, because anyway, who is someone who is 100 years definitely will have, as I mentioned, 92 years super ager. Definitely he has overcome vascular disease, he has overcome cancer, he has overcome some accident till death, so that only they are super ager, they are achieving that level.
Dr. Prasoon, the way the human life expectancy is increasing compared to yester century, do you think that a child is born today is going to live up to 100 plus? And what is young, what is middle age, what is old age now, latest definition?
Sir, I will definition. I will not go by chronological definition. More important is to have a biological definition. Our next study, what we are doing is biological. Few people has defined as a epigenetic clock, where we want to see the DNA methylation. DNA methylation is a very good marker to say about biological aging. If I give example, like Mr. Modi, who is our prime minister, he is 70 plus. As compared to him, anybody you see 70 plus who is staying at home, doing nothing, no engagement, no socialization, no vision, no mission, no aspiration, definitely Modi ji is doing much better. Apolitically, if I state that person, he's traveling so much, he's speaking so much, he's creating so much, he's speaking in multiple language, he's learning because he has a mission, vision, goal, and aspiration. But point is, with aging, we have to create a purpose in life. Purpose has to be a purposeful engagement has to be there. That decides many things.
Excellent, very good. Any questions quickly before we thank Dr. Prasoon? There are no questions. Prasoon, thank you very much for a wonderful talk. We'll meet you. Please come to Hyderabad. We'll have a meeting here with you. Thank you. It was so exciting to learn so many good things from you. The different topic. Thank you very much. Take care.
Thank you, sir. Thank you, Dr. Prasoon.
So I can
short lunch break and we'll see you at 2 p.m.
Yeah.
Sir, you can start the session.
Can I start the sessions?
You can start the session.
Is the moderator ready now?
Moderator, Madhu Babu, sir.
Yeah.
Madhu వచ్చారా?
అది కూడా మేము మాట్లాడి టానిక్ మాట్లాడి taxes లేకుండా క్యాష్ పే చేసి ఇస్తాం. సో దట్ వి సేవ్ our people relax because we have to otherwise there is no
బాలసుబ్రహ్మణ్యం సిబిఐ బెట్స్ స్పీకర్ ఇదయ్యా రిడిక్యులస్ ఇది లాగ్ ఎట్లుంటారు మీరు సీనియర్ ఏది
Hello, is the technical team online?
Sir, good afternoon, sir. I'm Dr. Krishna, sir. You can start the presentation, sir. There's a little delay with the...
Right, okay.
Right, sir. Please start off the presentation, sir.
Thank you. For some reason, I couldn't put the background because it's giving lots of...
No issues, sir. Please go ahead, sir. Thank you.
Help you with that. So, first of all, thank you for inviting me to talk in this esteemed conference. I'm very honored. And so I thought to change the title a little bit differently. So common skin disorders and elderly for the geriatricians. I think there is no point talking about the full skin conditions where it may not make much sense to the geriatricians or any use. So I'm going to talk about a few skin conditions where the geriatricians play a significant, if not more role than the dermatologists could do. So I think patients would benefit from your input here in these conditions. So let's talk about a few things. So before we begin with the pathological changes, what are the physiological changes we observe in the elderly? The skin goes thinner. I mean, it goes much thinner. We can easily identify in the form of barrier dysfunction. So, and also it loses the elasticity. So skin become more loose and easily bruised because of the no support in collagen and the elastic tissue in the dermis that leads to bruising and fragility. So you can easily peel off. And also reduces the sebum production. The grease production leads to the dryness and skin becomes very rough and scaly And the skin also pigments very unevenly. So you have a more salt and pepper appearance in the elderly population. And also have tendency to develop lots of benign tumors like seborrheic keratosis, warts, and DPN around the face. So these are the normal changes we observe in elderly skin. So this is just a diagrammatic representation of how the skin can be displayed in a cut section. Although the fat layer is not clearly shown here, but you can see clearly the epidermis gone thinner, very rough, and the collagen is getting more broken down. So that's the reason for changes we see clinically. So we'll talk about something called pruritus. I mean, you all heard of the term pruritus. It's an unpleasant sensation which provokes the desire to scratch. I mean, it may simply say it's itch, but in some cases it can give severe symptoms enough for the patient to thinking of suicide. So pruritus can be a very unpleasant sensation. So let's talk about what are the main focus of the condition that give us the pruritus. So one is pruritic receptive. That's we talk about mainly as skin disorders. Let's leave that for this talk. And then 3 other areas: neurogenic, neuropathic, and psychogenic. Let's talk about these 3 domains and see how we can help our patients. So neurogenic is essentially each originates from underlying medical conditions like a hepatobiliary obstruction that leads to the bile salts and other toxins and build up in the system. And second is a common one is a renal dysfunction. So any renal abnormality will see patients present with dryness and intense itch, which may be sometimes main focus of the patient rather than a renal function deterioration. Thyroid disease, we all know thyroid disease can cause a dryness of the skin, itching. Both hypo and hyperthyroidism can cause neurogenic itch. Malignant diseases like lymphomas or even solid tumors can cause significant widespread itching. And medications. So we know that most of my elderly patients on at least 1 or 2 drugs, and some of them are several of them. So it's better to read and understand about the medication that can induce the unpleasant symptom. So clinically, what you can see, you may see a small patch of inflammatory skin changes, as you can see the left side of the photograph, or it can be completely lichenified. You may not see much of excoriations, but skin goes thinner, inflamed, and cracked, and that may be the presenting sign. Or you can have continuous damage to the skin from the scratching. So you can see a lot of excoriations along with the lichenification. So these are the typical findings you see elderly, which depicts the severity and extent. And it can be localized. So some patients will have localized symptoms, although the symptoms can be widespread. The designs can be localized, as you can see here. Skin is very thickened, lichenified, and very dry. And the white discoloration you see is a purely dead epidermal skin buildup. And you can go to the level, you can even give suspicion could be underlying by skin malignancy like lymphomas, but actually just purely a thickening of the skin from the scratching itself, driven by underlying medical illness to scratch. So what are the neuropathies that may contribute to the itch itself? So some of the central nervous system abnormalities can drive the patient to have itching, like brain tumors, although it's a bit rare. And main focus would be the peripheral nervous system. So common one being diabetes mellitus and herpes zoster. Now you might ask, what's the herpes zoster do with the itching? So these neurological disorder, particularly infection-induced damage to the peripheral nerves, can cause incessant itching, burning sensation, and pain. And diabetes mellitus, you all know that it can give all sorts of peripheral neuropathy symptoms. And entrapment disorders like brachioradial pruritus, that as the name defines, it's a nerves get trapped in the cervical vertebrae. They can give quite a lot of symptoms, and often very little to see in the skin, but you will see the itchy sensation can drive them mad. Similarly, a specific entrapment disorder is called notalgia paresthetica. Again, your tiny cutaneous nerve get trapped and give symptoms. And these patients can easily present with a geriatrician like yourself, well ahead of the dermatologist. I think it's a good opportunity for you to intervene, investigate them, because you know full history of them, you know full medications you prescribe, you know much more about those medications than I do. This is a couple of photographs I'm going to show you on herpes zoster. As you can see, the patient can present with a pain and itch and crawling sensation first before they blister up to to produce blisters like this. So this is a great opportunity as a geriatrician to intervene with the acyclovir or similar antiviral medication like a valacyclovir, or even starting on someone like a someone with a gabapentin or pregabalin. So the early intervention is a better outcome with the neurological damage. And the right side, as you can see, patient can get complicated with infections. So that may be the driving point by the time they come to the dermatologist, but they may present with you headache, pain, itching, and together. So this is a typical example of a brachyradial pruritus. You can see the patients are scratched on the radial aspect of the forearm and the arm. And this simply tells us the patient's got entrapment disorder of particular teres nerve. So often due to the cervical spondylosis, which may go unnoticed in some cases, or you may have other symptoms to show, like pain and shoulder pain, which you may be able to diagnose that. But again, this is one of the area where you may know the patient well ahead of us. This is a very unique condition where the patient have itch sensation in particular parts of the back. You might have probably seen it and you probably not given much thought about it. This is typically an entrapment disorder due to tiny cutaneous nerve, which some reason takes the longest course before supply that particular area. It can be both sides, it can be localized. Usually you see a pigmentation from the incessant itch. So patients like this may not come to a dermatologist, or you might be the best person to notice it when you examine them. That question is simple advice on topical therapy like astringents or any antihistamines or other methods to reduce the itch sensation would be helpful for these patients. What about psychogenic? I mean, I listened to the talk earlier on about the super aging, and we are getting patients older and older, and we are getting in a society where patients live alone. And our cultural dimensions have changed over the last 30, 40 years. We can be more westernized. When more we do, more we become lonely. And more we lonely we get, anxiety and depression can set in. And also social stress. They cannot or may not be able to adapt to the modern society that we are transforming ourselves into. And our development of various illnesses, longer you live, you're likely to get more of the illnesses. So these all lead to the psychogenic stress, and patients present with itching. So itching may be the presenting case, but if you explore more, you'll find they have more to offer to diagnose and treat. So the treatment may be entirely away from the skin, maybe something to address the social stress, maybe to give a treatment for anxiety and depression, maybe to address the underlying illnesses they may be worried about. So psychogenic pruritus is again increasingly common now. So the presentation in the skin point of view may not be straightforward, oh, I have itching. They may present with conditions like this, which is very typical location for psychogenic pruritus to occur. One is the back of the neck, which often look like psoriasis. People diagnose psoriasis, but you find them anywhere, you don't see any psoriasis elsewhere. Another one in men, particularly, to have significant lichenified dry skin in the scrotum. I mean, this is not the primary pathology. Primary pathology is somewhere else in a systemic disorder or a psychological disorder, which you guys may be able to identify and treat well before this happens. And another case, for example, you can distract patients, other clinicians, like a hypopigmented lichenified skin, but is purely driven from the psychological itch sensation that driven to them produce such a damage in the skin. So what investigations would you do as a geriatrician? I mean, full workup with the hematological test, particularly focusing on iron studies and immunological tests, and the thyroid particularly needs more attention because thyroid illnesses can be quite subtle, and particularly we don't have other clinical signs. So I think full investigations in this regard are needed. And if you suspect possible lymphoma or underlying solid malignancies, imaging as appropriate, you can perform. But in most cases, I think the biochemical workup and hematological workup would be sufficient to find any underlying etiology that may drive them to having that itch. So how do you treat them? I mean, these are before you come to dermatologist. I mean, treat the identified deficiencies. If the iron is low, and from iron supplements, or maybe you give advice how to increase the iron in the diet. Maybe go to green vegetables, maybe red meat, maybe if they are not eating much. And review the medications, go back and look at the list. Now, sometimes so many medications in India, I see that given in combination medications. So they may be taking over-the-counter medications without telling you about the new drugs. So I think particularly opiates, statins, aspirin, all those things can intense age throughout the body. So I think reviewing the medication is vital in this age group. And encourage them to use liberal emollients. One thing I observe when I visit regularly, the quantity of the emollients available to the patients is much smaller. So they often give smaller containers as charge quite a lot of money. So I think if you encourage them to use liberal emollients like coconut oil or old-fashioned water, is good enough to give reasonable hydration in a very cheap manner. So I think you ask them to use to the level the skin should feel wet. Other than that means they're using emollients properly. And also look at any antihistamines. I mean, any antihistamine is going to give you antipruritic effect. They have to do that through the sedation. So in modern antihistamines, like non-sedating antihistamine, like fexofenadine, no use in pruritus. So you have to give something like chlorpheniramine or hydroxyzine if you want to give antihistamine effect and the antipruritic effect. And of course, gabapentin, amitriptyline, pregabalin can be used in a judicious manner so that they don't get drowsiness at the same time, get the benefit out of these medications. Now, let's look at some common eczemas in elderly where you have significant role to play. Someone is in the background talking. Is it possible to mute? Thank you. So one is eosinophilic eczema. This is again increasingly common and very common in elderly simply due to the various changes in discussed earlier on the physiological and also common to have pathology. So one is the protein deficiency. Albumin deficiency leads to edema of the legs. That leads to the cracking of the skin. And any disorder that makes the skin go thinner, for example, COPD or asthma, or any disorder that require oral steroid in high doses. So these means the patients will have more thinner skin, and in the combination with the albumin deficiency, it can lead to dry stretching of the skin and cracking. And they are intensely itchy. But
sorry, Ramkumar Kattam, can you mute your mic, please? Ramkumar Kattam, can you mute your mic, please?
Thank you, Magesh. So the skin can be intensely itchy, but will less to see on the skin. I'll show you a photograph here. This is a typical example. Of course, I'm showing a picture of a wet Caucasian skin, but it's not far from what you see in other skin types too. But the main thing is you see the crazy paving appearance. So the skin is cracked, a little bit inflamed, a little bit pigmented. Otherwise, you don't see much of oozing, much of eczema findings. You see any other type of eczema, but this much symptomatic. They will be dry, itchy, and then even they present to you with the different illnesses, they may have more symptoms in the skin. So I think as a physician for the elderly, you have a great role to play and much simple to do. I'll tell you how to do that. So treat the underlying cause. Of course, easier said than done in an elderly with the multiple comorbidities. So try your best to address the hypoalbuminemia, cardiac failure, liver failure. But once that's taken care of, the easy way to address them is a low potent topical steroid ointment in a thicker application. Every word in this line is vital. It has to be low potent rather than give you much more high steroid, which will thin the skin furthermore. It has to be ointment, not a cream. It has to be applied thinner, thicker, so that the patient have the cracks are sealed, and also anti-inflammatory effect is achieved, and they will heal quickly. So now getting hold of such preparation in India can be a task, because I see modern ointments are promoted and sold, but the old-fashioned low strength ointment will be sufficient. If you can't get hold of, get this higher strength version and ask them to mix it with petroleum jelly, will achieve the same effect. And emollients wise, go for more oil-based emollients like a coconut oil or petroleum jelly-based one like a white soft paraffin. Is a cheap as a dirt. They work exactly the same as the expensive one. And similarly, avoid any cream-based product. Anything that looks white in color will give stinging sensation. A patient may not use it. So the principles are simpler. Just hydrate the skin with the ointment, treat with mild topical steroids, and that's all you need to do with addressing the underlying problem. Patient will get better within a matter of a few days. They don't have to be referred to dermatologist. It can be managed by the physician for the elderly. This is most a common condition I see in the elderly, and I'm sure you are seeing more in India as well. There's more longer they live, the higher the chances are you're going to get venous stasis dermatitis, simply because they're likely to have other medical illnesses like cardiac failure, liver failure. The poor mobility will set in. They will be wheelchair bound or chair bound or bed bound, which means the legs become edematous. Our patient may develop varicose veins, which might not have caused a problem before. They may cause problem now because the mobility is poor. They may have clot inside. So they will exacerbate the problem with the venous stasis. And drugs, increasingly going to use drugs like nifedipine or amlodipine or any drugs that are going to cause edema can cause exacerbation of the venous stasis. Or any previous illnesses like cellulitis. So cellulitis will damage some of the vascular channels, including the of course lymphatic channels, which lead to more buildup of the fluid. More fluid you get, more oozing, more symptoms. So this is a typical example I'm going to show you. This is obviously not a severe case. As you can see, pigmentation, edema, and this can be just simply an itching or simply a cosmetic disfigurement. But as you can see, the right side is much more inflamed. The patient will have symptoms, itching, oozing, and this can give lots of comorbidities. I mean, they may not be able to go out like this. They may not be able to walk like this. So I think it would give a lot of restriction to the social life intervention. So I think as a geriatrician, you have an important role to play. I would say understanding of this by any carotheliary physician will have a huge impact on patients' well-being. The picture on the left side, you can see edema set in and you've never been treated and the skin becomes harder. Now this becomes harder to treat now because the edema become more fibrotic. More fibrotic they get, very difficult to compress. Very difficult to compress, the edema will become permanent. So more permanent, higher chance of ulceration, higher chance of getting further cellulitis because it's easy for the lymphatics to get stagnated. So infection will become septic too. So picture on the right side, you can see there is a small ulcer there. This is one of the complications we expect to see, some of the long-standing venous ulcerations. When you have ulcerations, they have all the complications you can easily see can happen, like further infections, non-healing, regular dressing, restriction in quality of life and mobility. So how do you manage it? I mean, the aim of the procedure is to reduce the venous pressure. Whatever you do, that's the initial aim should be. So to achieve this, you need to explain to the patient why the pressure reduction is vital. So without explanation, most patients will not think the value of dressing, for example, or stopping, for example. So you must tell them clearly until the level they understand what's the reason for some of the prescriptions you're going to make. So education is very vital. If you have any local language information sheet with photographs, I would suggest that's probably the key. An elevation of the leg and explain to them why there's elevation. So the fluid can drain against the gravity. So that's through the gravity. So elevate the legs. Give a support stockings. Now, support stockings is not something easy to convince our Indian patient to wear. So I tried a few times when I visited, but it's often finding harder to convince them to do it. So if you explain how they work, maybe there is a chance to do that. And again, emollient therapy for symptomatic relief. So drier the skin, the itchy. So you use any emollients you could get hold of. So the skin remains a bit more wet and moist. And review the medications again. Any medication that causes the edema need to be addressed and see whether any chance of changing them. And if they're inflamed, use the topical steroid ointment. You may dermatology, we use steroid in nearly 50% of the cases. So why not you? So just use a potent topical steroid to control the inflammatory signs and treat any intracurrent infection. The infection can be subtle. It can be without any fever, without any CRP going up or white cell going up. It can be localized. So if you have a topical treatment, antibiotic therapies, topical antiseptics, please do use. And prophylactic antibiotic therapy, I'm not sure how it's practiced in India, but in the UK, we do use in patients with these significant comorbidities, penicillin V, 500 milligrams twice a day for 6 months to reduce any infection settling in on the venous eczema. So we'll reduce the chance of cellulitis. And antifungal therapy, this is one of the simplest and cheapest measure to intervene any kind of intracurrent infection in venous eczema. So often, most patients will have crowded toes, athlete's foot, and macerated toes. You can be easily treated with a simple twice-a-day application of antifungal cream, which they can get hold of over the counter. Simple clotrimazole or meconazole will be sufficient. They are very cheap and easy to use and will reduce the fungal infection, which will generally increase the risk of cellulitis. Of course, when you treat with any venous disease, you also need to consider there is a possibility of arterial insufficiency, particularly longer you live, arterial insufficiency can settle in, particularly in patients with diabetes and hypertension. So I think not to forget the arterial insufficiency, which may be contributory factor for the pain and the ulceration. Any systemic illnesses that you can manage to improve it, of course, as you're the best place to do that. So address that. So I think venous leg eczema is going to be increasing in India, and more likely you're going to be seeing. And as a physician for the elderly, you have more a role. And in my practice, I liaise with them all the time. And sometimes, in my case, they don't even call me. They let me know that how they managed it. So I think this is an opportunity for you to intervene. Patient will definitely benefit far from your input than me alone as a dermatologist. So I will stop there at this stage, because I think talking about any other illnesses specific to dermatology may not be much use to you. And also, I don't want to take up more of your time too. Thank you for the opportunity. I'll take any questions if you have.
Thank you, sir.
Thank you.
Any questions from the audience?
Thank you, Dr. Bala. That was a very relevant topic for geriatricians, and you have given quite useful points in terms of low-cost applications. Thank you once again.
Thank you again. Thanks for the invitation.
Thank you, sir. I would like to call upon the next chairperson, Dr. Prajapati Rao, sir. Sir, good afternoon, sir.
Good afternoon, sir. Good afternoon.
Good afternoon, sir. Sir, sir, next introduction, Mere sir. Thank you, sir.
Okay. Okay, sir. The topic is nutrition in elderly. So nutrition is very much important for the elderly people, because these people are very malnutrition as compared with the younger people. So for this talk, I invite Dr. V. Sai Pratyusha, clinical nutritionist and lifestyle medicine expert. She did her MBBS and having master's degree in nutrition and food science, USA. She is former vice president, Food Science Club at University of Central Oklahoma. She has done a research and development on the extraction of the probiotic from broad beans. She was a speaker at the Mega CMA 2020 on nutritional importance in COVID-19. And also she has got many certifications from the University of Arizona College of Medicine on oncology nutrition and sports nutrition. And she has got awards from APJ Abdul Kalam Award and Health and Medical Excellence Awards in 2021. So presently she is working in her own clinic, Aspen Clinics, Hyderabad. Now I invite Dr. Sai Pratyusha to talk on nutrition in elderly. Thank you. Go ahead, madam. Hello.
Hello.
Am I audible?
Yes, sir. Good afternoon. Trying to share the screen.
Dr. Sai Pratyusha garu, you go ahead.
Yes, thank you, sir.
Go ahead. Krishna, is there any problem?
Sir, a quick technical issue, sir. We'll be online very soon, sir.
Okay, okay.
ఉంది.
మీకు యాక్సెస్ ఇస్తాను.
సార్ ఫోన్ తీసుకొని జడ్జెస్ రిపోర్ట్స్ తయారు చేయండి. అది ఫుల్ ప్లీజ్ ప్లీజ్ వ్యాలిడేటరీ ఫంక్షన్ అది కావాలనుకున్నాను పంపించాను. రాదా మీకు వస్తుందా? సార్ వస్తున్నాను సార్.
అది నాకు ఒక పేపర్ మీద రాసి అన్ని ఆడున్నాయి ఉన్నాయని తెలియదు. అన్నిటి నాకు ఇచ్చేస్తే నేను రాసుకొని అనౌన్స్ చేసి ఫోన్ కాదు మీరు ఎక్కడ ప్లీజ్ నాకు వెతికి సార్ పేపర్ మీద
మేడం మీరు కావాలి మేడం నేను చెప్పాను మొన్న కూడా చెప్పాను.
Good afternoon, everyone. This is Dr. Shai Pratyosha. So today my topic will be nutrition in elderly. So let's come to basics. What is nutrition? So nutrition in human medicine is nothing but the consuming and utilizing of the foods. As we go with the medicines, the same happens in the human medicine along with the nutrition is consumption of foods. So next thing is the geriatric nutrition. It applies to the nutritional principles that will delay the effects of the disease in while you age. So it might be divided into 4, but it is commonly seen in everyone while growing old. It might be psychological, psychosocial, or physical, or mental. Next. Okay, what is aging? Like aging is a natural process as we know, but it has a specific condition when we given the proper nutrition, they will have a good health and a very comfort lifestyle. Next slide. Okay, aging factors affecting the nutritional status in elderly. As we know, there are 4 major factors which affects them. One is the functional. They may have taken good amount of food, but the impairments which they are, like any health conditions or any physical conditions, like mostly arthritis where people can't walk, so they might be missing kind of a healthy lifestyle. And next thing are pharmacological. So it is because of the overuse of the on-the-counter drugs, maybe used for a slight pain or any other gastric issues, which causes them to have a nutritional deficiency or malnourishment and weight loss because they're not able to absorb the nutrients they have taken because of the prior medications. Next, the psychological. It can be any situation in an elderly while they might be thinking of the family issues or the nutritional status they have or the ongoing era what we are having. They may have lot of psychological effects on them which they are not able to have good nutritional food. And next, physiological. It's because the body mass will decrease because they have a very low calorie intake, or it might be due to the dehydration the less water intake what they have and decreased renal function, they have a lot of impairment in their behavior and neurological, where they're not able to take the food. And next slide. Yeah, so the main effects is the oral factors. So most of 80% of the masticatory insufficiency is seen in older patients, but when they're not dentate, they have good nutrition because they can have any kinds of food, any kinds of quantity or the quality. So as they age, as they have more dentate, they're associated with chewing and swallowing difficulties, and the masticatory function is lower, and they have less sense of taste and smell, where they're not pushed towards having good nutritious food. Next slide. Next, the energy requirement. So as they age, there is a lot of reduce in the physical activity, as we know. So the dietary elements are also reduced, whereas 1300 kilocalories for women and 1800 kilocalories for men. Even this causes a lot of, because of the deficiencies they have, any enlargement of the parotid gland, or mostly we have seen all the muscle wasting and atrophic changes throughout the body. Next slide. Next, coming to the macros and micros, how are we classifying to the elderly? So mainly now it is because the carbohydrates are consumed largely in any age patients. Now the percentage of calories we get from the carbohydrates will be 50 to 60%. And then the subclass will come as the carbohydrates, where fibers are most important because they promote bowel function, where the elderly actually experience a lot of constipational issues because of the low hydration effects or the low fiber intake, because there are a lot of differences, again coming to the oral and physiological and the social changes around them. Next, coming to the protein will be a little bit more as you age, because it's 0.8 grams per kg body weight, because the lean muscle will reduce as you age, and the fat will be taking most of the space in the cell as when compared to a younger adult. Next, fats. The transport and absorption of most of the vitamins, minerals comes from the fats. There are three types, as we know: saturated, trans, and unsaturated fats. But what is the discuss? What we have is, when the older adults look lean, we tend to give many fats to just make them bulk. So that's not what we want. We want this fats to be used in a good way for their amount of building mental health, gut health, and their energy throughout the day. So when you give excess fats, maybe it may be trans fatty acids or saturated fatty acids, they tend to form as fats, where there is unhealthy weight gain and obesity, which is indirectly or directly composing to the type 2 diabetes, which is seen in most of the older adults these days. So the right amount is giving 25 to 35% of the total calorie intake with a good saturated fatty acids, mostly omega-3, omega-6. So now, what does an omega-3 fatty acid does? So it has the potential of preventing and reducing the comorbidities in older adults. How does it happen? Because they have the effect of modulation of inflammation. They are capable of platelet aggregation, reduction of hypertension. So there are many studies where they aid to prevention of dementia too. So where we get this good amount of omega-3 fatty acids, it's mainly from all the nuts, seeds, and if they are love to take seafoods and leafy vegetables. And next thing, hydration. Hydration is the most important thing in elderly, whether it comes to the dermatological issues, to the physical activity, or the organal or the renal impairment. It is all because of the insufficient water intake, because they're not having any physical activity, or they tend to have a very limited physical activity. They tend to have very low water consumption. So next, let's come to the fat soluble vitamins. Now here we'll know about what each vitamin is actually does to the nutrition consumption in the body. Like whatever we eat, the nutrition or the macronutrients, the minerals, vitamins, how are they absorbed, and it is related to the vitamins, and how are they stored in the body. So now coming to vitamin A, it gives like the dietary allowance of vitamin A is 900 micrograms for males and 700 micrograms for females. The deficiency causes decreased salivary flow and keratosis, all the salivary epithelial dysfunction. Now the vitamin D, which is a very crucial vitamin, where they say it's mostly from the sun, but we have other sources of seeds and the egg yolks where they tend to carry a lot of vitamin D. So the dietary elements for this is 10 micrograms in males and females. Yeah, as we know, the deficiency causes mostly the osteoporosis, osteomalacia, and immune function decreases. Next thing is vitamin E. The vitamin E levels increase with age. So that's when we see a lot of problems where they face in the oral. They're not tolerable to spices. We see that given by the older patients, that they can't handle spices, or there might be any cracks all over the oral cavity. It's due to maybe the less levels of vitamin E, or they are maybe over increasing it too. Next thing we come is vitamin K. The coagulation vitamin is very crucial in relation to the blood clotting process. Yeah, as they age, the coagulation effects also increases. So the RDA is 1 microgram for males and females. So yeah, it's because they find a lot of petty K, gingival bleeding, and the coagulopathies. Low bone density is also found when there's low vitamin K. Next, the water soluble vitamins. It is actually water soluble vitamins, they carry to the blood tissues. The main thing what we see is vitamin B1. It helps the carbohydrates to convert into energy. So that's when we get it from different kinds of foods. But the deficiency, as we know, they have berry. Now, when the vitamin B1, the carbohydrates to convert into energy, we need to have a good gut health. So that gut health we'll see further. And coming to the B6, B6 helps in metabolizing of the carbs, protein, and fat, and help the immune system healthy. So now we see when there's low B6, we find a lot of glossitis conditions. And the next thing is folic acid. It is the coenzyme with B12 and vitamin C to produce cells in the body. So even they have a lot of oral conditions, as we have seen. And B12, it is the largest vitamin involved in the metabolism of every cell in the human body. So this deficiency gives us like a lot of immune related conditions, mostly candidiasis and stomatitis. Next, vitamin C. It is an essential nutrient in repair of tissues and enzymatic production certain neurotransmitters. It also functions as an antioxidant, which also helps in giving us the immunity and helps in wound healing and scurvy. And minerals, substances that body doesn't manufacture but are essential for healthy bones and teeth. They don't contain any kind of calories, but they don't provide any energy, but they're very important that they keep the body structure intact. So coming to the minerals, calcium. Calcium is required to build and maintain strong bones, healthy communication between brain and other parts of the body. We know the deficiencies causes osteoporosis, muscle loss, the tooth decay. Iron main purpose is to carry oxygen to hemoglobin of red blood cells. And next, We have zinc. Zinc is also a micronutrient which is required in advancing as the age advances, because it decreases in the interstitial absorption. Next, magnesium. It helps from form bones in teeth and also activates all the enzymes. Next thing, this is a food pyramid that we want all the older adults to follow, like what kind of variety of whole grains to follow, what are the saturated fats and the trans fats we need to avoid, and what are the other kinds of fruits and vegetables to be preferably taken. Then the vitamins, mostly concentrated on D, B12 and C, because they help in absorption of other nutrients along with them. And next, coming to the fat, non-dairy and the dairy fat, and low saturated fat. And older adults more than 60 to 65 years have to be taken minimum 9 to 10 glasses of water, depending on the various activity levels they have. And next thing, this is the most important thing where we see most of the adults failure to thrive. Okay, now failure to thrive is not considered as a disease or a disorder. It is just the signs or symptoms they give, and that will lead into the highest mortality or morbidity in older patients. It decreases the quality of life, as we know, but the awareness in what is causing failure to thrive will give us a good result in the deaths as we seen in old age, just by the warning signs what the elderly population give us. So let's see the leading signs of failure to thrive. So it can be any disease, dementia, delirium or drinking alcohol, drugs they take, dysphagia, deafness or any other kind of sensory deficits, depression, desertion of the family, destitution, might be any kind of poverty, despair, just letting go the things what they're worried about. And these signs are more important. They seem to be a lot of having a disease, or maybe they're taking it as a disorder, but these are the small signs which on a longer or a chronic go will help them get malnourished and have weight loss issues, low lean muscle mass, and that will contribute for them to have a highest mortality rate. And uninterrupted weight loss is a big deal. Yes, we see in most of the older adults, they seem to be lean, but why is it? Why are they having an uninterrupted weight loss? Because they're losing muscle. So muscle loss is a important thing, because as they age, the lean muscle tends to come to a smaller portion than the younger age. So the size of the cell tend to have a lot of fat and the less muscle. So it might be different ages. They may be compared to a 30-year or a 40-year, and compared to a 60 or 70-year. They may age different, but they may weigh the same kilograms. But the muscle, the weight of the muscle difference from each individual. So as we think, for a normal human being above the 24, 25 in recent studies are considered overweight or obese. But for an older age, depending on the other factors, the BMI 24 to 30 have the lowest death rates in adults. So next, gut microbiota. It is a very key control for a healthy aging in elderly adults. So now here we can see there are a lot of gut leakages, because they might having any kinds of symptoms like IBS, constipation, gassy feeling, and this is all because they might be a gut leakiness, and the bacterial toxins might be increasing. They have pro-inflammatory cytokines, and the opportunistic bacteria increases where the beneficial commensal bacteria decreases. So when there is more gut leakiness, that eventually flows into the bloodstream and then the omentum, and there's inflammation of pancreas where they tend to have a more increase of other pro-inflammatory cytokines, and they may the elderly might be having other type 2 diabetes, osteoporosis, IBS. Everything is interlinked just with the microbiota they are experiencing in their gut. Next thing is the gut-brain axis. So the gut-brain axis, as we have seen, it is a very important factor in aging and overall health. Let's not take an individual organ or how they tend to age, or are they deceased with one organ, but let's consider that it is overall their gut health which is need to be taken care of. It can be any other related to hormones, related to inflammatory markers. It is all interlinked with the gut and the brain, which is neurogenomics or any other metabolic issues, which is interlinked with the diet they take. And the most common mental disorder is Alzheimer's. So in very recent studies, Alzheimer's is more in older adults in whom they have low gut microbiota than people who have good gut health. So the pro-inflammatory gut bacteria that enters into the bloodstream can be directly linked to the levels of Alzheimer's plaques. So you compare an adult of same age with a good pre-probiotic gut and the same age adult with a low gut microbiota. So they tend to have more mental disorders than one who is not. So typically it is in all second individual at an older age we see. So let's give them this pre-probiotics which help them in boosting their gut health, which is directly related to their overall health. Next, so this is the treatment for any other disease or to an every old age person. It is all a balanced diet. Now we have seen taking how much kind of milligrams or micrograms, what to give, what not to give. It is all based on a single plate of food where they have 4 components in a balanced way. That is all what we need to do. We need to support them, and that will directly give the support mentally and psychologically, where they can improve their health and immunity and their mental health. These are few citations I have taken my presentation from. Thank you all. Any questions?
So right, no online ఉన్నారట మీరు కనెక్ట్ అవ్వండి ఆన్లైన్
Bikshapatirav sir.
Okay.
Thank you, madam. Thank you for your presentation, excellent presentation regarding nutrition in elderly. You touched aging factors, oral factors for the importance of nutrition in the aged people. You also touched carbohydrates, proteins, different types of fats, vitamins, minerals, trace elements, and also gut-brain axis, the most important. So you all covered this. Thank you, madam. Thank you very much. And I thank the organizers, Chandrasekhar sir, Krishna, and GERICON team for giving me this opportunity. Thank you.
Thank you, sir. Thank you very much. Thank you, Dr. Pratyusha, for a wonderful presentation. I would like to go on to the last topic of the day, and I would like to call upon Ram Kumar sir. Good afternoon, sir.
Yeah, good afternoon. Am I audible?
Yes, sir. Loud and clear, sir. The session, sir.
Okay, fine.
Thank you, sir.
ఇంకా అవ్వాలి.
Hello, welcome, sir.
Hello.
Super Suresh.
Yes, sir.
Confusion అయింది.
Sir, am I audible, sir?
Yes, sir. Yes.
And mute ఉంది. Mute ఉంది. Ramsamy sir.
Yes. But madam has come. Madam's
You cannot participate.
already something is there on the screen. So my Dr. Rupa madam's slide is seen on the screen. That is why I am not able to project. We will talk in it.
Hey, question.
Dr. Krishna.
Sir, 1 minute, sir. 1 minute, sir.
Oh, yeah.
Ramsamy sir, I'll be calling you on your mobile phone, sir. Please take, sir.
Okay.
Thank you, sir. Thank you, sir. Thank you, sir. Ram Kumar Reddy, sir. Are you there, sir?
Yes, I am here.
Sir, can you please read out the slide of Dr. Rupa Suresh Garu and start the session, sir? Thank you.
Yes. Dr. Rupa Suresh, she done MBBS at KIMS, Bangalore with honors. And she done MD Internal Medicine, State University of New York. And fellowship in Geriatrics at State University of New York. Executive member of Indian Academy of Geriatrics, member of American Geriatric Society. She is also Associate Medical Director, PES Institute of Medical Sciences, Andhra Pradesh, Assistant Managing Director and Consultant Geriatrics, Excel Care Hospital, Bangalore. She has so many laurels. Madam, please continue the talk.
Thank you for the kind introduction, sir. Very good afternoon to all of you.
Good afternoon, madam. Okay.
At the outset, I would like to thank the organizing team for providing me an opportunity to present this topic today. Sir, am I audible?
Yes, you are.
Yeah. So today we are going to speak about perioperative care of elderly surgical patient. Surgery in geriatrics is seeing an upward trend. 55% of all surgeries are done in patients 65 years and older, of which 40% are elective surgeries and 50% are emergency procedures. In estimating perioperative risk, age is an independent risk factor. As age increases, there is an increase in mortality. In patients aged less than 65 years, the mortality is only 1%, whereas in patients aged more than 65 years and less than 80 years, the mortality increases from 5 to 8%, and the overall mortality risk is about 0.3%. So what is our role? As medical consultants or as geriatric consultants, what is our role is what we are going to see today. Initially, we have to assess the risk, both the cardiac risk and the non-cardiac risk, then to reduce the risk by medical optimization guided by relevant testing, and to communicate to the management plan to the surgical team, and to follow the patients as appropriate in the postoperative period. So in the perioperative evaluation of a patient, we need to take a very good history and do a detailed physical examination, both of which are part of the comprehensive geriatric assessment. And then, of course, choose wisely to do the tests in the laboratory. In the history, we start with the geriatric review of systems to look for undiagnosed disease. The medication history of current medications, over-the-counter medications, and any herbal supplements. History of recent use of any anticoagulants, aspirin use, and non-steroidal anti-inflammatory drugs. History of allergies to both drugs and to rubber products and antibiotics in particular. And also any history of previous surgeries and anesthetic complications and any bleeding to previous surgeries. In the preoperative period, we need to take a baseline status in the 4 important areas on every geriatric patient. What are these 4 areas? Firstly, the cognitive status. We need to know what was the baseline of the patient in terms of his memory. And we need to screen it with a basic mini-cog screen. And where needed, we need to do a mini-mental status examination. The functional status of the individual has to be assessed both in respect to his activities of daily living and his instrumental activities of daily living. Mobility of the patient, whether he is able to walk independently or whether he is using any assistive devices. Most important of all, we need to figure out whether he had any falls in the last 6 months, which is extremely important for us to know. As previously we had a nutrition talk, it's very, very important to know whether there was any unintentional weight loss of more than 10% in the last 6 months or a body mass index of less than 19 kg per square meter, so that we can care better for this patient during the postoperative period. It is ideal to define frailty here as per the history if the patient presents with weight loss, weakness, low physical activity, slowness in walking, or exhaustion. If any 3 of these symptoms are present in a patient, that defines frailty. We just heard about failure to thrive in the previous talk, but these 2 are separate entities and both are important to be addressed. A complete physical exam of the patient needs to be done with importance given to the cardiovascular system, the pulmonary system, the musculoskeletal system, especially importance to be given to the cervical arthritis and feedback to be given to the anesthetist, and oral, dental, and skin examination. When the musculoskeletal system is examined, we need to assess the gait of the patient. We need to do a timed up and go test to see if the patient is able to finish this test within the framework of 15 seconds. We also need to check for the hand grip strength, which will give us more information about the frailty for the patient so that we can work on this in the postoperative period with appropriate physical therapy needs. Routine pre-op evaluation may not be adequate to assess geriatric patients. A comprehensive geriatric assessment may be required to add value to routine assessment. A Cochrane assessment of the utility of comprehensive geriatric assessment from 8 randomized trials showed that it helped decrease mortality, decrease the level of care at discharge. The secondary outcome also showed that it decreased the length of stay, the readmission to the hospital, the overall cost spent on each patient, and also the postoperative complications. When it comes to laboratory testing, the value of routine medical testing before elective surgery is unclear. All tests should be justified by a specific symptom, sign, or diagnosis, identified during the history or during the physical examination of the patient. There are a lot of physiological changes like cardiac and vascular stiffening, which can complicate fluid management in the elderly. But a 12-lead ECG is recommended for all patients aged above 50 years with a history of coronary artery disease. The cardiac risk stratification is based on the ACC guidelines, which were last reviewed in the year 2014. They are classified based on the surgical risk of the patient, the clinical risk factors that the patient has, and the functional capacity. The risk of postoperative cardiac events is directly related to age. To calculate cardiac risk, we have 2 societies which have given us 2 guidelines. Firstly, the American Society of Anesthesiologists classification, And the next one is the American College of Cardiology and the AHA guideline. We have these two website addresses which give us an exhaustive guidelines where we can go to the website address links which are given on the slide to refer to them. For the want of time, I will not be able to go through in detail. We also have the American College of Surgeons, which has a risk calculator, and the website address on the slide has also been given to reach that website, where you put in particular features of the particular patient and it calculates the post-operative risk of the complications for the given said patient. Elderly patients have pacemakers and ICDs. So what do? The ICD devices should be programmed to off mode immediately before surgery and then turned on again post-operatively. Pacemakers may need adjustment based on the need and location of the electrocautery by the surgeon. High blood pressure. The goal blood pressure must be maintained around 140 systolic and 90 diastolic. If the blood pressure is more than 180 systolic and 110 diastolic, this should be stabilized preoperatively. Antihypertensive should be continued in the perioperative period. Even on the day of surgery, if the patient is nil per mouth, antihypertensive should be given with small sips of water early in the morning. We have to anticipate and use parenteral agents in patients unable to take pills by mouth or via an NG tube. Moving on to pulmonary risk assessment. Age-related changes influence perioperative care. As a result of normal aging, multiple organ systems may have limited physiological reserve. Stiffening of the thoracic cage and diminished ciliary function lead to decreased pulmonary reserve. So, the ACP guidelines were last reviewed in the year 2007, and the pulmonary complications contribute to 50% of perioperative mortality. The patient-related risk factors are smoking, poor general health status, chronic obstructive pulmonary disease, asthma, obstructive sleep apnea, previous history of aspiration, and kyphoscoliosis. The procedure-related issues are, as the incision approaches the diaphragm, there is an increased risk of pulmonary complications. So to assess them, we do a forced expiratory volume in 1 second. If the FEV1 is greater than 2 liters, the patient can safely undergo the procedure. If the FEV1 is less than 1 liter, the patient is at a high risk of post-operative pulmonary complications. So what do we do in these cases? To risk assess, after doing the FEV1, the ACP recommends spirometry for patients who have dyspnea and are current smokers, and for those patients undergoing coronary artery bypass grafting or upper abdominal surgery. And once we do this, to reduce the risk, if someone is a current smoker, and at least for 8 weeks, he needs to stop smoking prior to surgery. And if someone has active lung disease, we have to aggressively treat the patient. And lung expansion maneuvers are to be started off as early as possible if we know the patient is going to be undergoing any sort of surgery and he's at an increased risk of pulmonary complications. We have a lot of elderly diabetics and they have increased complications due to vascular disease. So these patients on the day of surgery and 24 hours prior to it, if they are on long-acting oral hypoglycemics, they need to stop it at least 24 hours prior to it. And on the day of surgery, we have to withhold all oral hypoglycemic agents. We have to decrease the dose of insulin to half on the day of surgery. The goal is to maintain the serum glucose levels between 150 to 200 milligram per deciliter. We do not advise very tight control of blood sugars because hypoglycemia could prove more dangerous in the elderly patients. What about thyroid disorders? In patients who are having hyperthyroidism, we need to ensure that they are treated and they're euthyroid before they proceed for surgery because there are high-risk surgical complications if they are operated when they are hyperthyroid. The same way, if the patients are hypothyroid, we treat them and ensure they are euthyroid before they're taken up for surgery. What about nutritional assessment? As already mentioned, the height, weight, and the BMI should be calculated for each patient, and as malnutrition is very common in the elderly patients. Estimation of GFR is also required, as dose adjustment of medication is to be done as needed in the perioperative period. Older population have decreased lean body mass, which can lead to an assumption of creatinine values of 0.8 to 1.2 as being normal. Assessment for anemia. A hemoglobin more than or equal to 10 gram in patients with pre-existing heart disease is advisable. The very often asked question is when to stop antiplatelets or anticoagulants. This is sometimes a difficult question for us to answer. We need to weigh the protective benefit versus the bleeding risk in patients already on anticoagulation. Do not withhold oral anticoagulation for superficial surgeries like cutaneous surgeries, dental extractions, minor oral procedures, or cataract surgeries. For other procedures, the cessation of warfarin with or without bridging therapy with low molecular weight heparin is based on the patient's risk of thromboembolism. Here in this table, we are looking at the drugs, that is oral anticoagulants and antiplatelet agents on the left side. The middle column shows us when they need to be stopped, and the column on the right shows us when they need to be restarted. So the first three drugs are the oral anticoagulants, that is warfarin, apixaban, and dabigatran. Warfarin has to be discontinued 5 to 7 days before surgery. Apixaban has to be discontinued 24 hours before surgery, and dabigatran has to be discontinued 3 days before surgery. All of this can be restarted 24 hours after surgery. The last two drugs, aspirin and clopidogrel, are antiplatelet agents. They need to be discontinued for at least 1 week prior to surgery, and both of them can be restarted within 6 hours after surgery if there are no contraindications. Venous thromboembolism assessment is an important part. If it's a minor surgery with no risk factors, no routine pharmacological prophylaxis is recommended. But if it's a minor surgery with risk factors or a major surgical procedure, then thromboprophylaxis is recommended. What sort of thromboprophylaxis? We have mechanical options, which is venous compression stockings, intermittent pneumatic compression devices, inferior vena cava filters in patients who are not a good option for pharmacological therapy. When we look at pharmacological options, we have low dose unfractionated heparin, low molecular weight heparin, and fondaparinux. And we have oral anticoagulants like warfarin and rivaroxaban. The intraoperative care does not differ much from an young adult, except in older adults, we need to take care of extra padding during positioning of the patient in the operating room because of decreased skin integrity. And also, if we can speak to the surgeon and the anesthetist to see if they can decrease the use of narcotics and anesthetics, that is preferable, as they can cause increase in the post-op delirium. Avoiding high-risk medications during the intra-op period, especially the ones with anticholinergic effects, because these result in post-op delirium. Increase in intraoperative blood loss is also a major risk factor for post-operative delirium. Post-operative delirium. 60% of elderly patients can experience delirium. Any patient with unexplained dementia is at a risk of developing post-operative delirium. That is the reason we said that in the initial evaluation, we need to look at the cognitive function of every patient and know what their cognitive baseline is. At the bedside, confusion assessment method is a very simple test to perform and diagnose delirium. The risk factors for delirium are sensory and sleep deprivation, polypharmacy, pain, dehydration, abnormal electrolytes, especially those related to sodium, potassium, and glucose. How do we treat them? Preferably, first choice should always be non-pharmacological interventions. We need to ensure that the patient is frequently oriented to time, place, and person by the caring team, maintain a quiet and calm surrounding, eliminate restraint use, have families sit by the side of the patient, and try to give the assistive devices the patient was using at home, like eyeglasses and hearing aid. In case he was using a walker or cane at home, try to give it back to him. The last choice should be the pharmacological intervention, as antipsychotic medications have their own side effect profile that we need to deal with. Only given when the patient is either harmful to self or to the caregivers. Post-operative care. When we look at post-operative care, it is always done by a multidisciplinary care team. This involves a team consisting of a geriatrician, an intensivist, the surgeon, the anesthetist, a nurse, physiotherapist, dietitian. The primary care doctor should also be kept in the loop right from the beginning, and a social worker. Early ambulation is always a good option. Pain management is extremely important, especially in demented patients, as they will not be able to ask for pain medicines. So round the clock, pain medication should be given at least in the first 48 to 72 hours to prevent delirium in these demented patients. Decrease in the number of new medications given. Decrease in polypharmacy. And nutrition and hydration should be taken care of right from day one. Early discharge planning with home physiotherapy as needed should be done with the involvement of the patient, the family, and the concerned caring team. Here in this diagram, it beautifully summarizes the geriatric aspects of a frail old patient, how we have to intervene and how we have to optimize the care. On the left side, we see the preoperative markers of frail older adult, namely impaired function, slow mobility, impaired cognition, poor nutrition, social isolation, multimorbidity, and polypharmacy. The arrow in the middle represents the positive findings which we have gone through as to how to obtain them from a good history, physical examination, and relevant testing. And once identified, we have to start intervening and then optimize care. We already said that to optimize care, we need a MDT team. Approach the same has been enumerated. And on the right side, if an elderly patient has impaired function and slow mobility, we need to work on physical therapy and occupational therapy. If with impaired cognition, we need to work on the delirium pathway. If with poor nutrition, we need to supplement the nutrition. If with social isolation, then we need to work on discharge planning. If with multimorbidity, with more than 2 medical illnesses, we need to have geriatrics evaluation to take care of the multiple medical problems. And if with polypharmacy, then we need to do a detailed evaluation of the medications and see how to optimize these medications to have minimum side effects. It is said that if you start 5 new medications in the post-operative period, the incidence of delirium increases by 5 times. So we need to be careful with the number of medications we are dealing with in the post-operative period. And review of these medications should be done on a daily basis, and it preferably should be done by a geriatrician. So in summary, first let's go through what not to do, because we have learned a lot as to what needs to be done. So don't do a stress echo or nuclear stress test as preoperative assessment in patients undergoing low-risk non-cardiac surgery. Don't do a stress test on patients with no cardiac history and good functional status before non-cardiac thoracic surgery. Don't do preoperative medical tests for eye surgery unless there are specific medical conditions. And don't do echocardiogram for preoperative assessment of patients with no history or symptoms of heart disease. So then what do we do? Because surgery is an important therapeutic option for many older people. Preoperative assessment should be individualized, comprehensive, and often multidisciplinary. Attentive perioperative management minimizes complications in older patients, especially those with chronic medical problems and functional impairments. Thank you all for your valuable time. Thank you, sir.
Hello. Thank you, madam. Very excellent presentation. You have touched very important points where the geriatrics has this very special role because we, the ortho surgeons, come across day-to-day life where anesthetists and physicians, they always have trouble in giving pre-anesthetic or pre-anesthesia, pre-surgery fitness. So you have done very optimal compromise, and we are doing the checkup also. So preoperatively, the shortest preoperative time and postoperatively pain reduction and also the early mobilization is very important for the elderly patients. We have been seeing patients, many patients. If you get them bedridden for more than 3-4 days or 1 week, they will getting bed sores and the pulmonary complications. They never become fit for surgery again. So before that, we always request these physicians and anesthetists to give the fitness as early as possible. So you have touched very good points, madam. It's very nice talk. Thank you very much.
Thank you, sir.
Thank you, ma'am.
Thank you, ma'am. Thank you, sir. If there are any questions in the audience.
Thanks, Dr. Rupa. That was an excellent talk. It will help everybody to manage the elderly perioperatively in a better way. Thank you.
Thank you, sir.
As there are no questions, we are closing the session. Thank you, ma'am. Thank you very much. So this comes to the end of the final session of the day. So the validatory function is gonna start in Hall A very soon, and it will be relayed in the same hall, Hall B. Please wait for it. Thank you.
600.
184, sir. And in Hall B, 185. So 429. So this is only the delegate who are attending the live, sir, or from chairpersons, statistics, sir. So now I call upon Dr. YSN Raju, sir, to the valedictory ceremony. And I also welcome Dr. Ashish Goyal, sir, President-elect. And I invite Dr. Prasad Matthew, sir, President, Indian Academy of Geriatrics. And I welcome Dr. R. Magesh, sir, Secretary, IAG. And Dr. Shanti, Madam, Chairman, Scientific Committee. And Dr. Thangam, Madam, Treasurer, IAG, and Dr. Usha, Madam.
And Dr. Deepa also.
Dr. Deepa, Madam, and Dr. Krishna Prabhakar.
Yes.
So these are the invitees. So before welcome address, I profusely thank sponsor for this event, for particularly this technological this thing, Mr. Durga Prasad, representing a manager of Smriti Organics, who has helped me in arranging all these virtual logistics. So I invite Durga Prasad for 1 minute to speak about.
Good evening, doctors. Thank you all very much for giving me such a wonderful opportunity to interact with you all in online program today. And my special thanks to Dr. V. Chandrasekhar sir, and my special thanks to Dr. Ramaswamy sir, who is the board of directors of my company, and where we are based out of Shalapur, and we do look after Indian operations with our organization portfolio. And I wish to conduct a lot of programs like this type of activities, and I want to be a part of many more activities with all my doctors. I request everyone, please help me out to make me to be a part all of our scientific activities, all times, anytime. I'm quite available. And in fact, I'm based out of Shalapur, but I do sit in Hyderabad along with Dr. Ramaswamy sir, where sir is based at Ballanagar, Hyderabad. And as an organization, sir, we do deal with the product portfolio of Dapasol, Dapagliflozin, Metformin. We are the major suppliers of India as well abroad, especially the raw material called API, so-called. And we have got some of the product portfolio with you, which you can definitely help me a product support along with my representative, visiting when your place, and help me out with a product portfolio with your great help of support of your prescription support, which will be definitely enhance the confidence and all of team to be a part of many of other activities like this. Thank you all very much once again to give an opportunity like this to be with you all on today. Thank you very much, and good day to you all.
Thank you, Mr. Durga Prasad.
Thank you, Durga Prasad.
Now shall we start
now
off?
I invite Mr. Chaitanya Sajjad for the Joke Technologies, who is our vendor in arranging all these things. So I ask him to talk for 1 minute. So if is there, else we will.
Or Chandrasekhar, we can
So
do it at the end of the
he's not there, sir. So we'll move on. Sir, YSN sir, you say the welcome address and take over the proceedings of valedictory function, sir.
Now
So
I'd
in
like
between
to,
few announcements are there. So you permit me, I'll announce.
I will do it after the welcome.
Yes, sir.
I think
Yes, sir.
let's invite everybody. Welcome, actually, Dr. Prasad, Dr. Ashish Goyal, Dr. Magesh, Dr. Usha, Dr. Deepa, Dr. Shanti. Dr. Ashish Goyal is dressed up for us, though he's in Leh. Nice to see you, sir. Actually, I'm sitting here, and even welcome Dr. Ramaswamy, sir, Dr. Gandaya, sir, Dr. Krishna Prabhakar. And actually, I'm here sitting here with the mixed feelings. And the mixed feelings are for the same thing. I'm very feeling bad that the conference has got over, and actually feeling happy that the conference is over. So with this, I welcome you all. Kindly give your feedback. I think we try to do our best And thanks to all my seniors who have encouraged us and reposed confidence in us. Thanks to the scientific team. Thank you, Dr. Prasad, Dr. Ashish Goel, Dr. Magesh, who coordinated and made this possible. And thank you, Dr. Usha and Dr. Deepa. Dr. Chandrasekhar?
Yeah.
Dr. Prasad, you'd like to say a few words, please? Starting off with you.
Thank you, Dr. Raju. At this moment, I'd like to thank the organizing chairman, Dr. Raju, organizing secretary, Dr. Chandrasekhar, the scientific committee, Dr. Shanti, Usha and team, and especially Dr. Magesh for working tirelessly for the last 3 years. I'd like to thank all my office bearers, especially Dr. Magesh again, Dr. Raju, Vice President, and all the office bearers and the EC members for all the hard work they put in during the difficult time. Especially, I'd like to thank the local organizers for the excellent program they've managed at very short notice. Thanks to all who gave the technical support. And again, I'd like to wish Dr. Ashish Goel and the new incoming team wonderful way forward to take the association and the discipline of geriatrics to greater heights. Thank you.
So Dr. Krishna Prabhakar needs also mention. He was the guy silently working behind everything, and with Dr. Chandrasekhar. Dr. Krishna Prabhakar, thank you.
Sir, now I can ask the Dr. Ashish Goel sir to give some comments.
I can completely imagine the mixed feelings that Dr. Raju is saying that he's having, that he's happy as well as sad that the conference is getting over. It's completely understandable. It's a relaxation, and suddenly you will find you'll have nothing to do for the evening tonight. And
no, we got a GBM. We got a GBM. Thanks to Dr. Magesh.
Right, absolutely. Dr. Magesh has been totally tireless. I mean, he's been working more robotically and with precision and accuracy as well. And thank you, Dr. Matthew, for your best wishes and your good wishes. I'm sure with your blessings and support, we will definitely move ahead in the coming 2 years. Thank you. Thank you very much. And congratulations.
Next, I call upon Dr. Magesh sir, Rajendra Magesh sir, Secretary IAG, to give his remarks and permission to announce the medal winners in the oral and.
No, let Dr. Usha and Dr. Deepa talk. After that, we'll have the announcement.
Okay. Sir Magesh sir, please.
Thank you, Dr. Chandrasekhar. I think at the outset, I should start by thanking Dr. Raju, the organizing chairman, who was enthusiastic from the day we started approaching him that this should happen. This was difficult times where a live conference was not possible, and his support and enthusiasm to get this done has been immense. And I would like to thank the scientific team who dedicated a lot of time to choose the scientific program and the speakers. And the initial feedback from many has been, it's been a very informative and a new shift in terms of the program delivered in the GERICON. So I thank the scientific team, Dr. Shanti, Dr. Usha, Dr. Deepa, Dr. Thangam, Dr. Uma Kalyani, everyone who attended and put their thoughts into getting the scientific program and the speakers on board. Next, Dr. Chandrasekhar and Dr. Krishna Prabhakar have worked tirelessly. They've been through very tough days, and all of us who have organized conferences could empathize with them that they've definitely had a very difficult time in putting this program and getting the technical support, which is very new, to kind of get a completely virtual program and to kind of get it off smooth with ease, where speakers from all over the world were speaking, and to coordinate with the chairpersons was immense. So I thank you both and your teams, Dr. Chandrasekhar and Dr. Krishna Prabhakar, for pulling off a very successful virtual conference.
finally, I'd like to thank all the speakers who done well. It's kind of weird for many who are not used to technology to speak online without an audience, and also to spare their time and to give wonderful informative talks to make this conference a success. And then finally, I'd like to thank all the delegates who logged in and benefited from interacting with various eminent speakers. Now I hand it over to Dr. Chandrasekhar.
Welcome, Dr. Arvind Mathur, sir.
Yes, sir.
Sir?
Welcome, Arvind Mathur.
Sir, good evening, sir. Thank you. Thank you for joining in. Would you like to say a few words, please?
Dr. Raju, Dr. Chandrasekhar, and your team have done a commendable job in organizing this memorable conference. And I think this paves way for such communication amongst us. And that is then this conference would be the leader for that particular thing. So I again congratulate you and your team for such an excellent conference.
Thank you very much, sir. Thank you very much, sir. Yeah. Dr. Tangam? Dr. Shanti is logged in?
I think Madam is there, sir.
Good afternoon, all of you. My congratulations to the organizing team, Dr. Y.S.N. Raju, Dr. Chandrasekhar and his team for organizing this hybrid conference in such a short notice. And you have become a model for all of us to organize such meetings in the future if needed. And it was well organized. And I can mention it was that is you have organized the sessions well, and you have communicated with the speakers as well as the other chairpersons in a better way, and you have prepared them even before one session is going to commence, and you have prepared them well, and you have organized all the other things very well. I once again congratulate you and thank you all. Thank you.
Thank you, ma'am. Dr. Deepa? Good evening.
Madam, unmute
You have to
yourself.
unmute yourself, ma'am. Unmute, Deepa. Yeah.
Good evening, one and all. I congratulate the organizing team, Dr. Raju, Dr. Chandrasekhar, and his team for the tireless effort for the success of the conference. Thank you, sir.
Thank you. Dr. Krishna Prabhakar, would like to say a few words? Come on, come on. You won't believe it. This guy, I get a message at 4 o'clock in the morning. I see it. I say, okay, let me reply and see. And immediately I get a reply, okay, sir, at 4 o'clock in the morning. It's amazing. It's amazing.
Yes, sir. He is our future person, key person.
This is a
going
big
to be.
round of applause.
So he is
Dr.
my
Krishna
full
Prabhakar.
strength, sir. Without a Prabhakar proactiveness, it wouldn't have been possible. Yes, sir.
Sir, thank you very much, sir. It's been an honor and a pleasure and a good learning curve for me to be a part of this wonderful conference. I thank all my seniors, all my colleagues, and the entire technical team behind this to make this a grand success. And thank you very much. I'm looking forward to participate in many such conferences. Thank you, sir.
Thank you. Gandaya, sir.
Hello, good afternoon.
He's the chairman of the Telangana chapter.
Good evening, everybody. Thank you very much for giving me the opportunity to present myself as a speaker and chairperson. Thank you, everybody, particularly Chandrasekhar and my son like Krishna Prabhakar. Thank you, Raju. Thank you very much. Thank you, everybody. Wish you all the best for the days to come. Thank you.
Dr. Shanti, Dr. Usha. Madam Usha, madam, good evening.
Good evening, sir. My heartfelt congratulations to you and Dr. Chandrasekhar for organizing such a nice hybrid program. This is the first time we're coming across a hybrid program. And my congratulations to all the speakers for their inspiring talk. And it was a very useful conference. And looking forward to such conferences in the future from IAG. Thank you.
And it was very challenging. If you have a physical conference, you can actually catch hold of the speaker,
exactly. That's
make him
true.
sit in the chair.
Yeah.
To
make it as a hybrid, it's very difficult.
You can't see these people.
And especially in this pandemic situation, we were wondering how it would go on, but it was a real success. Congratulations to you.
Thank you very much for all your cooperation and help with the scientific program. Thank you, ma'am. Shanti, ma'am.
You're always there.
It is there in the. She's
Dr.
logged in. I
Bijin,
don't know.
Dr. Bijin would like to say a few words.
Thank you, sir.
You can, yeah, we'd like to see you.
Thank you, sir, for this wonderful opportunity. The first time I'm giving a talk here, and also first time I'm being invited to be a judge for this platform presentation. It's a new experience, and definitely I have to thank Shanti ma'am, Mahesh sir, and Deepa ma'am, Tanga ma'am for the guidance and opportunity. Looking forward to the coming days also to be along with you all. Thank you.
Sir, Bijin sir is taken all the sessions, sir, for judging, because sometimes we are getting difficulty for each session. Sir is asking, sir is ever ready. So Bijin sir and Prem Narasimhan sir, these are the two from IAG. So really, thank you very much, sir. Personal thanks, because chairpersons and speakers are very cooperative, sir. But for this student activity, so you are very helpful, sir. Other judges also I need to mention: Dr. Narayana sir, Dr. YSN Raju sir, Dr. Venkat Rajam sir, and most of the sessions, Dr. Bijin sir or Prem Narasimhan sir. So there are 6 sessions like that. 2 e-posters and oral presentations 4. Thank you very much, sir.
Dr. Gopi is online. Dr. Gopi, Dr. Shanti. Sumati ma'am seems to be online.
Yes, sir. I'm here.
Good evening, ma'am.
Just had a break. Thank you, sir.
Nice to see you.
I had some guests, so I just went out and came inside.
Madam, we are looking for you. Yeah. Yes.
Actually, this conference materialized because of Shanti madam and her team, Dr. Usha, Dr. Tangam, and Dr. Deepa. When me and Dr. Magesh talked to her, immediately she took up the responsibility, because the conference is only the scientific program. Thank you, Shanti ma'am. Would you like to say a few words, please?
Yeah, thank you, sir. Thank you. It was a nice scientific delight. And quick notice, I think you have managed to coordinate with Dr. Chandrasekhar, the organizing secretary. Of course, it was a very short time. And he also might have had so many hitches and straight constraints. But anyhow, this to the maximum possible extent, we had all of us have done our best, I should say, to carry on with this program. And we didn't want to miss this 2021 because 2020 already, because of COVID, we couldn't make it. So this time, I think by all your efforts, sir, under your guidance, the entire team of Warangal and the organizers, including Krishna Prabhakar and others who are with Dr. Chandrasekhar, we would like to extend our thanks on behalf of IAG for making this a successful and fruitful one. Thank you, sir. Thank you so much.
Dr. Chandrasekhar and Dr. Krishna Prabhakar have got immense reserves of energy. You won't believe it. This is the second conference in tandem. After a state conference, Dr. Chandrasekhar and Dr. Krishna Prabhakar agreed to do the GERICON. I really appreciate that.
Sir, actually, this is a long pending due, sir. Actually, want to do physical. When at CMC Vellore, so you said that we will do in Warangal. I happily accepted, but because of the COVID, we couldn't
the offer is still open. You should keep the offer still open.
Yes, sir, we are ready. We are ready.
Like
but
to taste your hospitality.
it is very difficult to miss such a wonderful personalities from IAG. So no, sir, I'll leave my general medicine and I'll come to geriatric department. If any permission is there from. So probably if the geriatric department is started in KMC, So I'll take the charge. I'll request the government to do that. So then I have to definitely take guidance from all Prasad Matthew sir, Ashish Goyal sir, Rajendra, Magesh sir, Shanti madam and all. So thank you very much
And
for
I can
giving me
see
this
Dr.
opportunity.
Magesh actually smiling away because soon he'll be relieved of all the secretary's
Yes,
duties.
yes. Sorry, sir. Sometimes.
I know what it is.
Yeah, sir.
I've been
Actually,
there
for
before.
Magesh, this is an extended period. One more year we have given.
No, but really, his efficiency is superb.
Dr. Raju, Dr. Gopi has joined.
Dr. Gopi.
Would you like to say a few words, Gopi?
Gopi, sir.
Gopi?
Are you there?
I still remember Gopi did one of the conferences in CMC Vellore.
Yes, sir.
And he's a very good singer. Dr. Gopi?
Yes, sir.
Will you sing a farewell song?
No, sir.
We'd like to see you. Come on.
Yes,
So
sir.
that is the one lacking, sir, in the virtual conference. There is no singing, no foodie sort of thing. And if the Gopi sir is doing that, sir, we are ready to enjoy.
Put on your video, Gopi. People want to see you.
Yeah, just give me a couple of minutes, sir. Just give me a couple of minutes.
Dr. Chandrasekhar will at least for a banquet, he'll call us. Dr. Prashant would say a few words. Dr. Lakshmikant Goyal, you're logged in, please. Dr. Prashant actually had two presentations. Platform. Dr. Prashant?
Yes, sir. Good afternoon, sir.
Would like to see you. Switch on your video.
Yes, sir. Just a
Anyway, we all get distorted in this sort of a conference, and there's with this camera, so it does not matter. You need not look your Sunday best. Yeah.
Yes.
Just would like to tell something. You had two presentations. How did it go?
It was a nice presenting, sir. We can get we residents are rarely getting a chance for to present in such a tough time because of COVID also, and getting different places, going to different places is a restriction for us. And due to also ongoing strike, the virtual conference gave us the opportunity to present paper and posters.
And the advantage is you need a platform, a poster, a publication before you can actually receive a hall ticket. And this has been the best this thing. And one thing we'll have to thank Dr. Mathur sir immensely. We handed over the abstract just 1 week before. And sir immediately forwarded it to the printers, and it was on paper, beautifully printed. And we like to thank Dr. Mathur for this tremendous effort and his magnanimity. Dr. Mathur sir, for printing it in our journal. Thank you, sir. Anybody else? Dr. Gopi, we are waiting. I think he's getting all. The makeup man must be with him. Dr. Chandrasekhar, while waiting for Dr. Gopi, would like to announce the results.
Yeah, sir. So if you permit, shall I go ahead, sir?
Yes, please.
Sir. So now announcement for the e-poster, sir. So third, these are the presentations, sir. E-poster prize winners. First prize goes to Dr. P. Dinesh Kumar.
From
Second
MMC?
prize.
MMC.
Second prize goes to Dr. Grishma Grace Thomas.
Okay.
Please
And
tell the
third prize to
institution
Dr.
also.
Prashant Ahlawan.
Institution also, please.
I think Dr. Dinesh is from
Institution.
Yeah, the college.
Yeah.
College. So just we'll
Dinesh is
check
from
the master
MMC.
list and I'll
Dinesh
let
is
you
from
know.
MMC. He talked about elderly who had
Adrenal insufficiency.
Primary adrenal
primary
insufficiency.
adrenal insufficiency. I was the judge for that. Dr. Grishma.
Grishma is from CMC.
Yes, sir. Yes,
Yeah.
sir. And she presented a retrospective study.
Within a minute I'll tell you, sir. Magesh sir, thank you very much. We have received all the gold medals and silver medals. So here we will definitely send by connecting them to their address, and all the gold medals and silver medals Krishna Prabhakar received. So, and for all the participants, so we will give a certificates of participation for the poster as well as oral presentations also, sir. So 30 presentations have came, sir. So one we didn't included for the marks evaluation because she has already got the gold medal. So as per the jury's decision. So
actually,
next is the winners of oral presentations.
Why don't you finish off the e-poster?
So e-posters finished, no, sir?
Yeah, no,
Yeah.
they wanted the institute. Dr. Prashant is from Chandigarh.
Yeah.
He presented a case about gemcitabine induced
hemolytic uremic syndrome.
Hemolytic uremic syndrome. And then Dr. Dinesh presented primary adrenal insufficiency, and Dr. Grishma, this was actually a...
So Dinesh Kumar presented a case of primary adrenal insufficiency in elderly. So that much is we know.
So
and
to his teachers from MMC,
presented for the factors associated with insulin resistance in patients with type 2 diabetes.
So CMC Vellore gets a big applause. MMC and CMC.
Dr. Prashant Ahlawat, he presented with gemcitabine induced hemolytic uremic syndrome in lung cancer.
And there were just 2 marks difference between all of them, but all 3 presented very well.
So only participation is winning, sir, actually, because there are certain technical hiccups have come in between. So that is also one reason. So I congratulate all the students who have participated with their posters and presentations. They are very good at. So only marginal, because that scorecards I have sent it to Dr. Magesh sir and YSN sir. So it is transparently did. And I congratulate all the participants. So next, coming to oral presentations, the first prize goes to Dr. Abhijit Rao. And actually, there is no third prize, sir, because Dr. Ebenezer and Dr. Ruben, they are standing on the equal marks. Okay. So only second prize 2, Dr. Ebenezer and Dr. Ruben. Congratulations to all these
Can
winners.
you put in a third prize also?
So
Anybody
I
else?
can announce if they.
Why not? Why not?
So if that is the case, shall I announce?
What do you say? Rest of the...
Yes, sir. Yes, sir. You
I
can give
think
the
they
third
should.
prize.
Usually we can make one. Usually, I think medals will be a problem.
Okay.
And usually the judges
Give a
decide.
certificate.
2 second prizes are there. They will decide based on out of the marks some other criteria. One as second, one as third. But
No, let us not. After it's announced, let's not go back on this.
yes,
Let it be.
We can do it, sir. We can do it that. So both are standing at 81.6%, sir. So that's the reason. One more. That already thesis, this is already announced, but again, Dr. Yamini Ajmera, winner of the Research Wing IAG Best Thesis Award for 2021. Congratulations, Dr.
She's from
Yamini.
AIMS, New Delhi.
She's from AIMS, New Delhi. Sorry that I couldn't able to give their institutions where from, because that is how it is entered into the scientific schedule.
One more prize, Dr. B.K. Mathur prize for the usually goes for the best oral presentation. It carries a cash award and a certificate. So the person who got the first prize for oral presentation receives this prize.
Okay, that means well, again you present. So oral presentation first prize is
Dr. Abhijit Rao.
Dr. Abhijit Rao. Yes, sir. So, but we will send these medals and certificates, sir, by courier.
In case they're seeing, congratulations to you, or since I can see the teachers.
Yes.
Thank you.
So then, so anyone wants to speak before I conclude by vote of thanks?
Gopi, this is your chance, Gopi.
So Gopi is
Come on,
probably waiting.
your makeup is not yet over, Gopi. Okay. Yeah, there.
If you don't put on your mic, we'll make you sing, Gopi.
Yeah, please.
No, I
One
was
short
listening.
favorite song.
No, sir. No. We'll have it during the real conference next year, hopefully in Calcutta.
No. Song on virtual, this thing is also great. A small romantic favorite song.
I was listening intently to Dr. Chandrasekhar announcing the results.
Yes.
It's good. I think we had a good time preparing for all these things, and unfortunately we could not meet in person this year. But I think we've not met twice now this year and last year. But I think Dr. Chandrasekhar more than made up for it by organizing a fantastic conference, and I congratulate him and the other scientific committee chairman, Dr. Shanti, everyone, Mahesh, Dr. Prasad, to organize a very lively and excellent conference. Thank you, sir.
And we have been joined by Dr. Vijay Mohan. He's an excellent academician. And we request Dr. Vijay Mohan to say a few words.
Sir Vijay Mohan, sir, are
Thank
you
you.
joined?
Yes.
Please, sir.
Thank you, Dr. Raju and Dr. Chandrasekhar. It was a fantastic. I was glued to my chair throughout since yesterday. Really, it was a fantastic show that you all guys have put up, and very, very happy and happy. I could learn so many things from so many stalwarts, and really, I congratulate all of you for giving an opportunity. And I had to chair 2 sessions. I'm feeling very fortunate to do that. And once again, I thank you, and God bless you in near future endeavors of you. Thank you very much, Dr. Raju and Dr. Chandrasekhar, and all other participants. Dr. Krishna Prabhakar, thank you very much.
Dr. Prasad, with your permission, shall we?
Yes.
Okay, sir. Sir, thank you very much, sir, for all the support and guidance and troubleshooting given, particularly Dr. Magesh sir, Dr. Shanti madam, and Dr. Vaisen Raju. And if any mistakes are there, it is not intentional, sir, forgive me. So I am in a learning curve. Definitely, I'll do better if the chance comes again and again for IAG. Thank you very much. So, and we will end up with one national anthem virtually.
You have to stand now.
Jana Mana Adhinayak Jaya He Bharat Bhagya Vidhata Punjab Sindh Gujarat Maratha Dravida Utkala Vanga Vindhya Himachala Yamuna Ganga Uchala Jaladhi Taranga तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Jai Hind.
Jai Hind, and thank you. I think
Thank you, sir.
members of the meeting.
See you again